what we call the fibroid mapping tool that we have now on our Voluson system. So fibroid mapping is an AI tool based on 3D, where you will get a coronal plane of the uterus with a fibroid localization. How does it work? We start with the sagittal view of the uterus, then we'll trace the endometrium with the finger, and as soon as you remove your finger from the touchscreen, you have your multiplanar. And as you can see here, the system recognizes the myometrium and the endometrium, and then we will be placing the localization of the fibroids within this volume. And you will have a full visualization of the uterus in a coronal plane with the myometrium, endometrium, and the position of the fibroids. So as a communication tool with the patient is very effective, but as well for you as a surgeon, you can really visualize and prepare your intervention in a very accurate way. And finally, the pelvic floor disorders are really, we can see that there is a big trend worldwide, and we see that the statistics says that 1 in 3 women will experience pelvic floor disorders in their lifetime. This can be pelvic organ prolapse. And in order to diagnose that, ultrasound play a major role. And by coupling AI to ultrasound in order to assess the pelvic floor, we are making it very easy. How does it work? Very simple. We just place the probe. We click on 3D sonopelvic floor, and the system will be doing everything to extract a coronal plane. As you can see on the video on the right side, it will extract the coronal plane of the pelvic floor with the ligaments, with the muscles, and it will be putting all the measurement needed for the pelvic floor assessment. And it can do that automatically in the 3 phases, in rest, in Valsalva, and at contraction. So we just ask the patient to contract and to rest during the exam in lifetime, and the system will be capturing the images for you and doing all the measurement needed for the diagnosis. And it can also do the minimum hiatus distance tracking, the MHD tracking, and it can also extract for you the anal sphincter, as we know that there is also a lot of anal injuries during the delivery. And in order to assess that, you can also use this tool called sonopelvic floor, and AI will extract all this information for you automatically and doing all the measurement needed. So to summarize, AI is really bringing simplicity to your exam. It reduces the complexity of the exam. It lets you focus on the patient. You don't have to care about the keystrokes that you have, the knobology, and pressing the button or changing the parameter. AI take that. And so you will focus on what matters, which means the patient and the diagnosis. Thank you for your attention.
Thank you so much. You may take a seat. Next up, we're going to have a presentation from Kairo Medical, Rwanda. Please, let's give him a round of applause as well.
Maramutsi. Good morning, everyone. Let me first introduce myself. My name is Karim Askar. I'm the Managing Director for Kairo Medical Group. Actually, Kairo Medical Group, we represent Mindray for 10 years now. Sorry, for 15 years now. Okay. So we started in Egypt 2002 with headquarters in Cairo. And then after that, 2012, we became an authorized distributor for Mindray in Egypt. Then 2021, we have established our existence in Uganda. Then 2025, we are in Rwanda, Kigali. Since 2012, it was a long journey, actually. And since that time, Every year we are the best we have been awarded with the Best Performance Award for Africa, and sometimes new product breakthrough, service golden channel, which is the best service in the Middle East and Africa. This is Kairo Medical. We are 150 employees. We are between sales, clinical application specialists, and service engineers. So I want to highlight why we are different. Actually, we have such an impressive portfolio covering all the needs, starting from very low-end machine to the highest-end machines. And also we have the digital radiography systems. So we know the difficulties in the market, so we are offering a tailored credit options for the customers. And also we have the option, it's called the trade-in machines. The trade-in, it means that if you have an old machine, Mindray, it has still a value. We can evaluate this machine and we can give you the advanced model, and we consider your machine as an asset. It has a value. So it is a long-term relationship. Also, if you are just starting, you want to start with a good machine, you can start with an entry-level machine, and then after that you can upgrade, because it's a long-term relationship between the company and between the community. In the after-sales service, we have around 24 certified engineers from Mindray, and they are also a trainer of trainee. So they have a certificates for trainer, for biomedical engineer, and for the doctors. Some of them are already physicians. For the training and education, actually I'm seeing our vision is aligned with what the RSOG vision is, because we believe in the training. Actually, in Egypt, we have 13 ultrasound schools. These ultrasound schools, we are making it in the obstetric and gynecology department. We make a partnership with those universities to establish an ultrasound school for training. And it is a successful experience, actually. And we are doing a regular workshops every month on those ultrasound schools. And we have also something called a fetal medicine diploma. This fetal medicine diploma, it is approved by the Egyptian Medical Syndicate and approved by the MOH. We have it in 2 ultrasound schools, actually, and those pictures from the graduation from those diplomas. And also we are doing an exclusive workshops, as we believe, as I said, in the training. The conferences, we are there. Also the corporate social responsibilities, we are very willing to participate in any camps. These pictures from a camp in Uganda, we participated in. It was 50,000 patients scanned in this day. This was all for free and we provided the ultrasound machines. So finally, we are here. We are Kairo Medical Rwanda. We are in KN3 Road, Chuchichiru, Kigali. And we are willing to help with all the new solutions, helps the obstetric and the gynecology. Like, for example, this one. This is a handheld. This is an ultrasound. So this ultrasound, it is convex and linear, and you just connect it to a mobile or an iPad, and you can do the scan. You can save your information, and then after that, you can transfer to another machine or another laptop, so you can interpret. So thank you very much for giving me this opportunity to be with here, and best of luck. Thank you.
Thank you so much. I would like, would you mind staying? I want to recognize these people. Would you like to stand up? And their teams. If you're working with the team that just presented, please stand up so that we can recognize you. The team members, great. Can we please applaud these people, because they have not only been here yesterday, they have been with us and they have gone to different hospitals to present these initiatives. So thank you so much. And they have booth outside. I kept them here so that you guys can go outside to their booth and learn more, ask questions, and let's improve the healthcare, because we cannot do it ourselves. We need partners, and thank you so much for doing this. Thank you. So we are moving on for our next session. We are moving on with our next session.
Good morning. I'm going to take you through 3D ultrasound technology in obstetric and gynecology. Usually 3D in obstetric gynecology we use mostly to detect anatomical abnormalities, intrauterine device placement and location, fertility workup as well. And today I'm going to use videos, real images that we have acquired in the East African countries. And these are our customers. Some of them are in the neighboring countries. So you'll see the impact of the 3D, and I hope after this, Rwanda will acquire the first 3D endocavitary probe. So advantages of 3D is increase of accuracy in the diagnosis. 3D is also useful in education. It has education gain. It improves trainee confidence and also understanding. It also guides in surgical planning, and I can give example in uterine fibroids. Management of uterine fibroids, especially the submucosal, it depends on the type of the submucosal. Is it type 0, type 1, type 2? Management is different. And therefore, the 3D will guide in locating the exact position of these fibroids for the gynecologist to know the correct surgical procedure to undertake. Then again, it's better for patient's experience. It enhances comprehension and engagement of the patient. 3D is easier for the patient to analyze and understand. And to make it easier, we've introduced freehand 3D technology on the 2D probe, the normal 2D probe. All our machines are now able to do freehand 3D technology, and these are examples of the images, these are the examples of the images that have been done from 2D ultrasound probe. Then we have smart plane CNS, central nervous system, and here we are able to correctly identify the anatomical plane, and machine automatically measures biparietal diameter and head circumference. At the same time, we are able to see the cerebella, also measure cerebellar diameter, cisterna magna, and all the brain anatomical landmarks, and as well as labeling every part for you. But the trick about this is that you have to get a clear 2D image for the AI to recognize the parts. In addition to this, we also have intracranial volume measurement automatically done by the machine. All you need to do is to get either transcerebellar plane or transthalamic plane, click on Smart Scene CNS, and we get automatic measurement of the brain volume. In addition to this, we have advanced more. So we have SmartScene 3D, where when you're at a body part, like the spine, like fetal face, like fetal long bone, the machine, you just click the SmartScene 3D, the machine will recognize that you are on the spine or the face or fetal long bone, and it places the box at the required level. All you need to do is to update, and machine acquires it for you. Then on routine 3D gynecology application, again we have what SmartScene, automatically, all you need to do is to get the 2D image in sagittal plane or transverse plane. The machine automatically opens the box. It recognizes that plane. All you need to do is to update, then it acquires the 3D, and you get the 3D image. Okay, this is example of normal 3D. As you can see, what competes this is HSG. So HSG, unfortunately, is not able to see the myometrium, and therefore you cannot assess anatomical anomalies within the myometrium. So contrary to ultrasound, we are able to see every details about the myometrium as well as the endometrium. This is a video, kindly play it for me. Okay, now I'm on the real images that we have done in East Africa. So this is a case of septate uterus on 2D. Many times you use 2D, of course you can see that, but at times we are not very accurate, and therefore next I'm going to go to the 3D uterine images. These have also been acquired in East Africa. This is example of an aquate uterus. This patient came with history of infertility, but that is what we picked. Second example is that. Third example, this case is funny because the patient came with a history of infertility. HSG was done, and HSG report revealed uniconvate uterus. So this radiologist just decided, because she had the 3D endocavitary probe, she decided to take the patient to see how it appears. But fortunately, she got a different thing from what HSG revealed. It is a complete septate. And therefore, that means that on HSG, they must have cannulated just one of the cervices. And that is what caused it. And this can tell you that ultrasound is now a better diagnosis of uterine anomalies than even HSG. And also in HSG, we are not able to correctly differentiate between septate and biconate uterus. Do you agree? In HSG, we are not able to correctly identify the difference between septate and biconate uterus. And this is because HSG only gives us the endometrium. For biconate uterus, HSG will show us, it will be the same thing. In case it is incomplete septate, then HSG will give us similar thing with biconate uterus. But when we do ultrasound, we are able to see the septation of the myometrium as well. And this is why ultrasound is now becoming more and more superior to HSG. This is example of the same case. This is now incomplete septate uterus with a fibroid. You can see a fibroid adjacent to it, which we are less likely to see on HSG. Then this other case was a normal pregnancy. The mother just presented for routine checkup in early pregnancy. Then, of course, she was attended by an experienced radiologist, and that was the finding. As you can see, this is again a septate uterus with fetus on one of the sides of the endometrium, one of the one of the sides. The other side is empty. You can see a pseudo gestation on this side, but this is where you're getting the pregnancy. This other case is gyne, and we can see polyp clearly on the 3D, which at times becomes difficult, especially when the patient is bleeding. In 2D, we are not able to differentiate between, at times we are not able to differentiate between polyp and blood clot. This is the same case. This is case of fibroid, and this is where I say that ultrasound is now able to guide on the surgical management of fibroids. Especially the submucosal fibroids, the type 0, type 1, type 2, we are now able to see it clearly on the 3D image. And also IUCD allocation, IUCD displacement. You know, at times we just see the displacement of IUCD on 2D, but we don't know where the other wings are. And therefore, 3D, because we are able to rotate all around, we are able to see whether it has penetrated into the myometrium or it is intact within the endometrium. Then again, on fertility workup, we have HICO-C, which is similar to HSG, but now we are using ultrasound and injecting contrast, and we are able to follow the contrast flowing into the fallopian tubes. We have, again, on infertility workup, we have smart follicle, and we have two types. We have 2D smart follicle and 3D smart follicle. What is the difference? 2D smart follicle, we are able to count, mostly we use it on follicular count. When you want to count the follicle, you can do this when you're doing follicular harvest. But the 3D follicular count is mostly used on infertility where there is polycystic ovaries. And you know, here you are able to count follicles, even the ones that you are not seeing on the surface. 3D smart follicle is able to do all this. And this is just example of what was done. This was done in Tanzania, and you can see the follicles and you can turn all around. Then again, in addition to that, we have what we call SMART ERA, endometrial receptivity assessment, where ultrasound is automatically able to pick blood flow into the endometrium, and we are able to tell fertility level of this patient. In addition to that, there are adnexal masses, and we are able to correctly see the type of masses that you're having. Other gyne solutions, we have elastography, both shear wave and strain elastography in gyne, and as well as contrast imaging in gynecology. And for the contrast imaging, we are also able to detect cervical cancer at a very early stage before clinical stage. Yeah, so in conclusion, 3D has become very useful in congenital uterine anomalies, complex early pregnancies, fertility assessment, coil allocation, and it also teaches us how to interpret 2D differently. And 3D is easy to acquire. Why? Because the machine is doing this automatically, and all you need to do is just to capture. Thank you.
Thank you very much. Can we appreciate her? And again, thank you so much for your support. She's going to be outside. Their station is over there. Go see them, talk to them, and learn more. Now we're going to take another gear for some of our today's session, and I'd like to call upon our panelists. The next panel is going to be on preventing maternal deaths, challenges, lessons, and a call to action. So I want to ask you guys to have your A game on, because now it's going to be, the Americans would say, this is where the money is, because this is where we need to be very, very, very attentive and be ready for this next session. So I'm going to omit the very many achievements that the panelists have done, just to call up their name and their titles for the sake of time. The first one to call on the stage is going to be Prof. Rulisa Stephen, with so many achievements. I don't know where to start, but mentoring so many of us in this room. You're welcome to the stage. Please A round of applause for Prof. as he's coming. A senior, one of probably the most senior midwives in this country, Sister Murekezi Josephine. I would like to call her on the stage. Please. What happened? Can we please show some love? Great, thank you, that's better. From the Ministry of Health, let's call Dr. Jean-Baptiste Nihumbia. Can we show some love to the Minister of Health? And then, last but not least, Dr. Derek Paul Pima, who is one of our faculty at Nyamata District Hospital, or Nyamata Level 2 Teaching Hospital. Thank you so much. And our esteemed moderator, Dr. Charles Nkurunziza. A little bit more. More. Thank you.
Thank you, Dr. Magnifique, for the kind introduction. Good morning, distinguished guests, dear colleagues and friends. So we are kicking off our day with a very interesting and critical session where we'll be talking about preventing maternal deaths, discussing challenges and lessons, but also a time for a call for action. So, allow me to start by saying that when we talk about maternal deaths, it's not just numbers. Because maternal deaths, when you have a maternal death, it's a tragedy. So you have children who are orphaned, we have a husband who is now widowed, and we have a country who is losing a citizen. So we have a panel of experts who have gone a long way dealing with challenges in preventing maternal deaths. So they will help us, give us the insights about that, and help us having a step forward to preventing fatal maternal deaths to ensure that no woman lose her life while giving birth. So please allow me to start by asking our panelists the question, then later on we will also open the floor for you for your contributions. Allow me to start with Professor Ruiz. So I would like to ask you, so during your long years of experience, we would like to ask you any intervention that has worked either in our settings in preventing maternal deaths, and the lesson we can learn from those interventions that we can apply for preventing further maternal deaths, especially those preventable ones.
Thank you. Thank you very much for that. There are several innovations, of course. And what I can say in my experience is that we know what kills women. We exactly know the causes of maternal mortality, and we know how to prevent it, and we know how to treat it. The strange thing is that why does it still happen? Because we know the causes. For example, if you remove postpartum hemorrhage, you remove over 70% of maternal mortality. And we know exactly what causes maternal mortality, what causes PPH. We can prevent it, we can treat it. Medications are available. They are the cheapest, actually. The question is, why do we still have maternal mortality in developing countries? What I found in my experience is that there are new innovations now, for example, emotive bundle, for example, multiple micronutrients, we can use them. In my experience, one of the biggest innovations that I found that works more than any other is leadership. When we did our maternal audit in this country, we found that when we analyzed the data and we told the people, we saw maternal mortality reducing when the director of a hospital changed. As simple as that, no new medication. A director changes, things changes. Same medication, same everything. Leadership makes a huge difference. Otherwise, the innovations, they are there. The question is, why don't we use them? Maybe we'll come to this later, but if you ask me what is one thing to apply, we've seen governments, why do one country reduce maternal mortality and others don't? Leadership. So if you ask me one thing, of course we can list several interventions, but in my opinion, leadership makes a much, much bigger difference because he's applying what we know it. The question is, why don't we apply them? Maybe I can stop here for now. Thank you.
Yeah, thank you so much. Yeah, of course, it's like you answered to one of the questions I also would like to ask, but we'll also come to that after. The intervention that you think, if you were to advise to the donors or maybe the government, what would be that intervention, but we'll come later on that. I will move on to our sister, Josephine, who is a senior midwife and has been working with the communities and been with women. So my question to you is that hospitals alone, healthcare providers alone, they cannot be able to control maternal deaths if we don't involve the communities, the local leaders, the traditional healers, because they are also in the community, they are with those women. So I would like to ask you, how do you think we can better involve the husbands, the community, and even the women themselves in making sure that pregnant women go through safer pathways during pregnancy and childbirth, and even postpartum?
Thank you. Safe motherhood is not the responsibility of healthcare providers only. It begins with a strong support system in the families and in the community. And here we have to involve the husband or partners, simply because they should be aware. It is a matter of sensitizing them. It is a matter of involving them. And it is a matter of making them aware that it is also their responsibility and they have to be real partners for the cause. So we would encourage the male partners to support and also attend antenatal visits where they will receive health education, where they will know the role they should play. They should be aware of the danger signs. They should be aware of when to seek health care, and they should really be real partners where they have also to plan, especially when it comes to financial support. So in that way, several strategies should be put in place, and we should be empowering the families, especially the mothers-in-law, because they are nearby the pregnant woman. They will support, they will be educated, they will be encouraged, and they will be also aware of the danger signs when to seek health care. They should also, the community health workers should also be involved, because at least they know when to seek health care, where to advise this woman, and equip I would equip the healthcare providers, and they should be aware of when to seek and when to call the ambulance to come and take the pregnant woman to health facility. I would also involve the community, the wide community, so that they should be having campaigns around in their health sector. They should know when to take the woman to the hospital. They should also be aware of the danger signs, and they should be encouraged to be accountable for that safe motherhood. They should be in an environment where they can contain this case. We should also involve traditional leaders, especially the religious cultural leaders, as champions for the safe motherhood, especially when they have some gatherings, the religious gatherings. They can talk about safe motherhood. They can also involve them as champions to safe motherhood with cultural context. They are influencers in the village, and they are well equipped for that. We're also empowering women themselves is very important, because when they attend antenatal clinics, they will be given health education. They will be knowing the danger signs of a pregnant woman. They will gain more evidences from the rest of the women, because they will have some health talks, and they will be involved in sharing knowledge and experiences that they have. And maybe I stop there. Thank you.
Thank you so much. One of the key messages I got from your answer is that we should be partnering with the community. That's if I got you well. So, then moving forward, I will move to Dr. Jean-Baptiste. So, from the previous speaker, we emphasized on the leadership. We also emphasized on the partnering with the communities. But then we still have a long way to go in preventing maternal deaths. So, I want to ask you if, in your view, if there are any systemic barriers that you think need urgent intervention if we have to save maternal women's lives. For instance, regarding maybe training of practitioners, maybe lack of financing, or maybe if there are poor referral system. They might be in our settings or elsewhere. So you are welcome for your contribution.
So thank you so much, moderator. So I'm happy that you asked me the question from the Professor Risa progressively. This is, I will respond from there. A strong leadership from the lower level, it's a key. So as he mentioned about the commitment of leadership at the lower level, he mentioned about the involvement of Director General and the key committee in the hospital. That is the first key, the involvement of leadership. And the event contribute around like 90% in the reduction of mortality. But as we used to do like an audit from previously, we now having another issue, the issue of communication. So yesterday, the chairperson of RIMDC has mentioned about soft skills and communication. The other case we evaluated retrospectively on the case of maternal death that occur in Rwanda, around 252. So as absolute number. So we realized that most of the time it's all correlated with the leadership, communication, and how we use our audit findings in action. Sometimes we see the delay in referral. So as we mentioned, WHO has put 3 delays to evaluate ourselves in our maternal mortality audit. So one of it is delay in seeking care from the home, from the pregnant woman. So in our context, we have been realized that the culture, so the culture is an issue, the culture brief, and also the loss of power for the women to decide on their decisions and the lack of finance. So this is the one we highlight as the big challenge in the delay one. In addition to delay 2, the government has put more effort in purchasing the ambulances. But when you see how the coordination of that and the availability of those ambulance teams to act as urgent as possible, it's the challenging action that, as the prof has mentioned about the leadership, then this coordination, when we put it together, it can be reducing the delays. So we have another delay, the third delay. The third delay is come on the delay in giving the quality of care, which occupy like 70% of the delays that comes in the maternal mortality. So all of that, it comes on how our workforce will arrange it. So when you even check deeper in it, it's not only related to shortage of staff, but how the leadership, the head of department, and how the director of nursing of clinics are arranging the timetables. So all of them that are contributing on the poor outcome related to that. So I can summarize that: the leadership, communications, the soft skills, but also use of the findings in the audit in action by doing the quality improvement plan, but fraud with the monitoring. Thank you.
Thank you so much. I like the idea of looking at the 3 delays, but also leadership keeps coming. So thank you so much. Moving forward, I'll move to Dr. Paul. So many years, intervention have been carried on, but we are still having women dying. So my question to you is, why do you think those challenges remain? Why do the challenges remain non-resolved despite many years of intervention and the many stakeholders involved?
Thank you very much, Dr. To give a context in which we are dealing with, the government of Rwanda came up with a Rwanda National Maternal, Child and Newborn Health Strategic Plan of 2018 to 2024 to reduce the maternal mortality rate to 126 deaths per 100,000. So you may ask, what is it now? Have we been able to achieve this target that was set? Because currently we are in 2025. And when you look at the latest information we have, is that our MMR is at 229 deaths. So we have not yet hit the target that was set out by the policymakers, and one will ask, why is that? It is not all gloom and doom, because when you compare yourselves, you have to compare yourselves to the global village. You have to look at what the rates are with surrounding countries. I don't want to misquote them, so let me quickly just give the figures. In the DRC, as of 2022, the MMR was 547. In Uganda, the latest records is 189, Kenya 594, Tanzania, which is doing the best, is at 104, Burundi is at 447, and Ethiopia is at 195. So you can see that where we are in Rwanda at 229, although we have not yet managed to hit the target, we have significantly reduced it from where it was, say, from 2022, which was at 234, and it is gradually coming down. So despite the interventions, why do we still have the challenges that mothers are still dying? The first challenge I would point to is we still have quality of care gaps amongst our respective cadres. Why? It's because most of the interventions that are supposed to be done to curb the deaths are known. The protocols are available, the guidelines are available, but they are not being practiced as there should be in the different facilities. So the gaps in the quality of care are one of the challenges that are being faced. Then too, we have health system gaps or bottlenecks. For example, shortage of staffs in the shortage of specialists in referral and the rural peripheral hospitals. The ministry and the government has really taken steps to curb this, to ensure that more numbers of specialists are trained, which is currently being undertaken by the 4x4 program. So when you lack these specialized workers, the midwives, the anesthetists, the obstetricians in the peripheral and rural hospitals, you are going to have an increase in adverse outcomes when mothers come to these facilities. So that is another challenge that we are still facing. The other one is still with resource constraints, stockouts, and sustainability of the same. For those who, I'm lucky to work in a not so resourceful center like Nyamata. It's not urban, it's not really in the rural. So you still come up with challenges of getting frequent stockouts of essential drugs, equipment that would have otherwise helped you save or intervene in case of a challenge, let's say like PPH, or a mother is convulsing. Then we still have issues of equity, where women in the rural areas, unfortunately, still have and depend a lot on their partners to get consent to undertake certain decisions compared to their urban neighbors. So this causes a delay, which was alluded to by my colleague. In the delay one, the delay to seek. Then we have other social determinants of health. For example, poverty. Poverty is still rampant, and malnutrition in the rural areas. All these affect the timely seeking of care, and they can contribute to the persistence in the maternal deaths. I should also make mention of adolescents, as we still have a challenge with having teenage and adolescent mothers. And we all know that when someone gets pregnant at a very early age, those pregnancies most of the time are associated with many complications and risk factors. So all these contribute to really the backlog and the magnitude of the problem. And finally, I've talked about the equity, yes, and the health system bottlenecks, the shortage of specialists all over in the different areas of the country. This can really be mitigated by increasing the deployment, encouraging most of us in this room who are attending the conference to be open to practice in areas that are really not urban. And with these simple interventions, I think we should be able to overcome the challenges of maternal death in our country. Thank you very much.
Thank you so much, Dr. Paul. So you listed a lot of challenges of different aspects, and so it shows that we still have a lot to work on and a lot to improve. So moving forward, I have a question to all of you. So you may voluntarily respond to or not, but I want to ask you if you were given the chance to advise the government, advise the donors, so advise the stakeholders in this struggle of preventing maternal death. What would be that one immediate action that you would advise, thinking it would make an immediate impact on preventing further maternal deaths?
Maybe let me take it first. One thing I want to correct here is that the official maternal mortality rate for Rwanda is 105, as per HSSP 5 and several government documents. So Rwanda now stands at 105. I think many people keep referring to all the document that the new data as per all government document is 105. One of the recommendations I can give as per your questions is that government or donors should use data to make decisions. I'll give you an example. In our MPDSL we just analyzed the data and we wanted to know who dies, what type of women who die, what kills them, when do they die, and what is the problem. We got striking findings that over 60% of women die on night shift. This information stays in this room, of course. Yeah? And then we found another more than 20% die during lunch hours. We were just playing with data we got from health facilities, playing with them on data. And when we present this data to the ministry and to directors of hospitals, all eyes were opened. And guess what? No new medications were improved. Just, this is where you come about leadership. When you use data, it speaks much more than anything else. There was no new innovations that came up. When we show this data to a director of a hospital or head of maternity department, and he just works on shifts, on handover, tremendous results happened. Maternal mortality reduction were visible in health facilities. Simply because people are aware that the way shifts are managed. I didn't talk about delays within the hospital, how many hours. I mean, if you look at when did the ambulance arrive here in your compound and how many hours passed before the first doctor saw the patient from an ambulance and what happened, it was tremendous. And when you fix all these things, which doesn't require any specialized expertise, a lot of lives were saved. And why? Because you just talk with data. There's no new innovation. You just tell them, here is the data, here is who dies, here is where they die and why they die. And everyone say, yeah, I can fix this. And a lot of things were fixed. When we showed this data, and then we said, when every woman dies, we ask the Honorable Minister, can you organize to call these people? When a DG hears, he will go to respond to a minister why a woman died, things changed. Simply because of that, everyone was accountable. And so my response to your question is that use evidence-based data and improve accountability and leadership. Things can change.
Thank you so much, Prof. So data is so important. Maybe I will only allow one of the panelists to, if anyone is volunteering, to give a comment on that.
So thank you so much. I will comment a bit on that. So in addition to what Prof highlights in the audit, so a strong leadership change everything. And because if a leader uses the data in action, everything changes. Because you can know where there is a challenge, because you do the follow-up. The data we mentioned about the time of death for the pregnant woman is true. Weekends, night shift, and the time of in the morning, in terms of handover, when the people are shifting, go home, that is the time that may be occupy more than 90% of the death we have. So for daytime, from 9 to 12, there is no more issue. But from 12 to 2 hours in the day, there is a problem. It shows that when we fix those small things, that does not even require the high amount of money. Everything might be fixed. In addition to that, I strongly say about the communication, because there is what we call a downstream culture blame. So when someone called the health center, called the district hospital for nurse for a particular case, you can say you can manage it for there is no problem. When there is an issue, call us. So when this blame game, or someone is calling from the district to the upper level, and there is those challenges, say, this case you can manage there, while the one in the district hospital has the capacity to manage the case. So once you can even bring the case, and you realize that by the pre-transfer management, the case is stable a bit, you say, why those hospitals is bothering that? So even the time of giving feedback cannot be there. So by this communications between the two professionals, the referring the case, so can be improvement things, because when we highlight on the audit, the things we see while we are auditing, it shows that we don't need much things to invent. Only the few things to highlight: communications, the strong commitment of the leadership, and also the audit culture. And for that, we set what we call the quality improvement project to highlight what we highlight within the audit is achievable. So in addition, the government have been setting different commitment, like availing the 4x4 reform by increasing of care providers, the equipment, and even modernizing the infrastructure. All of that, we can have it. But if we cannot change this culture, everything we can set cannot work. So that is the comment I can highlight. Right, thank you.
Thank you so much. I understand that other panelists also had something to say, but for the interest of time, I wanted also to have one contribution from the audience, either a question or a comment. I guess there is no. So I think there is no one from the audience. Oh, sorry, yes? And please, we want you to go straight to the point.
Yes, good morning.
Morning.
This is a very important topic, and I thank the panelists for explaining. I think we've been talking a lot about maternal mortality, and we have the target where we should go. And it seems that all the reports give us the same cause of death, the same conclusions, but sometimes we ask ourselves why we don't go faster. But according to the new data, I think there's some improvement, but we still have to do more. I always think that it's important to have a very good staffing. And that's why I was to ask Sister Josephine, because we know that midwives, they play a very important role in managing these women who are in labor or who are delivering. So there's something we call standards, like a ratio between midwife and these patients. Do you think at the moment in Rwanda we have achieved a very good number of midwives who can support that? Because you can have equipment, you can have whatever you want, but if you don't have good number of staff in terms of numbers and quality and knowledge, then it might be a problem always. I agree also about the leadership involvement, but I still think that we still lack a good number of midwives to look after these women. So any information or any update on that, Mr. Josephine, thank you. Or whoever who can help.
Thank you. I think it is a long-standing problem. Of course, we have been having shortage of midwives, but for the government program, we have been given the first priority, and we are now training more midwives. Hopefully, the problem will be solved, but we still have a long way to go. As they said of the delays and so forth, and as Prof mentioned that death occur at night, that means there is some negligence somewhere. Of recent, we conducted baseline assessment, and we realized that there is where they have high rate of infection. And when we went deep in investigating, we realized that they had everything that are not sterile. So I imagine if the leaders could help us and people go around checking, some people are using unsterile equipment when they have them. Some people are not attending to mothers when they are there. So it should be a combined effort from each and every healthcare provider so that we try to minimize some of the deaths that occur due to negligence. And I'm sure you have seen this when we conduct, when we have the incidents at the Nursing Council, Medical Council, where like 90% of the cases are preventable. So I imagine that if we could really raise up our voices and point out where the gaps are, we can try to reduce the mortality rate. Thank you.
Thank you. I will only allow, there was one intervention from the audience. Okay.
Thank you. Thank you so much for this good discussion. I want first to thank the panelists for good objection they have given to us. But still concerned, my concern will be addressed to the representative of the Ministry of Health and probably to professors and the other initiators of this fight against maternal death in our country. Obviously, Professor Rudisa was on the front line, and the other seniors here. As a volunteer, sometimes I walk around the country, and I see, as Prof. Ngoga said, I will not be far away from his objection. A shortage of staff is one of the many problems, even if we can see the government has set a good plan to increase the number. But as a Minister of Health, you policymakers, you in charge of monitoring and evaluation, do you sometimes sit and see also the root cause of, even if you get a good number, of putting our staff in the comfort position for them to implement well and to fight very well against this enemy which can take away our mothers. I know some of them have said it like giving them means of transport to get a good mean of transport, but still they are scared of, because how to say, exoneration is not enough for them. That was an example of transport, but there are others. Do you sometimes sit and think of them, for them not to be here and there? Because as Prof said, some of the cases happened during the night. But when you see, it's because some of the staff, they are tired. They have been here and there. So do you sometimes think about putting them in a comfortable position in terms of life or living conditions? That's number one. Number two, maybe my seniors will look at it that initiated this. And I will address it to my fellow colleagues. Rwandans doctors need to also give back to the community. When you see policymakers in the ministries and the other Ministry of Health institutions, we have quite a good number of people working there. And yes, they are doing a good job, but still their absence in clinical practice is sometimes remarkable. Is it a way that we can encourage people to give back to the community by volunteering at least once a month or once 2 months? Because I was sitting thinking that if I'm a clinician, as a policymaker in a government institution, and I give 1 day, in 2 months or in 1 month, I go and I see 10 people, when you calculate in a year, you will be seeing like around 400 people or even 500, depending on where you went. So would you encourage our clinician, mostly involved in the policy making or researches and the other things, to try and also be involved in the clinical practice in some of our district and the health centers to cover that gap that may be one of the cause of maternal death? Thank you.
Thank you so much. Maybe Dr. Jean-Baptiste will start.
Okay, thank you so much for a good question. First, when we check on those delays and involving the health professionals to contribute, like during the time of weekends or whatever, showing the strong shortage of staff. That's one, the interparenthesis. But we cannot forget that some of retention strategy to keep them more focused on that. As you remember, one of the reform have been approved is this detention strategy to help the healthcare providers to feel comfortable in managing the cases where they are. So there are different things. One, there is the retention strategy related to where they are working for, the environment where they are working for. This comes in what we have been highlighted about the leadership, where the healthcare providers working. So we don't say like the salary or performance-based finance is the only things to retain someone, but also the good working condition for the staff is a key. So you can get a huge amount of money, but when you are not in a good environment to work, it can affect you, either mentally or physically. So for that, we can say that we can advocate or working on different modality of putting the good mode of the healthcare professionals at the central level, but also taking into consideration to where they are working for. The leadership in the lower level, they can also emphasize on how we can take care of the healthcare providers in different things in retention modality. But on the higher level, we are now working on different aspects on how to retain or to improve the people working in the institution. But those combined together will help in improving the healthcare providers where they're working for. The second question that you mentioned on the healthcare providers that work in different institutions to volunteer for the health center or district hospital on a busy schedule. This can be acceptable because healthcare providers who have a license is allowed to practice. So we'll be happy to see those who have been volunteering to come, and we deploy them where they feel like they can work for, around where they're working for. So if we count the number of healthcare providers that work in the NGOs, even ourselves in different institutions, when we contribute like 4 or 5 in the health center, 1 or 2 days nearby health centers, we can contribute much, and then relieving pressure. This is a good discussion that we can highlight, and it's a good things that we can explore more. And what I can see, if, for example, you are ready to volunteer yourself, as you have the license to practices, you are allowed to practices. Thank you so much.
So thank you so much. I think for the second question of encouraging providers in different institutions to contribute, we can keep discussing among ourselves, because I think everyone has a say on that. So, because time is not on our side, I would like to thank our panelists. But from this session, I got a take-home message that leadership is the key on all the journey, and that use of data, we need to use data if we need to move forward and be effective. And of course, work on our communication. So this is the take-home message from this session. Please join me in thanking our panelists as they join back their seats. Thank you so much.
Thank you so much. Let's give him another round of applause. That's a very hard topic to discuss. I'm sure we could have gone on all day talking about maternal deaths. But I'd like us to go on to the next oral abstract presenter, which is Dr. Ayaya Miskan. He's from Gisenyi District Hospital, and he's one of our faculty members in Ethiopia. He'll be presenting on the non-disassociated clear cell carcinoma of the cervix in adolescent presenting with dysfunctional uterine bleeding, a rare case report and clinical insights. Let's give him a round of applause.
Good morning to you all. Thank you for the opportunity to present this very rare case. So my presentation will be on non-DS associated clear cell carcinoma of the cervix in an adolescent presenting with dysfunctional uterine bleeding, and will be discussing the case report and some clinical insights on it. So this will be our background. So clear cell carcinoma of the cervix is an unusual type of cervical cancer. As you know, 99.9% of cervical cancer is associated with human papillomavirus. So this is an unusual type of cervical carcinoma. It's not easily suspected in young women due to infrequent occurrence in the age group. And delayed diagnosis and management can also impact the management. So the objectives of this case will be identifying the risk factors for clear cell carcinoma of the cervix. Will be also describe the clinical picture, investigations used in the diagnosis of clear cell carcinoma of the cervix, and we'll also review the current treatment options available, including fertility preservation options, because majority of these carcinomas occur in young age, in adolescents like 19, 20 years old. So fertility preservation is a concern when we address the management of this case. So we'll present the case summary. So this is a 17-year-old. She's nearly gravid, and she had her first menses at age of 12, and coitarche at age of 16, presented with blood mixed whitish vaginal discharge of 4 months duration, and it was capacious and foul smelling for 1 month, and she had also delicate lower abdominal pain of 6 months duration. And for this complaint, she visited the nearby health facilities, and she was managed with a suspected DUB, dysfunctional uterine bleeding, and she was managed with microgynon for 3 months. And she lives with her family. She has no family history of cancer, and there is no history of DS exposure. And her vital signs were stable. She had pelvic conjunctiva with normal breast development, and with unremarkable cardiovascular and chest examination. And on the abdomen, there was a tenderness over the left lower quadrant on deep palpation, with poorly defined 16 weeks gravid equivalent lower abdominal mass, and no sign of fluid coagulation, and there was no lymphadenopathy. On genitourinary system examination, she had foul smelling, she had foul smelling, brownish vaginal discharge, fragile polypoid cervical mass involving the upper vagina. The Cul-de sac is obliterated, and the mass has extended to the pelvis with 14 weeks size left adnexal mass. And on rectal exam, there was palpable, hard, regular mass. The upper edge was not reachable and freely mobile rectal mucosa. So the labs show a hemoglobin of 7.8, and the HCG was negative for pregnancy, and the creatinine was 0.7. Liver functions were normal, and she was negative for HIV. On imaging, on ultrasound, we got a malignant-looking cervical mass with uterine extension and regional lymphadenopathy and possible invasion of the urinary bladder. On CAT scan, there was 7.8 by 4.6 centimeter mass, and 13.3 by 8 by 7.7 measuring uterus, 8.5 by 7.3 by 8 centimeter measuring heterogeneous cervical mass, and also a large lymphadenopathy. Conclusion was heterogeneous enhancing cervical mass with signs of invasion of the bladder and rectum, with multiple lymphadenopathies secondary to advanced cervical carcinoma. And we took biopsy, and also we did examination under anesthesia on histopathology with hematoxylin and eotin stain. There was nesting with trabecular, pseudopapillary, highly pleomorphic round 2 polygonal cells with xenophilic to clear cytoplasm. This goes with the histological diagnosis of, this goes with the histological diagnosis of clear cell carcinoma, as you can see on the magnification image. So with the diagnosis of clear cell carcinoma, which is advanced and young and nearly gravid, so we discussed this case with a multidisciplinary tumor board. And we did also central pathology review. We sent the pathology to Germany for further analysis because of the rarity of the case. And we discussed on the possibility of management, and we entertained palliative chemotherapy, and we considered the ovarian protocol. We use carboplatin, paclitaxel, and also to consider VEG inhibitors, but that is too costly, so we continue with the paclitaxel protocol and as a palliative management. Meanwhile, the patient developed left proximal DVT. She was admitted and managed for the deep venous thrombosis. Palliative chemotherapy reinitiated after treatment, and she has been under surveillance. So epidemiologically, in the post-DS era, which is like 70, 80 years back, the prevalence of clear cell carcinoma ranges between 4 to 9% of the case of adenocarcinoma of the cervix. So this prevalence study is based on these case reports which are published. So DS exposure, in the DS exposed woman, the prevalence is bimodal. So the age group includes 17 to 37, which is a younger age group, and their mean age is at 26, and the second mode is between the age of 44 to 88, with a mean age of 71. And in the non-DS, I'm sorry for in the non-DS exposed group, the mean age of occurrence is 50 years. Etiologically, the etiology of clear cell carcinoma is not clear. And it is speculated to be DS in the DS era. And there is limited data on the role of HPV, especially HPV 31 and 53. And suspected etiologic factors also include cervical adenosis, endometriosis, oral contraceptive pills, and HIV infection are also suspected as a possible cause of clear cell adenocarcinoma of the cervix. Historically, these patients often present with abnormal bleeding per vagina. There will also be ulceration, postcoital bleeding, intermenstrual bleeding, and usually refractory to hormonal therapy. And when you see our case, she was being managed with microgynon for 4 months as dysfunctional uterine bleeding. Then later, when the disease advanced, she got referred to a referral center where she was diagnosed with a clear cell carcinoma. Sorry. On physical examination, often the patients will experience fullness of the cervix or the vagina. The tumor is often not palpable during the rectal examination. And sometimes it may accompany with genitourinary malformations like double uteri vagina with unilateral renal agenesis or atretic hemi-cervix with ipsilateral renal agenesis or bicornate uterus. So whenever we have a clear cell carcinoma, one of the differentials that we have to think is Mullerian anomaly. For our case, that was not, that was normal. She has a normal anatomic development. On macroscopic findings, the tumor is often located in the endocervical canal and can have either an exophytic or endophytic appearance. And microscopically, we can have 3 growth patterns like tubulocystic, papillary, or solid growth pattern. And to help in the diagnosis, immunohistochemistry can also aid. So in the immunohistochemistry, you can have the napsin A and the PRR and P16 stains. Often they are negative, and normal P53 expression in most cases of this clear cell carcinoma of the cervix. On imaging, we can use magnetic resonance imaging, the PET scan, and also we can use cytology for to make the final diagnosis. often the imaging is important to plan the possible management of the case. Similar to that of cervical cancer, the management is often for early cases radical hysterectomy plus pelvic lymphadenectomy. And for certain cases, especially if you have the young nulliparous woman with early stage like stage 1B, 1A, we can entertain fertility preservation, in which case we can do radical trachelectomy with ovarian preservation, which can be followed by concurrent chemotherapy plus VEG inhibitors. There are also trials of immunotherapy for this group of patients. And external beam radiotherapy is also standard of care for the advanced stage disease. The management is the same as the HPV-associated cervical carcinoma. In a recent study, the oncological outcomes revealed that fertility-sparing radical trachelectomy is possible for certain cases, especially for those who are stage 1A, 1B1, and 1B2 cases. We can do fertility-preserving radical trachelectomy plus pelvic lymphadenectomy, followed by concurrent chemotherapy because of the issue of the ovaries. Radical hysterectomy for stage 1B, cervical carcinoma in young adult woman is also a consideration, but obviously the problem is the fertility. And there is no statistical significant survival difference between the fertility preserving surgery options. So if we go for fertility preservation for young women, and if we go for the definitive therapy, the 5-year survival rate and the prognosis is the same. So this is a literature review which especially focus on the early stage disease of clear cell carcinoma of the cervix. And from this literature, we can see that fertility preservation is an option, but still there is also a high chance of recurrence, and follow-up should be meticulous. Will not be leaving these patients for following like for 3 to 5 years, like in case of HPV-dependent cervical carcinoma. They may need longer follow-up, like 5 to 10 years of follow-up. And in the longer follow-up, recurrence has been identified, like chest, lung metastasis, even while we do the fertility preserving option. So these are the negative prognostic markers: tumor size larger than 4 centimeters, presence of positive lymph node metastasis, carcinoma in advanced stage, nuclear atypia, high mitotic activity, and solid or mixed growth pattern on histology can show a negative prognosis. Late presentation leads to advanced disease, increasing the risk for metastasis and limiting the therapeutic option, which negatively impact prognosis, treatment efficacy, and survival outcomes. So in conclusion, this clear cell adenocarcinoma of the cervix in an adolescent continues to occur even with no exposure to DAS. The presenting symptom is often misdiagnosed with dysfunctional uterine bleeding, especially in young adolescent girls. So these findings underscore the diagnostic complexity. It is disconnected, I think. Actually, that brings the presentation to the end, and thank you for your attention.
Thank you. Thank you very much. May you have a seat for at the podium. Thank you. We're going to get 2 more presentations, then we'll take the questions after. The next presenter is going to be presenting on prevalence of human papillomavirus among HIV-positive women attending Guamagana Level 2 Teaching Hospital. Dr. Batibuka Jean-Paul, you've got 10 minutes. And because I've seen that there's a little bit of hiccups over the remote we're using, when you go to the next slide, just say next slide, and the people at the back are going to help you roll the slides. And next, after him, will be bridging the gap, Rwanda's HPV control model as a blueprint for global cervical cancer elimination before 2030, and will be Dr. Mark Hagenimana. So 20 minutes, thank you, go on.
Thank you so much. Good morning, everyone. Point of correction, I'm not a doctor, I'm a biomedical laboratory scientist. Yeah. So I'm going to talk about the prevalence of human papillomavirus among HIV positive women attending Rwanda Level 2 Teaching Hospital. So the objective of this research is to determine the prevalence of HPV infection in HIV positive women receiving care at Rwanda Level 2 Teaching Hospital as the key research question. It is to know the prevalence of different HPV genotype among HIV positive women. Also to link the relationship between the HPV infection and viral load for those women attending Rwamagana Level 2 Teaching Hospital. So this study will enhance the knowledge and awareness of HPV and its prevalence among HIV positive women and contribute to research and professional development, and will also assist to community to identify the HPV subtype and understanding the importance of vaccination and regular screening. So the methodology used, the sample size was 220 participants, which was selected randomly, and the association between HPV positive and factors like age, HPV subtype, and viral load was examined, and chi-square test was used to assess the relationship between variables. As findings, so among those participants, 70.4% were negative and 29.5% were positive, and the prevalence was 29.5%, and the most prevalent was the group age greater than 65, as 30.6%, followed by 30 to 6 years, 10.9%, and the lowest was 4.1, and HPV subtype 16 was the most predominant, and there were no association between having a high viral load and being positive on HPV. So we recommend strengthening for regular screening and vaccination. Also, we see that the HPV in order has high prevalence in older women, And also there is no association between having high viral load and being positive on HPV. Thank you so much.
Dr. Mark. So, if you're not a doctor, I'm sorry, but you appear as a doctor on my... Ten minutes, thank you.
Good morning. While they're putting the presentation, I can present myself. My name is Mark Agenimana. I'm working in Rwanda Biomedical Center, which is an implementing agency of the Ministry of Health of Rwanda. I'm working in the Non-Communicable Disease Division, Cancer Diseases Unit. Mostly, most of our job is to include like cervical cancer elimination. So my presentation will be about the presentation of Rwanda progress towards cervical cancer elimination. I'm gonna present a current achievement of our country and the plans that we have towards achieving WHO global strategy of cervical cancer elimination. Maybe can you put the presentation? Okay. My topic is bridging the gap, Rwanda HPV control model as a blueprint for global cervical cancer elimination before 2030. Next. Cervical cancer, as you all know, it's a leading cause of cancer morbidity and mortality in low and middle income countries, including Rwanda. Rwanda recorded the number of new cases, 866 and 690 deaths in 2022. If you look at different strategy of global cervical cancer elimination, we have achieved the high HPV immunization, which has been introduced in 2011. A cervical cancer screening has been introduced in Rwanda in 2014 using VIA-based screening, and HPV has been introduced in 2020. This presentation we are going to present Rwanda progress towards achieving the WHO 90-70-90 cervical cancer elimination targets. Next. As we know, there is three, we will achieve cervical cancer elimination if you have the incidence of cervical cancer less than 4 by 100,000. Actually, we have 3 pillars to achieve those elimination. The first one is to ensure that 90% of girls before 50 age are immunized. Second pillar is to ensure that 70% of eligible women have been screened and 90% of women have received treatment. Actually, you can see that countrywide we have achieved the first pillar, where Rwandans more than 90 girls have been vaccinated. But when you look at screening, we currently have 38 coverage with HPV and VIA, with HPV accounting only 28%. And regarding 90% of screened, you have like the percentage of more than 80% of those women. This approach, the approach that have been used to achieve where we are now, we have implemented a first model. The first model is the program that helping us to achieve dose pillar. 3 years before WHO target. WHO target is calling countries to achieve those elimination by 2030. And in Rwanda, we have launched what we call Mission 2027, where we are aiming to achieve those pillar by 2027. So this first model, it means fast testing, affordable cost, systematic tracking, and timely treatment. So the data source of those information, we are using like OpenMRS and Muzima and DHS2. I'm going to present the period of from 2020 up to 2025. The population that you're going to talk is about all women screened nationally. And you have done analysis using descriptive statistics on coverage, positivity, follow-up, and treatment outcomes. How the first model works of screening and treatment. So we are using a demand generation using district-wide screening campaign where we make like a coverage, we implement this strategy in one district, and when you achieve coverage, we move to the other district. And again, we have been integrated services delivery through different services, mostly ART clinics, and the general population through family planning and antenatal care services. And you have expanded the HPV testing via integration into existing testing tool and the referral system. And again, training, mentorship, and supervision are a key to build the capacity of healthcare providers, and we are using electronic patient tracking system to ensure that we are following well our women. Next. If we look at the data for the first pillar, as you can see from 2011, when the HPV immunization has been introduced in Rwanda, until now, we have sustained the coverage high, more than 90% until now. Next. If you look at the second pillar of screening, you can see the number of women screened controlled over the years. If you can see from 2018 up to now, the number of women that you have screened for cervical cancer controlled has been increased dramatically, showing a scale up of services. In 2025, we are in the middle of the year. At the end of the year, that graph will be also higher, as you have seen that graph of 2024. Next. So you can see in this slide, in the red color, it represents the number of women screened with VIA. In the blue color, it is women screened with HPV. As you can see over the years, we are moving from VIA to HPV, which is a standard test recommended to achieve cervical cancer elimination goals. Next. If you can look at this map, as I have mentioned before, we are doing a district-based campaign, as we have realized that opportunistic screening or routine screening is not working well. Actually, we are integrating a mass screening campaign, and after we continue routine screening integrated into services. You can see that in the green color, those are districts that have already achieved a 90, 70, 90 screening coverage. Sorry, okay. You can see that we have in northern province, Gicumbi. In the east, you have Bugesera. In Kigali, you have Kicukiro. In the western province, you have Karongi, Rubavu, and Nyabihu. Those are the districts that have already achieved 97, 90%. Countrywide, you have 38 eligible women screened with both HPV and VIA. The coverage of HPV only, it's 28%. Among the women that you have screened with HPV, 17% have been tested HPV positive. Among the total women that you have screened, 70% have presented precancerous lesions, which represent 18% only among HPV positive women. More than 80% of precancerous lesions countrywide has been treated with ablation or RIP. And countrywide, you have identified 2,751 cancer cases that have been referred to our different referral and teaching hospital for appropriate management. Rwanda integrated strategy, vaccination, HPV, and HPV screening and treatment shows strong progress toward cervical cancer elimination. We have achieved a high vaccination coverage, and we are improving also, we are expanding screening and improving the treatment and the follow-up. This can show that Rwanda is on track to reach WHO elimination threshold before 2030. Next. I'd like to acknowledge most of our partners and stakeholders that are contributing to these efforts. Some are in this conference. I would like to acknowledge the high participation of Erecta Foundation, and other partners that have been supporting include United, CHA, Imbuto Foundation, Genius, RSOG, Partners in Health, UNFPA, WHO, as well as other partners. Thank you for your attention.
Thank you very much. Let's see if we have questions for our panelists for the 3 presentations. Yes, go ahead. Keep it 1 question. Someone give the microphone to Prof. Muganda. 1 question, and please specify whose the question is directed to.
Thank you so much for good presentations. My question, it is about the last presentation. Really, you are doing a great job, which is very good. But I want to ask some precisions about answers, results of HPV tests you provide. You have sites where you have been testing. When you provide the result, what did you say? Positive, negative, just that? Or you add also the subtype found? Okay. That is very important in the management. Okay. The second question is about the last number you presented, 2,751 confirmed cancer cases managed. I think that is another study. We should know what is the outcome of those cases, confirmed cases which have been managed. So I wanted just to have precision about those 2 questions. Thank you.
Okay. Thank you. Any other hands? Oh, any other hands? Yes, there's 1 question. I'll take Dr. Eugene. And then, is there any other person? All right. Oh, and Deja, then that will be it.
Thank you. I just want to comment for the first presenter. We have seen that the clear cell carcinoma of the cervix is rare. So from the presentation, we can see that for young patients that are having this abnormal uterine bleeding, they should be also thinking about cancer. So there may be cervix, there may be sarcoma of the cervix for the young patient. So when the patient is given the treatment and it's not subsiding, we need to be thinking about cancer. So for the second presenter,
thank you. Let's keep it to 1 question. We have another one. I'm sorry.
Thank you. I'd like first to thank panelists. My question goes to the last panelist, Mark. Okay. Can you share the secret or strategy you used to achieve this high number of cervical cancer screening in those districts, different districts? Thank you.
Thank you. I'll give 2 minutes to Mark to comment on both questions, and Dr. Ayaya for 1 minute to comment on the question. Thank you.
Thank you for those nice questions. The first question was about the HPV results that I'm talking about. Actually, it depends on the type of platform that we are using here in Rwanda. Actually, we are using mainly 3 types of platform. About molecular platform, Roche molecular platform. We are using also BioLad. We used also previously Atila Biosystems. Most of those systems are providing HPV types, genotypes 16 and 18, and other high risk combined together, other 12 high risk combined together. So I think that is the response, but there is also another platform that you have used in one district, in Ngoma district, which is based at NRR, which was able to provide 14 subtypes. But in summary, most of the platform that we are using, they're providing 16 and 18 and other combined together, and this is very helpful for us, as we know most of cervical cancer, 16 and 18, they are the most oncogenic. The other questions about outcomes of those women who have been confirmed with cervical cancer. So I was not able to present it here, but we did also another similar study. Maybe you can see also at the internet, which is survival among adult diagnosed with cancer. Even if it is not part of this abstract that I have presented, you have observed that the survival of Rwandans at 5 years, it's around 55%. That means that only around half of our patients that we are diagnosing with cervical cancer are surviving after 5 years. Yeah, that is like the information that we would like to present. Maybe in future we can also incorporate so that you can see number of diagnosed cases, but you can see the number that are still alive and those who have died. And the last questions about which strategy that we are using for those district-based campaign. So actually, the most strategy that we are using, we are working closely with different partners and stakeholders, as have been mentioned. This strategy have started in 2020, mostly with our partners, Electa Foundation and CHAI. We have also mobilized other partners like Imbuto Foundation to synergize our efforts and to plan together this campaign. This includes like demand generation, where we work with local administration from the mayor up to SER, executive secretary of SER, for community mobilization. Work also with healthcare providers at all levels, including doctors and nurses. And again, we use like media, radio, TV, and other mobilization channels. And we deploy also a community, a team that go to health facility to support healthcare providers. Yeah. And we provide also training and mentorship of healthcare providers. And again, there is one providing those services with our coordination and collaboration with different partners in the local administration. It is that way we manage to screen a lot of women in a relatively short period, working together with different stakeholders, local administration, and healthcare providers.
Great. Thank you so much, Dr. Mark. Dr. Ayer.
Okay, thank you. So mine was a compliment. Thank you, Dr. Eugene, for the compliment. This, especially these adolescents presenting with clear cell carcinoma, their first presentation is often irregular vaginal bleeding. And that should be a window of opportunity for meticulous examination, meticulous diagnosis, and management. The earlier the diagnosis, the earlier will be the stage, and the better will be the outcome in the management. And thank you for the compliment.
Great, thank you so much. A big round of applause for our panelists. May you please take your seats. So we are going to make an agreement, because I want people to keep enjoying, but also want to make sure that we are mindful of time. So we've got 2 greatest sessions coming. So, and I'm sure some of the people are already starving. And we've got like a nice coffee break outside. So what we're going to do, we're going to have one more session. Then after that session, I will request everybody to step outside, go grab your coffee, tea, juice, and snacks, and bring them back. Can we do that? Can we do that? Yes. Great. So we bring everything back, and then we sit here, and then we enjoy the next session. So without no further ado, I'm going to call, we're actually going to go in the same breath, exactly where Dr. Mark just left off. We're going now to talk about cervical cancer in Rwanda and the roadmap to its elimination by 2030. So we're going to call upon Dr. Theoneste Maniragaba from RBC. Thank you. Can we please show some love to Dr. Theoneste? Dr. Manirakiza Emmanuel from RSOG, one of the cervical cancer screening champion. And we've got one of our partners who has helped us a lot and definitely doing much in this campaign, Miss Lacey Harbert. Can you show some love? And last but not least, Mrs. Muhuza Imelda. And I'm going to call upon my moderator, Dr. Elafet, who is one of our members at Shashibe, to moderate and chair this discussion. Thank you.
Okay, good morning. Good morning, distinguished guests, colleagues, and partner CNALs. I would like to welcome you to this important panel discussion. First, I want to summarize the presentation before to highlight where we are with the fight of elimination of cervical cancer. Rwanda has shown the world with vision, commitment, and with collaboration, what once seems impossible is now achievable. From scoring one of the highest HPV vaccination coverage to expanded screening and treatment services, it is now already named as a model of progress for cervical cancer control. And on the behalf of the audience and myself, I would like to welcome and thank our panelists for being here. Okay, thank you very much. Now let's start our discussion going into the specifics of our roadmap. As presented before, the overview of the government current status about the elimination roadmap was presented before. And now specific to our clinical practice, I will start from Dr. Theoneste, from your clinical experience. Probably the representative can answer this. How do you see the role of the Electa's advanced external beam radiotherapy in advancing the cancer treatment? Probably Ms. Lacey, from her years of experience from medical technology, can help us answer this question.
Thank you. Good morning, everybody. First of all, let me take this opportunity to appreciate our partners, starting by RSOG, for giving our cancer program, of course, representing RBC in what we are doing in cancer and disease program control in Rwanda, and also thanking for your role in supporting the program in strategy, but also in implementation. But also, I want to take this opportunity to appreciate the contribution of all of our partners, including Electa Foundation and you being here. Thank you so much. So to add to what my colleague Mark has presented, this is the implementation of WHO strategy that will take 10 years from 2020 to 2030. However, due to the good political will and also the leadership of our country, we asked the question to ourselves saying that can't we achieve it earlier? And we thought that would be better. And then as everything started by the strategy, the Accelerated Cervical Cancer Elimination for Rwanda was launched by Her Excellency First Lady on 1st February 2025. And this will be taking us 3 years to be achieved in 2027. So as the pillars have been mentioned, to remind, we have to make sure that we achieve the 90 of cervical cancer vaccination, whereby we'll be screening ladies of 13 to 15 years according to our cervical cancer screening and vaccination guideline. But also we have to make sure that we have screened the eligible women For our data, who will be around 1,500,000 women that are between 39 to 49 years, and also make sure that we treat at 90% for all those will be found with pre-malignant lesions, and also the malignant lesions, to say those who will have invasive cervical carcinoma. So the first goal was to make sure that the strategy is there, and also with the 90%, as it has been shown since Rwanda started the vaccination in 2012, we have been covering above the 90, unless during the COVID, whereby we were around 90, but other years we're covering at around 93, and we keep maintaining this. With screening, that's where the challenge actually is still, but we are making sure that in collaboration with partners, we can achieve this throughout campaigns. This has been mentioned during the presentation by Mark. Now, with the treatment, that's where also we have to tackle, because globally, 6% of all cancers are treated by radiotherapy. And when you go to women cancers, starting by cervical cancer, vulva, vaginal, and even endometrial, according to, for a gynecologist, according to evidences, from the stage 1, for stage 2A, till to stage 4A, radiotherapy would be the major treatment modality, whereby also the surgery would play a very good role, especially for stage 1A, stage 1B, and even for other like stage 1, 2A and B, but you still need radiotherapy. And when you need radiotherapy also, you need to make sure that when you are configuring your modality of treatment, you give the external beam radiotherapy and the brachytherapy. So Rwanda has installed this treatment in Rwanda from since 2018, that is based at Rwanda Cancer Center, which is part of Rwanda Military Referral Teaching Hospital. And we are using the best modality, which is, for those who can understand, we are using the VMAT, and this is the best modality. What we are not having it is brachytherapy, and in collaboration with partners, the Minister of Health is making sure that we start with the brachytherapy, because the evidence have shown that when you treat with brachytherapy and external radiotherapy, you get good outcome, but also you decrease the effect of radiotherapy, just side effects for women, including especially as we are having young women who are at the reproductive age, but also who need longer time for survival. Reminding that with our data, 5 years survival for our women, it is around 50%, while it should be increased around 70%. The reason is that most of our patients present at late stage, around 70%, and throughout these campaigns, we want to make sure that we can find women of 2A, 2B, with having like 80% chance of cure. Thank you. Maybe that's where I can.
Okay, Ms. Lacey, can you tell us something about?
Oh, I'm not sure I can add anything because I have experts here. I just want to say, so people say, you guys all know I'm from Electa Foundation, we're the screening. Actually, before I joined Electa Foundation, I worked at Electa for a long time. Electa is the world's leader in radiotherapy devices, and Rwanda Military Hospital has it. Actually, I want to tell a story. I did not know that. So 3 years ago, I visited RMH. I was surprised to see there are two, like Dr. Serenesti said, a 2 VMAP machine. And at that time, they're treating 70 outpatient treatment a day, which is amazing. Because I've been with Electa, I've been to a lot of countries. I can tell you in Africa, not too many countries have radiotherapy, right? So seeing that, it's just amazing. And listen to Dr. Pacific saying they treat 70 patients a day. That just, I was just wild. And fast forward, they can now treat 120 a day now?
Yes, we can do.
Yeah, so with 2 machines. And also, Dr. Sianesti was saying, with the braking machine comes in. So Rwanda is not only good on the screening, and also on the cancer treatment, right? That's exactly we see how, when I say government's committed, what I see is not what they say. It's what they do. And that's a great for cervical cancer patients, because the protocol, my understanding is, if the cancer is confined within cervix, you do surgery. But out is 17 weeks in the radiotherapy and the chemotherapy together.
Yes.
And that's a gold standards. And you can see it's not, you screening so many, you also take care of cancer patients. And I'm super, super impressed.
Thank you.
Thank you, Ms. Lacey. It is a state of the art. Even few countries in the region has this radiotherapy machine. It is revolutionized the cancer treatment. As I also open the floor for Ms. Lacey to tell us more about Electa's foundation role in cervical cancer elimination journey in Rwanda. And I'm hopeful she will tell us more about the Mission 2027, the FAST model, and how the progress is going on until today.
Okay, I will try to keep it short because you guys probably had to stay for 2 days for me. I get excited when to talk about this. So a lot of people asking us, you hear, say, Electa Foundation, our great partner, all those, what exactly the role we are playing? So I summarize in 3. So first one is implementation. So together with RBC and our partners, you hear we co-designed and co-developed and implemented this FAST model. I'm not gonna go through the details. This FAST model is how we are able to do mass screening, right? So during the mass screening campaign, we can screening 1,500 to 2,000, 2,500 a day in Bugesera. And that's what we're able to do in the district by district to reach 70% screening model. And that is we doing together, and we are not just a regular NGO come over and to see and how fund this. We're actually deeply involved in the implementation. We're working together. We have so many meetings. I think at the CNSD, we probably have a weekly WhatsApp check. So this is one role we do. The second role is to, I call this bridge, because it's not only we doing faster, but how ensure this program is also state of art, right? That's, we use our connection to bring the global experts. For example, Karolinska Institute in Sweden, it's what's renewed, everybody know there. They are the best HPV research center. I remember first time we come in, and Dr. Jürgen Delna, who is, we call it the HPV god, right? So I remember he told me, he said, well, Lacey, if you want to go there to do screening, truly make a difference, don't do these opportunity-based screening, 5,000 here, 10,000 there. Yes, it will help, but this is sexual transmitted disease. You need to go there doing population-based. What does that mean? That means 70%. So that's how we say, we're gonna do Kachumbi, do 70%, and that's, you see Mark was saying you finished 6 districts. So it's important to, not only the program can do faster, and it can do better, right? And then the third role, I would say promote, because I feel Rwandan is, you're so busy doing good work, and sometimes we forget promoting ourselves. In Rwanda, so that's, I'm doing a lot of work going to the global space in eliminating cervical cancer to share our success story, to talk about our FAST model. Recently, for example, in June, in Bali, WHO and the Gates Foundation, they hosted the second global eliminating cervical cancer forum, that we call this Bali Forum. So state minister was there to give a keynote speaking, and before that, people don't know Rwanda is doing that. And then after that, everybody knows about Rwanda. So I'm asking all of you, because I know you have a lot of global conversation, talk about the Mission 2027, talk about our achievement. Don't be shy. Tell people how good they are, because when you're doing that, you actually brought global attention, and you can bring more resource here, and bring the more experts here. And that's the 3 roles we're doing that.
Yes, thank you very much, Ms. Lacey, for your detailed explanation. Apart from partnership and global awareness, the work we do in the community is very important. Especially community mobilization is a backbone for this elimination journey. Perhaps Ms. Emelda can tell us more about the work they are doing in Society for Family Health. So how does Society for Family Health is playing a role in cervical cancer awareness creation, community mobilization, and can you also tell us a bit about the community-based clinic that you are doing a lot of good work in fighting the fight?
Yeah, thank you so much. I'll start by saying that we all know that access to information is essential to everyone to make a decision on their health. So as a woman, and as women here, we know that it is really very difficult to make a decision to go to test for cervical cancer. Think it this way: you're feeling much better, I don't feel any pain, and nobody has ever told me or asked me or told me if I might be at risk. Why should I take cervical cancer screening necessary? So this is a question to all of us, and this is a question to all women in Rwanda and outside Rwanda. So I'm saying this because I would like to say that information, education, community mobilization is very, very important in the journey of the cervical cancer elimination. Yeah, so this is a reality for every woman that is here and outside here. And this is why we should take community mobilization, education, friendly messages, not scaring messages. Don't tell people that they're going to die. Go to them, find them their communities, talk to them, and tell them that it is necessary to test before the symptoms appears and before it is too late. So this is what we do at SFH Rwanda. We design messages, we design friendly messages, take them to women where they live. We don't call them on the radio, we don't call them on TV. We find them in their communities. So we work with community health workers. This is a very good platform. And there's a question that was asked from a colleague that what did the government do to screen all those numbers of people, all those numbers of women? Well, we did find the women at home. We worked with community health workers and local leaders, and it's very important to engage local leaders from the mayor, as Mark said. These local leaders have a lot of platforms to disseminate messages. We have existing structures, existing channels. Every week there's the council meetings, there's Muganda, the end of the month. There is the CNF, the Women Council. So all these are platforms, the local structures that we can use to reach women. Yeah.
Okay. Thank you, Ms. Melda, for your explanation. So the health-seeking behavior is very important in reaching out this journey. When we do HPV vaccination, we decrease the risk of HPV infection. When we do screening, we detect early precancerous lesions. So the overall goal is to avoid happening of cervical cancer or early detection so that we can treat. That means we can decrease the risk of cervical cancer deaths. That's the primary goal for all this mission. Perhaps from the clinical experience, Dr. Emmanuel can tell us the importance of precancerous lesion detection and treatment, and the early stage detection and treatment having the impact on the clinical outcome or the patient survival rate.
Thank you, moderator. I'm happy today we are here saying the roadmap to elimination. In the last conference, we were talking about is it possible or is it a dream or reality? Now from the presentation we had today and this conversation, you can say it's a reality because we are on the way going. If I start from the question Dr. Muganda raised, from those 6 or 7 districts we achieved, we have like more than 110 confirmed cervical cancer, and most of them were at stage 3 and 4. Unfortunately, more than 14 died right now in a period of less than 1 year. So, cervical cancer is there. At every 2 minutes, a woman is dying from cervical cancer. Whatever we can do, having those modalities of radiotherapy, wherever, we can improve the survival rate still at less than 20 when the cervical cancer is advanced. So, what can we do to prevent that? Vaccination, we achieve the target at more than 90%. The second prevention can be screening and treat early and precancerous lesion. That will improve the success of our road. We need to screen. We have a target. We have the materials like HPV. We can do VIA. But what is our commitment to do that? It is still a challenge. As they said, we need mobilization. I can ask to the audience, how many of us talk about cervical cancer screening in the last 2 weeks to the community, to our client? Because by screening, we can detect early precancerous lesion and early stage of disease, which will enabling us to treat this disease before it went far from nearby organs, bladder, rectum, and wherever. Because when the disease reach the further or advanced, it's where the survival rate will decrease. So we need to participate in this cervical cancer screening and try to avoid the further expansion of the disease to advanced disease. Because when it comes there, it will have more complication and difficult to treat. We will need this radio, chemotherapy, will be impossible to remove the localized disease. Even surgery will no more working. We will see the effect of treatment and the survival rate will be worse. So the importance of screening, the participation to mass screening, and the participation to the audience, gynecologists, students, nurses, midwives, to this movement of campaign and screening will help our women and prevent them to go to the advanced disease. Thank you.
Okay. Thank you, Dr. Emmanuel. So as stated by Dr. Emmanuel, it's better to avoid than deal with the complication of cervical cancer, especially case of cervical cancer, advanced case. Even after treatment, the quality of life they will have even after cure of the cancer is very poor quality of life. So the important place to work on dealing with cervical cancer is on prevention, especially on screening of early cases so that we can intervene early. And after we intervene for precancerous lesions, we can give the quality of life for the woman for her remaining lives. And when we come to the practical level, one of the challenges we see in dealing with cervical cancer is the high cost for cancer treatment. Especially some patients even may find it difficult to follow up with the cancer treatment because of the high cost of the cancer treatment. Perhaps I'll forward this question to Dr. Tuenste. How does inclusion of the cancer treatment cost into the community-based insurance will benefit the patients?
Thank you so much. It's a very interesting question. One of the key achievements throughout this roadmap to achieve cervical cancer elimination is the universal health access to cervical cancer treatment from the screening or screening for screening first of all, treatment of malignant lesions and malignant, and this will include surgery, radiotherapy, and systemic treatment. So by January this year, the government of Rwanda has approved the what we called cancer benefit package, which will be dispensed under the CBHI. Previously, there was assistance by CBHI for radiotherapy only and surgery, but also not all surgical interventions in cancer care that were catered. So there were this discussion through the Minister of Finance, of course, with implementing agency, which is RSOG, to say what may be the case, comparing maybe what can be done to improve the quality of life of Rwandans, but also not costing too much to the government. to think about what can be the effectiveness of this CBHI covering for cancer patients. Because of all we know, cancer treatment is very expensive, not here and even globally. Then when the cancer benefit package was approved, the government worked within its all means to make sure that there can be different sources to search for funds to support this, and then it was approved. Currently, we are now on phase by working with our partners, Rwanda Medical Supply, dealing with the procurement of these drugs. And what you can say is that throughout this cancer benefit package also, the Minister of Health has worked with reviewing the tariff to make sure that some intervention costs can be reduced. For example, the radiotherapy for one single session was around 80%, but has been reduced around 13,000. Make sure that when we start getting this treatment under CBHI, especially talking about cervical cancer, there will be this seeking behavior will change because a lot of women will be accessing to treatment. I can give different stories that are not, which are very painful because women would come at RCC, and when you tell them the cost of what they are going to pay, which will be the 10% of the contribution, some will be running. Because for a patient to be treated curatively, let's say maybe a woman of having like a stage disease of 2B, they will be requiring around 30 sessions of radiotherapy session. And that without adding the indirect cost and even the systemic treatment that will be adjunct to the radiotherapy, because the treatment is concurrent radiotherapy. So it will be around 200 or 300,000, which is difficult to be afforded by a normal citizen here. But throughout this mechanism of cancer benefit package, approval to be under the CBHI model, then with the tariff, I think this has alleviated a lot to all of us. And we think now it is part of us, now clinicians and the government, to make sure also that we improve the infrastructure and equipment, but it will help the patients to get access to treatment. Thank you so much.
Yes, thank you. As doctor said, even some patients are fearing screening for the fear of the cost of the cancer treatment if it is detected. It will enhance the screening therapy, the screening package, and the community mobilization that there is a chance of government support from the cost of the cancer treatment. Thank you all for your engaging participation. Now we are reaching to the end of our time limit. Okay, I will accept one question.
I'm very sorry. Dr. Emmanuel, despite you are doing a great job, but I'm still worried. I am still worried. You are doing a very good job, I accept. You have good figures, but I am worried about our ladies in town. Are we doing it enough? Are we doing it enough? In town, we have educated ladies, we have business ladies. Are we doing it enough to screen them? Because I think that in a rural area, really, you are covering, as it has been said, you have technique of communication. So how are we communicating in the town among educated ladies, business ladies? So that is why I'm still worried about screening in Rwanda. Thank you.
Just a quick comment. Rwanda's done a remarkable job with vaccinating young girls, and now I hear women, which is amazing. How about we get men, boys and men, to get the vaccine as well, because I feel like they're half the problem. Thank you.
Seems like no hands.
Maybe better we respond for these questions. I think the first question is about how is the screening awareness creation in the urban areas?
Screening is a process. It requires mobilization, as they said. It requires understanding. It requires materials. It requires all of us, community health workers. In the town, there is a big challenge. It's supposed to be easy because we suppose they are educated. They understand the importance of life. But it is where it is very difficult because they are very busy. We tried in Kichukiro, we reached the target more than 70%, but it was very, very difficult. You go to door to door, you don't find them there. We give a message, they don't come. And most of them, they said, we have our own gynecologists and doctors. We will go there and look for the screening and treatment. My doctor Muganda didn't tell me anything about cervical cancer. It's an example. That's why we call all of you to participate to this activity. Even you are treating them for pregnancy or other causes, please tell them about screening because the materials and the providers are there. And also, we need the quality of care. We are training the people, we are calling the people for the training for these procedures, HPV detection, via RIP, term ablation, but most of the time, these providers in the town, they are very busy, more than others. So we need to change strategies for a town or in a city screening, but we are doing our best, but is not enough, as you said. We need all of you to help.
Please, let's get to the next
Perhaps
responder.
Mrs. Emelda can tell us more.
Yeah, I would like to add that at SFH Rwanda we do targeted messages. So we talked about reaching women in the remote areas, but we also think about women in towns. So we are planning to do targeted messages through social media. You know, we are all on YouTube, Facebook, and whatever. So as I said before, they need reminders. They just need to be reminded about the dangers of not being screened. So maybe we can take it as a strategy that we can use. Talk to them where they are. They are at work, but they have computers, they have smartphones, they can access YouTubes. So we can put testimonies of people who have screened, and it's just like reminding us, I'm one of them, so thank you so much.
So,
yes.
Can I support?
Yes, please.
Thank you. First of all, we don't need to blame this population because every time when there is a challenge, it comes back to the leadership and we are the one to deal with it. So the rural population community is different from the city, as you have said. We have noticed the challenge that it's difficult to reach them following the same model that we use in campaign in rural area. So in last 2 weeks, I think SFH is part of this exercise. We are trying now to think about what might be different models of communicating throughout the city. Because it is not only in Kichukiro, when you go even in Rubavu, where we have passed around in those Rubavu city and even in Musanze, so it is a challenge because people are difficult to be reached because of they are busy, but also think about access. That's why in Kichukiro, while we were in conducting the campaign, we have given a chance even to collaborate with private clinics to make sure that people can access these services beyond the working hours. We have now opened a service in Legacy, in Carrefour, DMC, Shema Clinic, that health center around the Rwanda Military Fund and Teaching Hospital on the way, so that people can have access. So I think I can't promise a date, but we are working on these communication models so that we can make sure that we improve this communication in city, in our towns. That's what I can say on this. And responding to, I don't remember the name, who have asked why aren't we vaccinating men, right? So it's a matter of protocol and resources, because we know when we are vaccinating HPV, HPV is not oncogenic for women only, for women cancers, even for men, for different reasons that we know, especially talking about penile cancers, talking about anorectal cancers, which are becoming common. So with the protocol, we said, let's first of all make sure that within our means we can achieve this elimination, and then we'll keep changing, accruing to women, so that we can see that we have tackled them. Because HPV is not a risk factor for this only, it has other risk factors. We know that, and we'll be considerate about it. Thank you.
Okay, thank you, doctor.
I want to go back, I want to comment as well. Can you hear me? So I tell you my 3-year experience when Dr. Mel was saying, the women's not just coming because they're free, right? I feel like this is an area, all the doctors here, you have practice your clinics, you in your village, they listen to you, right? Because I tell you, I go to this village, women, first time I was very shocked because they're very scared that they are HPV positive. They told me they're rather than HIV positive. Now I live in the US, we didn't know much about AIDS, HIV. So I was really say like, why are you worried about it? Because 25% to 30% of women in our lifetime were HPV positive, body were clear. Just because you're positive does not mean you have a precancer. Just because you're precancer, you won't develop a cancer. That's because the cervical cancer is one of this cancer, highly preventable, curable, right? That's why WHO say we should eliminate it. Because as a cancer, we don't know the root cause. And then Dr. We went to this like a health center, women saying they are not going to do VIA because she's going to have more babies. They think when you're doing the thermal ablation is you kind of take the cervix out, you clean them up, you put it back. So there's all sort of there's a myth and stigmas, and the woman does not want other people know they are HPV positive. I really feel it's a lot of education. And this is not only Rwanda, it happens other countries as well. So if all of you can take your daily practice, go to your community, can educate them, I think that will really help as well. Because access is one thing, having them come, it's a different story.
Thank you all for your response. If you have time, I want you to give me one short remark, like 30 seconds, that we can take from this our panel discussion.
Maybe before, since I'm the MC, I have the chance to ask. I have a question for Ms. Lacey and Doctor. How do we move from campaigns? Because as an obstetrician, we don't have a campaign of ANC, we don't have a campaign of placenta, plavia, we don't have a campaign of everything. But it's easy to make campaigns of these other conditions. So why do women have to wait for a campaign to be in line with other 1,300 women to be screened? How do we put this in the pre-service training so that as an equipped gynecologist, when you're at a clinic A, you have this clinic where you do screening, or you were in a midwife, you can do screening. And it's a daily thing, and it doesn't have to be a campaign. Because I think as of now, campaigns are the only solutions, because we have millions of not screened. But then what's the phase out of this program? Thank you.
Ms. Lacey?
The questions for me, I didn't get the questions again.
I was saying that at the moment, the only way we can beat cervical cancer for 2030 is through campaigns. Getting the mass people to come, we do screen, we provide the services that are being provided. It's the best way to do it. However, I do not think it's a sustainable solution. How do we move from those campaigns to prepare something that is going to last for long? So my daughter, who is now 10 months, doesn't have to wait for a campaign to be screened.
Right, I totally agree. So there's a twofold. First of all, we need to reach 70% screening because this country has so many women still not had the first screening, right? In order to do that, I kind of agree with RBC. We need to district by district. It's like a wedding, right? You are married September 5th, you come to screen. It's not like any day is not a day because that's way clear. Also, the resource is very limited.
So that's why I think we better do a better communication. Yesterday we went to RBC is have a roadmap. So all of you know, hey, January we're gonna do this 3 district. April we're gonna do the other district. So then you have these women come. Now address your sustainability because that's another second step. Now they have a pre-cancer. They had a thermal ablation in the LEAP. They need to come back next year, right? And then how you have a sustainable, and then go to the primary health facilities, local health centers, health posts. All the nurses and midwives know how to have a follow-ups and how to make sure these women coming back a year. We did a study in Gachumbi. It's like a pouring teeth have a woman to come back, right? So how have a system you say, these women gonna come back, they will get treated. The third thing is I also last night we talked passionately about this LEAP procedure. All the gynecologists here need to know how to do this. So the woman is not going to Kigali, go to Siashka, to say, go down there to have treatment because we know women is not gonna leave the village. That the dollar transportation, they can't afford it. Right? They're not going to those big hospital to do it. So how can you have the service in district hospital? The challenge is we don't have enough gynecologists there, but how we can have a system they can go and all the gynecologists can provide that service. So that is the step 2 and 3. So we just started. Did I answer your question? Yeah. Okay.
If I can complete to what she said, we are doing a mass campaign to catch up. We are training the health workers to sustain the program in existing program to the health facilities. But we launched a strategic plan in February where we insist to increase the training in school training so that in our curriculum we can integrate, put in something like cervical cancer screening, precancers, management, and we call those who are in charge of training in the school to integrate this program in the curriculum. Thank you.
Yeah. So as said is, yes, doctor.
To give him maybe confidence of what, one, we need to make sure that we leverage on the existing system. So we are working with the CHAI to make sure that starting by next month, we work on integration of cervical cancer screening into the existing programs, like family planning and HIV. Second, the pre-service, we are working with 4x4, so that they work with the nursing schools, because they are actually the very major pillar that is helping us to achieve this. And this will help us just to save a lot of funds that we use in this campaign, training people, because they say that they don't have knowledge and skills, and that's what we are thinking. And also the third is to make sure that the CBHI help in paying for the screening. This is very important because with this campaign, we are screening for free. But that free we are talking about, the government or some partners will have paid. So when this will go through CBHI, and to mention CBHI now will be covering the screening for cervix, cervical cancer, breast, and prostate. Great. So this at least will give us like a hope that it can be sustainable. Thank you so much.
Thank you so much.
Thank you.
I think we need to give a huge round of applause for the panel. Thank you, thank you. So this is the part where we have to agree. So we are going to go outside. You may be seated. Thank you. We're going to go outside, grab a drink and a snack, and come back. Can we do that? Can I see how many people are going to do this? Because we're going to come and remind you. Please don't be, we have like a good team outside, but they complained that when they tell people to come back, people still stay outside. So please, let's go outside for 5 minutes, grab something and come back with it. Don't wait to eat and drink outside. Yeah, and as you are lining on the T, there's a poster you can look at. But please, let's go. And this is the time when you actually stand and go and come back. And DJ, this is the time when you put in some music, you know?
in Rwanda, a dream to bring together obstetricians and gynecologists to raise the standard of women's health and to ensure that no woman loses her life while giving birth. This dream became the Rwanda Society of Obstetricians and Gynecologists, RSOG.
In this country, you know that women has a very important role to play in the development of the country, and you cannot doing much if you're not healthy. The associations brought all of us together so that we can have the same way of dealing with the issues.
What started with a small group of committed doctors has grown into a powerful professional society, one that has shaped maternal health in Rwanda for over a decade.
It has been 13 years when RSOG was established, and we were able to establish different programs, basically resident program in collaboration with the University of Rwanda and the Ministry of Health, but also we participated in the capacity building for healthcare providers in the hospitals and in teaching hospitals, focusing on sexual reproductive health, on abortion, family planning, but also teaching GPs and midwives how to manage obstetrical complications. So we were able already to train more than 100 healthcare providers at the district hospital and health center. This is the starting because we have a capacity, and our vision is to be the lead for women improvement in Rwanda, but also at the regional level.
In the last year, RSOG has been implementing residency program in obstetrics and gynecology in alignment with 4x4 reform from the Ministry of Health of Rwanda. It has been implementing this program in 10 hospitals, including 9 hospitals in rural areas and 1 hospital in the capital city. The aim of this residency program is to increase access to sexual reproductive health and rights in Rwanda, and also increase the number of obstetricians and gynecologists across the country. We're not only training the doctors, but we're training the leaders, the policymakers, the implementers, and the future leaders of the country.
RSOG, Rwanda Society for Obstetrics and Gynecologists, has been partnering with us in the health education. They have kind of revolutionized the way we run residency trainings in Rwanda, enabling us to move from an average of 12 enrollments per year to over 70 resident enrolls for PGY in OBGYN. So this is very well aligned with the 4x4 reform that aims to quadruple our health workforce in the next 4 years. And it does not stop there. For me, from the success that we have recorded so far, it's a very good example that other professional societies should be able to follow in Rwanda.
It's a privilege to have worked with RSOG for over a decade. We really value the partnership and the collaboration as having the same shared vision over different projects, I may say, MCSP and Tuvero project and even beyond. So we really reiterate JAPAIGO commitment in continuing working with RSOG in promoting women's health and children to ensure that women are getting health care they deserve.
We see RSOG as a strategic partner that we have worked on a number of projects together, but more importantly, the training of physicians to ensure they are able to provide quality services. I'm very proud of how far they have moved to grow into one of the biggest societies in the region. So we are very happy to have been part of this process, and we are very excited that RSOG is now taking on leading the training of healthcare providers, but also ensuring and working towards improvement of women's health in the country.
From our early age with limited resources, RSOG has grown steadily. So from our first days with limited resources, we have built a strong experience, and we are now recognized national and international. We have expanded our experience in the teaching, in the mentorship, and now with our recognition, RSOG is no longer a simple society, is a trusted partner in education, research, and advocacy.
Jewe natangiye akazi hano mu Rwanda muri 1998.
icyo gihe byari bigoye, abaganga bari bake, ibitaro ntibajya bifite ibikoresho bihagije. Uko nashakaga mugenzi wanjye kugira ngo anyungure ubwenge, ampe ibitekerezo ku burwayi buri imbere yanjye, siko namubonaga. Nabiganiriye na bagenzi banjye, kwishyira hamwe turi abajenekologe 13, tuti dushyireho sosiyete duhuriramo, dushobora gushyira hamwe ibintu byose bishobora gutuma umuhamagaro wacu utera imbere kandi ugafasha benshi. Twagiye mu rugaga international rwo bita FIGO rw'abajenekologe obstetriciens, turi abantu 33, ariko ubu ngubu ndumva turenga 130.
This belief in a shared vision is what kept RSOG alive, even in difficult times, and what inspires the next generation of doctors to lead with courage.
The mentorship program is not just about passing on skills to the next generation of healthcare providers, but it ensures that these healthcare providers are able to not only carry out these skills, but RSOG also ensures that that they are followed up and that they work in conditions that allow them to be able to put in place their skills and be able to ultimately take care of all those mothers that come to them.
Before RSOG was formed, we were just individuals firefighting, working hard to save women's life. But when we formed the RSOG, we got a united voice for women in this country. We got a home for all obstetrician gynecologists in this country. So every graduating gynecologist, whether graduated from Rwanda or from outside, they knew they have a family they are coming to join. So it's a united voice and a family for OBGYNs, but also a united voice for women's health in Rwanda.
I have known RSOG for the last 1.5 years. So in the hospital I was assigned for, there were many shortage of materials, and residentship was started that time. So the materials were provided by RSOG, like ultrasound and other materials. These materials have brought a lot of changes in terms of maternal and perinatal health. So for example, we are detecting complications like placenta accreta and conjoined twins because of this ultrasound's capacity, apart from the professional expertise we have.
RSOG yaradufashije cyane ku bijyanye n'ubuzima bw'umubyeyi n'umwana, cyane cyane kurinda ibijyanye n'ibibazo bishobora kuba nyuma yo kubyara k'umubyeyi. Akenshi iyo umubyeyi yamaraga kubyara akava cyane mu buryo budasanzwe, byari bigoye guhita tumenya icyo gukora cyihuse, byabanzaga kutugora. Ariko hamwe n'amahugurwa RSOG yatugejejeho, yaduhaye, twagize ubu udufasha umubyeyi mu buryo bwihuse.
I was trained by RSOG about LEAP and precancerous lesions detection. So it was very interesting. I learned a lot and to build up my confidence in detecting those lesions and treating them and then save women's lives.
As an OBGYN resident, RSOG has helped me much. When joining this program, I knew already I was going to join OBGYN, but when they came with this new program, it was a golden opportunity because they encouraged women and they gave us opportunity to choose the place where to work from, and because before it was not that easy, we are really thankful to RSOG for that.
Training gynecologists by RSOG, it is a model or example for Africa and the world.
RSOG is more than an association. It's a family to me. It has given me the opportunities to learn, to network, and to grow as professional. So it empowers women so that we are becoming many in that field. It gives us a voice.
Nkanjye nagize ambori pulmonaire igihe nari ntwite, kandi kubera ko najyaga kwa muganga nakurikiranwaga n'abaganga babishinzwe, baramfashije na nyuma yo kubyara bakomeza baramfasha, byose bigenda neza.
umubyeyi wese aba agomba kureba abaganga bakurikirana ababyeyi inshuro enye mu bihembwe bitatu, atari inshuro enye mu gihembwe kimwe cyangwa mu gihembwe cya kabiri. Ibihembwe byose uba ugomba gukurikirana muganga kandi ukubahiriza gahunda muganga yaguhaye.
RSOG is not only giving back to women and children, it's also helping the patients, surgical patients, and it has a great impact in the society because there is a lack of physicians there where I work, and we are showing some improvements, and I'm grateful to be part of this opportunity for helping me help patients. I thank RSOG.
Mbere yuko nkora test ya HPV numvaga mu by'ukuri ntaho nahurira nayo, numvaga bidashoboka ko nayigira ari ugupfa kwikora, ariko aho nyipimishirije nkabona ibisubizo bakanamfasha kwa muganga, navuga ngo byaramfashije cyane.
Since 2012, RSOG has stood at the heart of women's health in Rwanda, training doctors, mentoring young professionals, conducting research, advocating for better policies, and most importantly, saving lives. But the journey is not over. With every life saved, with every doctor trained, with every policy influenced, we move closer to Rwanda where no mother or baby dies from preventable causes. Together, we will continue to walk with women, and for a future where healthcare is safe, equitable, accessible, and of the highest quality for every woman. In 2012, a dream took root in Rwanda, a dream to bring together obstetricians and gynecologists to raise the standard of women's health and to ensure that no woman loses her life while giving birth. This dream became the Rwanda Society of Obstetricians and Gynecologists, RSOG.
In this country, you know that women has a very important role to play in the development of the country, and you cannot doing much if you're not healthy. The associations brought all of us together so that you can have the same way of dealing with the issues.
What started with a small group of committed doctors has grown into a powerful professional society, one that has shaped maternal health in Rwanda for over a decade.
It has been 13 years when RSOG was established. Basically resident program in collaboration with the University of Rwanda and the Ministry of Health, but also we participated in the capacity building for healthcare providers in the hospitals and in teaching hospitals, focusing on sexual reproductive health, on abortion, family planning, but also teaching GPs and midwives how to manage obstetrical complications. So we were able already to train more than 100 healthcare providers at the district hospital and health center. This is the starting because we have a capacity, and our vision is to be the lead for women improvement in Rwanda, but also at the regional level.
In the last year, RSOG has been implementing residency program in obstetrics and gynecology in alignment with 4x4 reform from the Ministry of Health of Rwanda. It has been implementing this program in 10 hospitals, including 9 hospitals in rural areas and 1 hospital in the capital city. The aim of this residency program is to increase access to sexual reproductive health and rights in Rwanda, and also increase the number of obstetricians and gynecologists across the country. We're not only training the doctors, but we're training the leaders, the policymakers, the implementers, and the future leaders of the country.
RSOG, Rwanda Society for Obstetrics and Gynecologists, has been partnering with us in the health education. They have kind of revolutionized the way we run residency trainings in Rwanda, enabling us to move from an average of 12 enrollments per year to over 70 resident enrolled for PGY in OBGYN. So this is very well aligned with the 4x4 reform that aims to quadruple our health workforce in the next 4 years. And it does not stop there. For me, from the success that we have recorded so far, it's a very good example that other professional societies should be able to follow in Rwanda.
It's a privilege to have worked with RSOG for over a decade. We really value the partnership and the collaboration as having the same shared vision over different projects, I may say, MCSP and Tuvero project and even beyond. So we really reiterate JAPAIGO commitment in continuing working with RSOG in promoting women health and children to ensure that women are getting health care that deserve.
We see RSOG as a strategic partner that we have worked on a number of projects together, but more importantly, the training of physicians to ensure they are able to provide quality services. I'm very proud of how far they have moved to grow into one of the biggest societies in the region. So we are very happy to have been part of this process, and we are very excited that RSOG is now taking on leading the training of healthcare providers, but also ensuring and working towards improvement of women's health in the country.
From our early age with limited resources, RSOG has grown steadily. So from our first days with limited resources, we have built a strong experience, and we are now recognized national and international. We have explained our experience in the teaching, in the mentorship, and now with our recognition, RSOG is no longer a simple society, is a trusted partner in education, research, and advocacy.
Jewe natangiye akazi hano mu Rwanda muri 1998. Icyo gihe byari bigoye, abaganga bari bake, bitaro ntibajya bifite ibikoresho bihagije. Uko nashakaga mugenzi wanjye kugira ngo anyungure ubwenge, amye ibitekerezo ku burwayi buri imbere yanjye, siko namubonaga. Nabiganiriye na bagenzi banjye, kwishyira hamwe turi abajenekologe 13 tuti dushyireho societe duhuriramo, dushobora gushyira hamwe ibintu byose bishobora gutuma umuhamagaro wacu utera imbere kandi ugafasha benshi. Twagiye mu rugaga international rwo bita FIGO rw'abajenekologe obstetriciens, turi abantu 33, ariko ubu ngubu ndumva turenga 130.
This belief in a shared vision is what kept RSOG alive, even in difficult times, and what inspires the next generation of doctors to lead with courage.
The mentorship program is not just about passing on skills to the next generation of healthcare providers, but it ensures that these healthcare providers are able to not only carry out these skills, but RSOG also.
Abantu bari hanze, please, turi kubareba kandi turabakeneye. Abantu bari kudufasha kwinjiza abantu, mubwira abantu ko amasaha yo gutangira session ikurikiyeho yageze. Please, if you're standing, abantu abahagaze ku muryango, mwadufasha mukinjira mukegera mu byicaro byiza twabateguriye. Please, if you're standing outside, we need you. Please come on. We're going to start our next session. And I'd like to call upon my co-host to go on with the next session.
So let's begin. I'd like to introduce this next panel discussion on improving access to infertility care and reproductive endocrinology services in a setting where infertility carries significant social stigma. Updates from IVF centers in Rwanda. So let's introduce Prof. Thomas Mekuria. Please, may you come forward? Prof. Thomas, Professor Thomas, please may you come forward. Next, Dr. Ndizeye Nwari and Prof. Ngoga Eugene, Dr. Jean-Paul Jirinjiro. Please may you come to the stage. And next we'll bring our moderator, which will be Dr. Mireille Aimé. Great.
Good morning, everyone. So I'm humbled to moderate this session to talk about improving access to infertility care and reproductive endocrinology services in a settings where infertility carries a significant stigma, social stigma in Rwanda. So we are going to be updated about IVF in Rwanda. So as we know, infertility is a significant public health concern in Rwanda, where we have studies where they showed that about 20% of women who are seeking care are having that concern, that issue. So as our health sector is evolving, they made an effort to address that challenge by introducing IVF as one of the way to address that challenge. So we are fortunate to have 2 centers in Rwanda. So that today we are going to focus on updates regarding IVF in Rwanda and explore strategies to improve access to infertility care and reproductive health services. So as our audience is composed by different people with different knowledge, I would like to first ask Prof. Mekuria to briefly explain us what is IVF, who is eligible, who will benefit that services, and he will also talk about the success rate in our center. Thank you.
All right, thank you very much. Can you hear me? Yeah. Okay. It's a pleasure to be here. I think the audience knows what IVF is, but briefly, it is a process by which we take a woman's egg, fertilize it with the sperm in a specialized laboratory, and culture the embryo, the resulting embryo, for a few days, 3 to 5 days, and then transfer it back to the uterus. So there are a series of steps that are involved when we do IVF, starting from ovarian stimulation, then we'll do oocyte retrieval, then after the oocyte retrieval, fertilization in the laboratory, embryo culture, and finally embryo transfer, with or without freezing. So regarding the eligibility of patients for this procedure, the clinical criteria or indications are very many, but the most common we have seen in Rwanda is tubal factor infertility. Tubal factor infertility seems to be very prevalent, and I think it is the result of STI, sexually transmitted infections, and I think this is something the ministry and everyone else involved in primary care should look into. We should have STI clinics, and primary prevention is very important, not just for the women and tubal infertility, but also for the man as well. We see a lot of male infertility because of these STIs. So tubal infertility would be the most common, tubal factor, then male factor. Then we have ovulatory dysfunctions like PCOS. We also have diminished ovarian reserve, manifested as premature ovarian insufficiency or menopause. We offer donor egg and donor IVF, so that is also a significant portion of patients we do IVF for. And also unexplained infertility is also another cause for IVF. I think that answers the question.
Thank you. And how about our centers in terms of success?
Yeah, so we have 2 centers in Kigali that I'm aware of. I don't have much data to speak about the private center, but at RMH, so when we talk about success, we tend to focus on pregnancy rates. But I think pregnancy rate is just one part of the equation. We should also talk about the live birth rate. We should also talk about the complication rates like OHSS, multiple pregnancy, including triplet and higher order pregnancies, which occur very high cost on patients. So just talking about pregnancy rates, our average pregnancy rate ranges between 50 to 55%, which is a very good rate and acceptable worldwide. But we are trying to push even further. We are trying with Professor Ngoga here, the commandant of the hospital, trying to push the IVF unit in the right direction, buying new equipment. We have also started REI fellowship this year. We are planning to start clinical embryology training also. So by building up our human resource and also increasing the capacity of the embryology lab, I think we will get even better success in the future. And our complication rates, including OHSS and multiple pregnancy, are acceptable and very low. OHSS is less than 1% in our clinic, ovarian hyperstimulation syndrome. And we never had triplet or higher order pregnancies in the last 2 years that I've been here. Our twin pregnancy rate is around 15%. So all in all, we're doing well, but we are trying to push the boundaries.
Thank you. I think success rate of 50 is a good achievement to clap on. So I'm moving to Prof. Ngoga, as he's one of the pioneers among the IVF centers. You have been working with couples who struggled with infertility for many years. So can you tell us what are the main barriers our families, our couple who are struggling with infertility, what are the main barriers they are facing? And also on our side, like our side as healthcare providers, what is the challenges do we face during that process of delivering IVF services? Thank you.
Yeah, thank you very much for that question. I think if you look at the patients, what they face as problem, I can just put them in 2 categories. The first one, as you all know, human beings, sometimes they don't want to reveal their secrecy to anyone, and I think Rwanda is even much more advanced, so we like to keep our things to ourselves. So the first thing is like maybe denying the problems, meaning that to accept that this is a problem I'm facing, it takes some time. You can have two sides. First of all, that side of saying that, is it really or true that I cannot get pregnant? Because we know in our society, having a baby, a child, it's very important. So these people, they struggle, first of all, to accept that. And there are even others who tend to come very much earlier. You can see that they are very stressed. So because they get married now, and after 3 or 4 months, they start coming to see a doctor and say, look, nothing is happening. And you have to explain to them that be patient and you can wait and see that. So those two categories, which shows that it's really a very big problem for our couples, our patients. And it becomes worse if the couple, they don't put together their effort. So most of the time we see that women, they are the one who will come first to try to seek for help. The men, sometimes they think they are not the problem. And if this game of what you call a blame game between the husband and the wife started taking place in the family or in the couple, then even conceiving is becoming a problem. So that's what I've seen in these different couples. And if they come for IVF, and then at the end when we get the results, so we used to see or to hear from some women saying that he gave me money and now the result is negative. So well, it's like it was go and get a child for, if it doesn't work, then you must explain this amount of money I gave to you. So that's a very big challenge, and we always teach the couple to stay together, husband and wife, so they can increase the chance of pregnancy. Another challenge they have is financial, because IVF has been expensive all over the world. We don't know for what reasons, but that's how it is. Wherever you go, it's a lot of millions of Rwandan francs, and it's not everyone who gets this money. Some people, they wait until they get money, and it's too late sometimes to get eggs. It's becoming a problem. So the younger you get, the challenging to get a pregnancy, and that's why you get money to get this service. The younger you are, you don't have money yet. I think that's why maybe today you see that young people, they try to get rich as soon as possible to sort out some issues. But that's a trend. You wait until you get financial possibilities to seek for help, which become more difficult in the failure rate. So from our side as doctors, I think one is to deal with those issues, explain, try to make sure that they understand it. But I think one of the worst times for IVF is when you have to reveal the results to your patients, because you like it or not all of them will get pregnant. And you remember when it's expensive and the result is negative, it's really very touching. It's really painful. So it's still a big challenge that all over the world, we accept that IVF can be positive or negative, the results. And people, they come to seek for help, knowing that it can happen like that. So until we get really a high success rate all over the world, because it's at the moment acceptable that if you have 30% in your center, then it's acceptable. And that's about 3 ladies in 10. But it's different from center to centers, but never 100%. Even when you think that this couple, they have the great chance of getting pregnant, sometimes you are surprised at the end that that lady is negative, and the other one where you are thinking that maybe Iman raza kumufasha, and she becomes pregnant. So there's still some unknown in IVF, and that's where the doctor, of course, doesn't feel good because of the results which you give to your patient. Thank you.
Thank you very much, Prof. So going to Dr. Ndize, he's a gynecologist, but today he's representing one of our biggest insurance company, RSSB, Rwanda Social Security Board. So as Prof was saying, one of the barriers our family are facing is the high cost of IVF services. So my question is about how can public and private can partners doing partnerships so to expand that infertility services in Rwanda. If we can maybe recognize infertility as a public health priority so that maternal health is also recognized to facilitate access to its services for even those poor families or vulnerable ones. Thank you.
Thank you, Mireille. As you say, I'm a gynecologist, but also I'm working for a social company, social security company, which is managing the two big scam. Since today, our RSSB is not reimbursing IVF, but I can't say it will not reimburse because we started a conversation with Dr. Ngoga, which one of the steps of starting understanding well what will be the component of that package and what will be the cost. Is this cost help the scam to be sustainable? If we go to that package, are we going to reimburse for a long period? That kind of question have to be part of that conversation. But they started, we already started the conversation, and I can't predict the result of that conversation for now, but let's see what will be the progress.
Okay.
For the second question, about engaging private on the public relation, yeah, this is a good idea. Why do we want only to interest private investors? What about donors? What about other peoples? Because we see by the history, our health sector have been get support from many people. Many donors have shown their impact in constructing our health sector. I think we can't stop only by thinking about private investors, but also we can think about donors to come and start investing on the infertility. Because it's my opinion, because I have no data, but I assume maybe we are thinking about IVF, but we should also think about other intervention, not costly, but also not accessible to Rwandan population. It should be, I think it will be a time to think infertility as a program, even if the focus will be on the reimbursement of IVF, but also we need to increase the service offered at the community level, at the health center level, at the primary health care level, at the district level, at the district hospital level. What kind of package can be offered so we can be sure that even the less cost-invasive are also giving good results.
Yes.
For making the infertility a public health priority, there is a way of making a medical conditions a public health priority. Either you want to ask if we can consider infertility as a reimbursement priority?
Yeah.
It's not public health. Because if it's the public health, this will not be our call at the level of the RSSB, but there is a step. First, we have to have data. What is the burden of this disease? This is part of the conversation we are making with Dr. Ngoga and the team. We need to understand first the burden of this disease, the epidemiology, the impact, the affordability, because if we go for the IVF with the cost of 3.5 million, an example, the co-payment will be easier for our patients to access because it's almost 10% of that money. All this have to be part of our thoughts or our discussion. Another thing which is very important for making something a priority is what could be the impact if we go through this. Because there are many diseases so far not yet reimbursed, who are pending to be reimbursed. We need to assess the magnitude of each disease and prioritize them. Like the current health technology assessment which was conducted, We choose the rehabilitation of orthopedics and the cancer, and they are still under assessment. Maybe after this assessment, infertility will come, or management of pain during labor will come, but we need to be more strategic in purchasing new services.
Yeah, thank you. So this is, it engages us as clinicians to do researches, to give you data to base on while waiting for our turn to be part of that. So I move to Dr. Byiringiro. He's a gynecologist also, and he's also doing a fellowship in fertility endocrinology. My question is that infertility carries significant stigma in Rwanda. As you a clinician, a fellow in that field, do you see that stigma is real? Do we have surveys which can show us how real it is? And what are the strategies which can help to change the perceptions of Rwandan couple about that stigma, and also how can we engage men? Because we know that infertility is sometimes placed on only women, but we know that they are sharing 50-50 possible causes. You can tell us about that. Thank you.
Thank you. I first being grateful to our country for the big step that has been brought through his own child, Prof. Ngoga, that is considered now as the founder of this area in this country, because it was highly needed. So it's encouraging all of us. I was going to say younger, but there's no younger one. You can make big decisions. Just energetic people, other energetic people. It's a good job, well done. But despite all of that big step, as you say, there is still some stigmas brought in by less of perception, common perception about the problem. So this is basically linked with less information. Our people, they are still less informed about that. Even if, as you said, if we can use data, but we don't have rich data that can show how it is standing, but by experience on a daily basis of clinical practice, we can see that those stigma are based sometimes on less information or some beliefs, religious belief. It's also important because people in their belief, they still seeing it as a controversial. Our treatment, our approach to this problem is controversial according to their belief. So to overcome it, obviously, there must be a coaction between the decision makers, policy makers, and the clinicians. As you have said, we need to do some studies about it and to see how we can overcome all of those through policy making and creating curriculums that will mobilize people towards the common understanding of the problem. Because if we don't do that, as you said, now we consider it as a problem affecting both male and female. But when you don't take out all of those stigmas, culturally, people, they start blaming the women. They become victims. So we need to work together between policymakers and the clinicians towards mobilizing our population through different ways, either as each and everything in health education, it's a concomitant action. We need to work together through different ways, through schools, through media, and through community outreach, so that people can be mobilized and taught about the real problem.
Thank you. So another question came to my mind. I was thinking, if you have any way beyond medical treatment in your services, do you have a way to support emotional and psychological part of our couples who are struggling with infertility?
Very nice question. Yeah, it's really ridiculous to see those people when they are receiving such bad news. I sometimes, when we manage them and it didn't succeed, I sometimes ask myself how Professor Ngoga, that started this problem resolution, how he was behaving before when he started that in Medihill, when people comes and they tell them that things didn't go well. But in any case, each and everything has got a solution. You know, when you start your management in each and every discipline of medicine, the first point is the counseling. So when you sat with them, you explained to them, you told them what is happening, what is the success rate globally, they somehow get prepared to anything that can be a result. Obviously, some emotional effect can come afterwards. But nowadays, when you have prepared them as a health provider and your team, people, they are a little bit trained, even if we still need more and more staff, or that might be social workers or psychiatrists in the case you get a case that highly affected. But so far, by experience, because of pre-preparations and preparations, well done, people, they get emotionally managed by counseling by the consultant or our midwives helping the team. They are very well, they are very nice towards counseling those patients after a bad news if the result didn't go well.
Okay, thank you. So my last question goes to Prof. Mekuria. As we hope that our insurance companies are going to see if they can help our people to access to infertility services. Do we have, as an expert, is there any low-cost IVF models which can be implemented in Rwanda so that it can reduce the costs and our families can afford? Thank you.
Thank you. Before I answer that question, just to supplement on what Dr. Bironjiro said, we have a trained clinical psychologist at our clinic who gives counseling for these patients before they start IVF cycle. So they know what they are getting into, the intricacies and the outcomes of IVF. So that helps in accepting whenever we have a bad result or whenever we don't have pregnancy, which is around half the time. So coming to some of the innovative methods that we can employ, one of the methods that comes to mind is the hub and stock method, which means we have like one hub. Setting up an IVF laboratory is a very expensive endeavor. It takes a lot of money, and thus instead of having multiple IVF centers all over Kigali, what is possible is to have one very good lab, and the clinics can be dispersed. Like you can have 10, 12 clinics that can do ovarian stimulation and that can follow the patients. Then they can send the patients when they are ready for the procedures like ovarian, egg retrieval or embryo transfer or testicular extraction to the main hub, and you can do those procedures. So that's one of the things that elsewhere is employed. Another is the use of minimal stimulation protocols. So the drugs that we use for IVF are very expensive, the gonadotropins. So we can use oral medications combined with the gonadotropins to decrease the cost for the patients. although the yield that we get, the egg number we get, or the number of embryos we get might be lower, the success rate is somewhat comparable, and there are numerous papers showing that minimal stimulation protocols are as good as the conventional ones. And there is also another device that has been around for the last decade called InvoCell. InvoCell is a device where after you retrieve the egg and combine it with the sperm, instead of incubating it in the conventional incubator that we need in the embryology lab, we put it in that device and put it back in the vaginal canal. And after 3 to 5 days of it, we remove it, and then we remove the embryos and put it back into the embryo. So as you can imagine, this decreases the need for a sophisticated embryology lab, and it is one of the cost-effective solutions that have been developed in the last decade, and the results have been good also. So these are some of the approaches that we can use for IVF.
Okay, thank you. So now this is the time to take some questions from the audience. If someone has a question, we can take it. Thank you.
Yeah, maybe we can take one more question. Okay, thank you so much. Let's give them a round of applause. Thank you so much for that. It was a great panel discussion. When there's no questions, that means you answered everything. So next up is something more entertaining, but it's also educational. So next up is something entertaining, but also educational. We'll be having a sexual reproductive health in action sketch. I hope you guys enjoy. So yes.
Basigubye basigubyeta basigubye ego mana ko suye umugabo nkubaba yagiye kuko basigubye ntabazigubyeta mwamboneye basigubye we ntanabona ko umugore wameze nabi arazinduka akigendera gusa nta muntu wamboneye bazigubyeta koko ngo mfashe mwababyeyi bazigubyeta uyu mugabo kuko mana yanjye ubusa ko nta na telefone mfite ndamuhamagaza iki bazigubye kandi yarambwiye ngo agiye hano hepfo mu gihe
ariko uranyabiriza icyo mugore we
ariko si ubwiye ngo uhamagara ntabwo unyumva koko bazigubye ni ngombwa ngo mvuge abaturanyi bose babyumva
yenda agahamagarwa n'uwiteka ubu kurya uzindukiye umuntu muri iki gitondo muribereye mu mirimo
none se ko warambwiye ngo ugiye hano hepfo munsi na nkaba nagushatse nakubuze kandi nshaka
hanyuma tuvuge ko imirimo yose wabyukiyemo irangije ku buryo wumva muri musigaranye rero kumpamagara ako mwebu ntabwo mwumiwe umuntu ashobora kubyuka ahamagara mugenzi we imirimo yagoranye
kubasikubyeka wagireka kumbwira nabi
Dansi
Dansi
utwite ibisazi utwita abadayimoni, utwite satani. Niki kigutera kumuza amahoro umugore?
Nako si ukuba ngo uhamagaye ndi umugore wawe uzi ibihe ndimo umw'abantu mw'ubingiye nkoze ikosa none se mpamagare nde mwagira ngo mumagare Karame.
Nejejwe no kumenyesha ko nakwishimiye.
Ako se kuki utanyishimiye kuko bazi gubyeta.
Umuntu akaba yibereye mu mirimo yigeze kure ukabyuka uhamagara umuntu mwabiza ku gasozi ubundi kuva ko nta kindi kintu wakora mu gitondo.
None se ubu kuguhamagara nk'umugabo wanjye ngo tugire icyo tuganiraho kubona ibihe ngezemo koko bazi gubyeta. Ubu ni ikosa nkoze.
Ubu rero ni wowe ushinzwe ibiganiro muri uyu mudugudu wose ku buryo uhamagara ushatse mu gihe ushatse.
Ariko nabitabaje nk'abaturanyi ngira ngo wenda mbabaze n'umutware wanjye ari hehe. None se hari ikindi kintu naba navuze, hari ikindi kintu ratana babwiye. Nabazaga hano wagiye nagira ngo tuvugane.
Nawe uvuga uri muranyereza.
Nyine nari mfite ikibazo.
Ese vuga vuba.
Nyine nari mfite ikibazo kuko ngiye kugera igihe cyo kubyara kandi nkaba nta gitenge mfite nta n'ibyo mfite nzaterura mu mwana.
Yego ye.
Nagira ngo nyine ko nta kintu uri kumbwira nyine ngo wama nk'amafaranga nitegure.
Ariko dasi ugira ubwenge urasara. Ubu cyo cyo ushaka gutuma umurutuza mu bantu bangana kuriya nibereye mu mirimo ubyuka utanga amatangazo ngo wambuze. Ubwo
none se ko nijoro nakubwiye ngo tubiganireho ukaza wifitiye agasamusamu nkavuga noneho reka ndebe muri iki gitondo tubiganireho ube wamudufaranga noneho ngende njye ku isoko ngura igitenge noneho nshaka n'ikintu nzaterura mu mwana.
Noneho bashaka kumfatirana mfite inyota ukumva ko aribwo numva.
Ntabwo ariko navuze, ntabwo byari ibyo navuze pe. Karame.
Ejo nakubwiye ngo iki? Narakubwiye ngo ujye kwa muganga upimishe iyo nda bakurebere niba nta bibazo ufite. Urananira uvuyeyo
bazi gupye genda nakurahiye pe nongere nkurahire ndakihina inagiye ntago nasubira kwa muganga. Ubu giye umuntu umaze kubyara inda 11 nasubira kwa muganga agiye maze kuba amenyo y'abasetanga hose giye nkajya kwa muganga nzayibyarira hano mu rugo nishaka izanyica ninsanga yo bakeya nzagaruka. Ubundi se mama we ntago yambyariye mu rugo njye nyera amafaranga njye kwigurira igitenge ibyo kubyara.
Okay biroroshye dansi. Niba udashaka kujya kwa muganga uranyumva. Niba udashaka kujya kwa muganga uzabage wifashe iyo nda uzayibyaze uzayiterurane ibyo bikenya by'ibigomo uvuga uzabyigurire nta gitenge nzakugurira uzambara ibyo usangaho kuvuga ku byara 11 hanyuma bo wabyaye mbere wabateruye muki hanyuma buri mwana yakuze ibyo wamuheka murabigurisha ubishyirahe.
None se bazi gubyeta kozi ko wanguriye umwana wa gatandatu se womeruka kugura ikigome cyangwa igitenge. Ubwo ngubwo kuba ntaragiye kwa muganga kwipimisha nicyo cyatuma udaha uburenganzira uyu mwana ntwite keretse niba uvuga ko atari uwawe. Ngiye rwose ntabwo nzasubira kwa muganga. Niba ushaka kuzampa igitenge ari uko giye nagiye kwipimisha ntaho nzajya nishaka nzamuterure mu byahi cyangwa nzamuryamishe hasi.
Okay none reka nkugire inama rero.
Karame.
Byara vuba niyo nama mfite yo kugira. Noneho ubyare vuba ngo utere indi nda hakibona dore imyaka irimo irangendana.
Ngo iki?
Ngo utere indi nda kuko ndashaka umubare ushyitse nyine wa kirisitu.
Bazi gubyo wabitekerejeho.
None 12 barageze.
Reka nkubwire rero bazi.
Kandi ahubwo tugiye no kubyara 13 kuko rega mu bana hashobora no kuza mu cyayuda ukabona umuntu asigaranye 11. Ahubwo noneho ugenda ubaza abandi babyeyi uburyo umuntu w'umubyeyi yabyara nk'impanga ngutere tubiri dukurikiyeho duteganya ko hari mumwe watubera yuda noneho umuntu yuzuza umubare w'Imana rekeraho.
Bazi gubyereka noneho je n'iby'ibitenge mbivemo. Jewe dansira mpagaze ku maguru yanjye abiri nta kintu na kimwe nitayeho. Niba wumva genza abyara ugasubizamo indi nda ibyo ntago bishoboka. Nkimara kumushyira hasi nzahita nitabira uburyo bwo kuboneza urubyaro. Urumva neza nushaka undi mwana cyangwa izo ntumwa zawe niba ari niza Yesu uzajya kumubyara handi jewe dansira umva nushaka uzanaho ngusinyira ntawe nabyara.
Ariko dansi iyo wigira gutyo ejo bundi nkuvanye wanyi Nyamagabe utagira inkweto wararwaye amaga ufite imyata ahantu hose nkuzanye hano nkugejeje i Kigali ngutuje za Kimisagara uhahiye hafi utuye ahantu hari amazi n'umuriro ibyo bintu byo kwiryagagura bikuye hehe ko nakuzanye utagira agasura.
Nere sibyo wagiye umwana none ibiguzi byuko nabyaye. Reka nkubwire ndakubwiye ngo giye uyu nzamushyira hasi njya gufata uburyo bwo kuboneza urubyaro kaba gashinge cyaba kinini jewe dansira.
Ubwo ugiye kuzanamo bya bintuze hanyuma usigare warumagaye njya manuka muri guserebeka kuri kaburimbo.
ariko nk'ayo makuru muyakura heyo kuma
Dansi urarya umwungu sibibamba
ibyo bintu byo
niba ushaka kuzanamo ibintu byangiza systeme ibyo byo kuko isano dufitanye ngewe nawe riba nawe urahazi uramutse ukubisemo ikintu gituma humagara ngewe nawe ubwo twaba tubyaranye abo kandi nagira ngo umenyeshe ko uyu mudugudu ubyiriye abakobwa beza bato nahita nzana undi ukibireba
ako se nk'ayo makuru bazi gubyeta koko uburyo bwo kuboneza urubyaro ni bwinshi imibiri y'abantu ntihuye urumva ningenda ngafata uburyo bumwe nibungwe neza nzasubira kwa muganga bongere bampindurire kuki wumva ko njye ninjya muri ubwo buryo bwo kuboneza urubyaro
noneho urashaka ko inzira yawe ihinduka gahunda ni mu rugo kwa muganga wagiye kurata byambuye nabi hanyuma uzajya kubisuzumisha bitabanje kuntera ikibazo
ariko kuko
okay mbwira uburyo wumva uhisemo nonaha ariko butarenza amezi ayo 6 ugafata gahunda itarenze amezi 6 kugira ngo nyine mpite ngukurikirana neza
ako se bazi kubyeta koko wa mugabo we
mbwira ndakubaza nubuye buryo uhisemo
nyine navuze wenda nk'agashinge cyangwa se ikinini n'ubundi bwinshi bwo mu kaboko ariko niba ibyo ngibyo utanabishaka twakoresha nakoresha n'urunigi urunigi bwo gute nyine urunigi ruba rufite amabara
okay noneho urunigi urunigi rwo niba rukwambike ni numva ndurambiwe nzarukwambura hanyuma gahunda ngi kandi ntabwo nshaka kuvuga nawe ibintu byinshi kuko mfite akazi kenshi ikintu nkubujije cyo ntuzongere kumbaza ibintu bijyanye n'imyenda ariko umuntu mukuru agura undi myenda te ni gute umuntu mukuru akumuhe ibyo umuntu babiseri umuntu ashaka kujya mu isagura umuntu mukuru imyenda ubu se ntugire iwanyu
wacu nonzajya kwaka imyenda koko
ubu akabagabo twaragoye koko umuntu mukuru wewe imyaka 50 nkugura imyenda wese wayiguriye nyakugurirwa ikiziriko
ako bazi gubyuragiye koko nuko nguko ingenje basi reka nkubwira ikindi twigaho turebe icyakorwa bazi gubyeta ntabwo rwose wagenda gutyo tutavuganye
niko mwarabuye wahabonye iki ni igikorwa ni ukuri kw'Imana wahabonye wiki no akazina wahise none niko keza hose ni akabari kanjye impamo y'Imana ariko ubonye ari amashambure izina wayise rero niko izina wayise niryo ryo ahubwo mbese ndyibagirwa rya ngo yitwa Mugahege ni roge buriya rero Mugahege ni roge ni ahantu ushobora kujya ntugire izimwe na rimwe wumva ku izina rye mva sinkubeshye aha hantu noneho twatunyobwo twose tuzajya umva ko polisi reba narakubwiye ngo ngewe mfite akabari gasobanutse umva ko polisi reba ko akira niko yabaye Imana niko icara ngaho jari dusoma kamwe oya ni impamo y'Imana ziraro niko se shaba aribo niko shaba
mwiriwe neza
ayo Mana we uyu mwana akora ha
mwiriwe kiriya
oya cyeshyire hasi shaba cyasuza bacyo kuko udatoza umuco abana nk'aba ngaba oya shanya neza nyagera sha ega makwibondo
mwegere nta kibazo
akazi yagera umukiriya
none se papa
yagera umukiriya ngo so uyu muntu umukobwa wawe ni umukobwa wawe sohoza
musuhuze
nkobera humura urabona mpanda
humura nazamura
uyu mura nta kintu nambariye
ambara
musuhuza nta kibazo waruzi ko nambariye ku mahwa
muraho
ayiwesha kinyabupfura disi nkobera twumve sinzi akantu kandiye hano shaka
hakose manangira
uzi ko ayibogoye sha
ni ukuri kw'Imana ni mumbabarire
ngiye ntabwo nyuma
mbabarira ntabwo nsongera mumbabarire ku nzoga yanyimenetse
oya humura nta kibazo inzoga se ko ari nk'intuza hano ko ari nk'amazi
ubu rero mwarabu
mwari mumpamagaye
burushete 6 ntabwo zirashya
reka ndebe aho zigeze
aho bigeze
Eh,
ariko se buriya dukoresha uturahure dukomeze tumwe gutya
oya nta kibazo
reka ndebe aho zigeze
ubikurikirane
murakoze
ayiga mana we uriya mwana nta kintu apfana na Bikira Mariya ariko se reka mubaze wamukuyeho uriya mwana
mwarawutoza nakubwiye ko akabari kanjye gafite umwihariko ku izina ry'Imana amarage wayabonye abana beza se urimo kubabona bakora mu kabari kanjye
barambwira ngo shambure ni 15,000 aka kana ngiye kagiye kunganiriza se abarangahe buriya
Niko icara nyine
shaka kwicara reka
wabonye ko nshagura neza sha
reka ngubwire rero buriya njyewe nkunda gufata ihene ikihebeba
yego
aka kana se
wese ntukabona nyine
tujye mu biciro tuguriranye nyine nimba ari n'umukozi wawe niyo hofu nayigura ni mama y'Imana
ariko rwose
cyangwa se mugure wese uburyo uko nzajya nza azajya nyitaho uko azajya nza azajya nyitaho nako kwande se huye
ariko se ubwo ari wowe ubwo ngubwo urashaka umugerekaho kuri wa mugore wawe ufite
ariko umugore nazanye yanyerera none atajya kuzana amagaragamba mu ntoki shaka kubera umuhini w'isuka
umva rero nkubwiza ukuri buriya rero nanjye nkubwiza ukuri pe nanjye burafite ububasha aka kana nanjye nakitera ariko reka
buriya njyewe ngira imbeho nibanira nayo byibura kariya kana ukuntu kamfashe tuguriranye nangaha ahubwo bigishyushye
ariko se nakubwiye ngo ngifite ububasha nanjye kariya kana nakitera akishingira
nyine se tuguriranye
ariko bazi gupyeta uri hariya yanyica
nuwo bazi gupyeta ibyo biroroshye ni nk'ubuntu ahubwo kuko bazi gupyeta ni imisururu ya buri munsi akana nkazajya nza nkagatera zingaro mayoneze agafiriti akavuga ati urabona ko umwana mwiza nk'uri akavukira mu batindi koko
umva nkubwiza ukuri rero umva maribo nushaka umwibarize wenda utagira ngo
ariko se ndamwibarize iki wowe mbwira tujye mu biciro
karame
ndahano ye
unywa iki sha unywa iki unywa iki
oya nuwe rwose pe
ufite inkoko
nka fanta oranje
usa nayo ni impamo y'Imana
ntabwo agoye
ntacyo genda bagushyireho agafi harya ngo niko
karame
amakuru numvise niyo
ayaheze
isongo yitwa bazi gupyeta
uriya ni papa wanjye
se niwe yambwiraga
ni papa wanjye
nimba ari ibyo
na mama wanjye yitwa Dansira
yarahindutse nyine umuheruka
none se shareka nkubaza
ndakumva
umwana mwiza nkawe wahisemo kuvukira mu batindi wo gatindikirwa mu mutiba w'inzuki nkande koko mwoka byaraba
uzi ikibazo cyabaye se iwacu twabyaye abana benshi cyane abana bageze mu 10 rero ibyo tubona bidutunga ntago biba bihagije niyo mpamvu papa yansabiye akazi ahangaha rero kugira ngo njye mfasha mu rugo gutunga abana
ano matama yarajya guhombana nzayahombanura
ariko umva nkubwire mwana kuva kigera ngira ngo urabona uko anyerera
aranyerera pe
ubu murasha ntanza nzongera kugira kwa kari performance
genda bagushireho zinga rushaka
uzajya muduhahira
oya wowe uzajya nyine
ngomba kubanza kukwitaho nkawe ibiguru byo bitese mama we
mana yanjye
umva nkubwire
ndakumva
genda baguha icyuryo nta kibazo
murakoze
icyo twashaka
ko nawe hafi umva genda komeza akazi
reka ngende
urabona udashaka kurengera
hari icyo mpfa nawe nicyo
none se wagize ngo uyu mwana ari hano gutya gusa nk'umukozi ku isoko ari ku isoko
mbwira nyine icyo washaka cyose aho wakiba hose n'inote
nini nyine bazi gupyeta kubera ya mibereho abaho itari myiza no kubyara abana benshi byamubereye ikibazo abura uko abagaburira arambwira ati rero umukobwa wanjye amajije gukura reba bya bikire bijya biza kunywera iwawe urebe ko ari cyo wamushyingira gipfa kuba kiguha inote gusa
wivuga byinshi rero nguhangaye tuguriranye nyine uko ubibona
ngo rero nawe wamubonye arasa neza mu isura inyuma wahabonye urumva
ni naho ushaka cyane wenda
ayo
300
ibihumbi 300
inyana y'ihene we
ibihumbi 300
nako inyana y'inka ariko ntacyo 200 ni impamo y'Imana
ariko se wowe
ndagushashura pe
200 ngo amarira iki ngewe
amaca ngahe
erega umenye ko bazi gupyeta rero nzamuha nanjye nkagira ayo nsaba
shagira vuba atagira undi w'umukiro uza agaparika ve wito ugasanga baramu
ndagukuraho 20 280
80
iriya ni imari isobanutse
imari iryoshye, imari isa kuriya, imari y'umutonore.
Kutagendana sheke we, umva nkubwire rero. Tubanze twikoze nkubikuriza amafaranga nyaguha. Ni mpamvu y'Imana ngwino.
280 urayamba.
N'inzoga turazinywa tugaruka.
Urayamba?
Ndayaguha rwose none angana.
280 urayamba.
Ako si waje nkayaguha.
Umva nkubwiza ukuri rero. Mwarabu.
Ndakumva.
Tugenda uyana.
N'izina ry'Imana. Ubuse turagenda ni moto.
Tugende.
Inzoga
280 ndayafata.
Ni impamo y'Imana. Ndayaguha pe. Ndayaguha ku izina ry'Imana noneho duciye bugufi. Ntacyo.
Ye narumiwe koko. Narumiwe pe. Uru rugo kurubamo mba numva ari ibintu bihanitse. Yewega. Mbega.
Ariko se mana yanjye kuko ubu ndabigenza ne kuko.
Yewe.
Ubu se ndahinguka kwa masenge meze gutya.
Ariko urinde wowe utinjira ukaguma kurwigirira inyuma y'inzu.
Tante.
No gutura ku muhanda n'akaga. Wajwigiriye ko hadakinze uzi winjira nkamenya uhuriwe.
Ubu se kuko uranyakira koko. Reba kuntu nabaye.
Mwana wa.
Ndumva mfite isoni zo kuza uri.
Woya humura ngwino umbwire. Mbega pucuri. Mwana wa niwe narindimo ntonganya. Ngwino wabaye iki mbese?
Tangahinda karangije.
Wabaye se iki mama?
Ndatwite.
Oya. Dore subizaho uri kuye. Muvandi
mbabari. Nicare ntago mfite imbaraga.
Icara umbwira umuntu wagukoreye agataro gacitse. Umunsobanurira. Urambwira ngo isobazi guteta ntaza kwica none akakurangiza. Umva.
Ndakwinginze ntabara.
Ngo byagenze bite?
Habaye ndabihera koko.
Ninde muntu waguteye? Urambwira ngo ndagufasha iki?
Uzi kuntu byagenze ntubiza abana ba mu rugo kuntu bangana. Ubwo rero papa yanyohereje kwa Karipoforo gushaka y'akazi. Mageze rero Karipoforo amuza n'umukire. Yajyagamo ibyo kurya ngashyira mu rugo. Arangije aranshuka mfata ku ngufu none yaneye inda.
Cyo gezaho. Ariko rero bivuze ko bazi gupyeta zarikora. Umuntu ageze ku rwego ngo agende umwana bamuha ibiryo byo kurya we bamutimbura inda. Barayigutimbuye nyine. Umva rero nkubwira. Ibyo umbwira byose ndabizi so tuvinda imwe ni musaza wanjye. Kugira ngo aguhitane. Ngewe iyo gahunda ndayigutunganiriza.
Ngo iki?
Inaha hose baranzi nyiragitariro. Ndagukoraho ryake. Ndayihubaturamo kugira ngo bakwice baguhitane.
Umva icyo narinje kukubwira rero ibyo utarabitekereza. Nyine bambwiye ko uyu muntu agiye kwa muganga. Bamufasha gukuramo inda. Iki gihe yayitewe afashwe ku ngufu. Nagira ngo umerekeze rero. Njye kwa muganga.
Nagira ngo umerekeze rero. Umva aho babera ubugoryi. Kwa muganga bagufasha iki? Ngewe ibyo ngibyo ndabigukorera pe. Ndaje nyikuremo. Ni wewe nyine se ndabambikoreye ugira ngo. Ina hose baranzi. Kicukiro yose, Kimironko, mu Busanza hose ngerayo.
Urayikuramo se gute? Urakoresha iki se?
Ngewe ndayikuramo da none se reka nkubwire. Umukobwa kwa Stefano singe wayikuyemo. Kwa Karagirwa singe wayikuyemo. Kwa Stefania kwa Margarita. N'ahandi kwa Kabano. Ngewe wazibakuyemo neza. Kandi ubu bari tayari baragenda bidegera.
Reka nkubwize ukuri. Ibintu bidakoreye kwa muganga sinabyizera.
Umva mbese.
Uribuka kansirida? Uzi ko na n'ubu kuva yashaka atarabona urubyaro kubera kuntu bamukuriyemo inda.
Ino murahinda.
Nukuri pe.
Ushatse none se reka nkubwire. Wa mukobwa wo kwa Makurata. Singe wayikuyemo nubwo nyine we buriya.
Akota uzika kiva kuva cyagiye.
Ariko ubwiki ko buriya ubwo abagome bamubwiriyeyo.
Oya rwose.
Ntago ibyanjye bigoye. Ndagenda shake hariya igiti cy'umwumbati. Nicyo nkoresha ubundi burundu.
Igiti cy'umwumbati.
Ukagashyira hariya.
Tareka nkubwiza ukuri. Reba Serafina yabuze urubyaro kubera ibintu bamukoreye. Urumva?
Ariko ubwabo nabaswa.
Reba Yosefina. Na nubu.
Ngewe gutinda mu bintu.
Yabuze urubyaro. Ese uribuka ko wa mwana wo kwa Karisa nawe yapfuye ngo cyo cyamwishe.
Abo ngabo ntago ari ngewe. Umva ro nkubwira. Aho kugira ngo ugume untinze.
Ndakumva.
Jya hariya mu gikari nze mbitunganye.
Ngo ngwiki?
Genda mitunganye.
Oya nago ndi tayari.
Kabiri gatatu mva imbere.
Wambara ukamerekeza kwa muganga.
Hoci tugende.
Kwa muganga ariko nta handi hantu najya atari kwa muganga.
Genda nyiguhuruturire mu bundi ureye kutaba mu ryerye. Pamujya muvana ubujishaho.
Niko bazi gupye. Niko bazi gupye tawe.
Ni seko.
Ndeka sha.
Ibintu seko ari bishaka wa mugabo.
Nakubwiye ngo nje byanze pe. Byanze burundu. Wumve ngo byanze.
Gutese.
Ahubwo se reka nkubwire. Wafashije rwose ukaniza ku mugore ko wanjye yabaye barafu neza. Yabaye barafu n'ubukonje gusa.
Ese uravuze ngo ubu nyine usigaye ugenda nkuri kugera muri Karabasaso.
Ntabyo zisha.
Ntacyo biri gutanga.
Handa gake Karabasaso. Nakubwiye ngo
ariko buriya barakurogeye.
Reka da.
Kintu.
Reka.
Sinanubaza.
Si binini yirwa miragura se shawo ngo atazabyara se byaje bikamugaga.
Si ibyo se mba nkubwira. Buriya ahantu uzabona ikinini hose mu rugo iwawe. Nigishaka kizabe kivura ubukene. Jugunya. Agore batwigiye ubwenge.
Ndakubwiye ngo binkozeho.
Kandi buriya
binkozeho pe.
Kandi buriya rero Karipofori.
Ndakumva bazi kubyara.
Agaciro k'umugabo rega no kubyara. Burya nuko abagore bagenda batwigaranzura iyo ubuze umwana nyine ubaye igicucu.
Cyakoza sha.
Bakura akavuga ati wese ufite utwana dutatu. Ariko burya umugore ugomba kumurinda. Ni gahunda ya leta nyine yo kurinda umugore guhorerwa. Abyara mu gihe cy'imibere ko mukubise ebyiri. Mu gihe cy'imvuga giti ngiye kuri centre de santé mukubite ebyiri. Hanyuma mashaka akagenda kamushiramo. Uko mwicupa wemye.
Cyabazi kupye. Ahubwo se numvishe ngo ari ukuntu bajya babigenza. Ngo bakagira gutya ngo bakishyiramo ngo agapira ngo hasi no hejuru ngo hasi cyangwa hejuru ngo gakora ibintu ari munange.
Buriya izo gahunda zo zirahari nanjye narazumvise. Nyine niba nyine wiyemeje kutabyara ushaka kujya nyine mu bandi bagabo batari seriye wabikora. Ariko noneho hari amakuru Tansira yeretse kumpa.
Nuko
Tansira yamaye amakuru mbere yuko bagenda kuriya yuko umuntu ngashobora gukoresha ahubwo nari ikiziriko. Ikiziriko ni ikigozi ni
igiki.
Arya ni igiki? Shenete? Ni urunigi. Nakubitamo urunigi. Urunigi ntabwo ndamenya ahantu barutereka. Ariko nyine ngo urunigi rwo ngo burya ngo ahantu ruhurira na system.
Ukora ibintu ari munange.
Ngo ukora wemye urimo wirya nk'uwenga igitoki cy'intuntu. Nta kibazo rwose.
Nkubaze urwo runigi ruzahora rufite amabara atukura rugira amasaro.
Niko numvise.
Atukura n'ay'umukara.
Tubara dutukura tw'umukara ku buryo
aho ngiye urwo runigi numva narwambara nkajya ndujyana mu bukwe pe.
Warutsa pe. Ariko rero kuvuga n'ugutaruka. Kuvuga n'ugutaruka ku mugani wa Mpyisi ng'umushefu kina mutama. Kunaguhaye umwana wanjye ukaba ntacyo umbwira ubu biragenda bite?
Ariko se umwana wawe wowe icyo urugero nkubwira iki se?
None se ubu sinakubwiye ngo nubona umugabo w'umukire uzampereza amafaranga bihwaniremo.
Ahubwo se inzoga umajije kunywa zingana iki? Ku buryo uwo mwana wawe hari ikintu cyaba kikirimo. Buri munsi uraza ugafata icupa, mu gitondo icupa, nimugoroba icupa. Uribwira ko umwana utamumazemo?
Asuga icupa rigura ngahe ku buryo nta ntara yamazemo. Bari kubwira Repafo. Byibuze basi n'ibihumbi 200.
Ibihumbi 200?
200 wijyanire.
Ariko byiki? Nimwonyumvira ngo ibihumbi 200 ra? Ibihumbi 200.
Ariko kare kanuza ukuntu kanduhije. Uzi ko buriya kiza na primaire kakayirangiza.
Umwana wawe usuzugura utegera abakire ngo abashe kubegera baganirize. Umwana wawe usuzugura ngo ibihumbi 200 ku mwana we. Ibihumbi 200.
Ntabwo ayoboka ntabwo yumva.
ntabwo yumva amatwi ye ndamubwira ngo yegere umukiriya ahubwo akamwitaza
ubwo nyine naba naratemesheje
cyokoze akamubwiza
okay ntacyo basima iry'itanu
oya ndaguha amafaranga 70,000 n'ubundi andi yose wayamazemo
ariko kari amafaranga wawe ubundi mu bibari mbabarira unyuzurize ijana basi
ariko se umva ngubwire bazi gupfa
wambara ukanyuzurize ijana
bazi gupfeta mubwize ukuri tubirangize neza ndaguha 80,000 Yego umenye kuko yaraje ararya
oya ntabwo nabyemera kare bufo nyuzurize 100,000 jewe ngende nkubwiye ko maribori mu kwihereye wirwarize nushaka nawe ujyemo
nimba utafashe 80 byihorere
kare bufo bazima 90
ni 80 ntabwo nyarenza naramugaburiye arisiga ry'inyama
okay urafite hano se
oya tugende nyaguye hari ikibazo
cyo tugende kuri banki ako ndiriye mu bari pe uriya mwana ukuntu ari inzobe hakuzi ko abana b'inzobe
inzobe isuzugura simaze iki
ako se ntushobora no kujya gutya ngugere nimuwe urebe ukuntu umuntu aba yaravunitse ari umwana ariko uzikorera umwana kugeza igihe abasha guterura icupa rya mitsingi ukuntu bivuna
ndakubwiye ngo jyanayo ako sungu jyanayo ngayo
bamabari basora jya izindi nzoga se base
uyu karugufatira imwe ariko utahira iryo ngiryo ryonye
ako se ngo rimwe wari nko kumva ngowe neza
mujyana
Karame
uraho neza
uraho
urakoze kuboneka umwanya w'abajyanama w'ubuzima ukuntu ubugoye
urabizi ukuntu tuba dufite akazi
none urabona tuje kwitabira inama yacu
yewe
kuko uyu munsi twebwe inaha nibwo tugira ya nama ya nimugoroba yo kwa kabiri
yego
ubu rero muri uyu mudugudu wa muntu we byaratugereye nakuraje nawe ubyiyumvire dufite abagabo aha dufite ibibazo by'ihohoterwa dufite umwana wakuyemo inda hari n'umugore uherutse gupfa uzi ko umugore we bazi gubyeta yapfuye yakuyemo inda warabyumvise
narabyumvise
umva reka tujye mu nama turabivugirayo mwiriwe abaturage mwe
mwiriwe
ni amahoro uraho yewe mwa
murebye ni amahoro
turebye tutarebye se
aha
koko niko ndabaza bazi gubyeta ari hano
yarahari
icara kari pofora ari
ndari muyobozi naje rwose ntabwo nyansiba inama abantu bose barabizi
ngaho tuza twakumvise tuza wa mugenzi wawe se ari he mwarabu niba ari mwarabu niba ari muzungu ari he mwarabu uri he
mwarabu nawe araho yaraciye ariko ari mukuzi
mu birombe
oya mwarabu nazi
uri he mwara
ariko yewe mana yanjye niho amakosa yose ava
ariko mwara ntabwo wari uzi ko hari inteko y'abaturage ngwino wicare hano ca hano
manigira amaboko
mwara icara ari he nyiragitariro arahari yaje mu nama
amenya aho arahari ariko ndahari
ntabwo ari wowe se
birashoboka ko mpari
ese kutitira wabaye
ufite ikihe kibazo
wirirwa ukuramo abana
malariya ariko ndahagira
ubabuza kujya kwa muganga
uramenye
umva mujyana urakoze kuboneka ubu rero dore ukwicaye iruhande yirirwa akuramo amada abantu ngo akoreshe ibiti by'imyumbati ngo agira gutereka sinakubwira kandi duhora tubivuga ngo abantu bajye bagira ibibazo bajye kwa muganga ariko yabuze abantu kujya kwa muganga
ngewe oya rwose
uyu mugabo bazi gubyeta wagurishije umwana ntabwo ari wowe wagurishije umwana mu kabari ntabwo ari wowe wagurishije umwana mu kabari
ese ntabwo uzi gusubiza
ntabwo ndi kukumva muyo
ariko ntacyo umuyobozi w'akagari n'ubundi agiye kuza ibi byose twabikoreye raporo kandi twarayibashyikirije agiye kuza ariko icyo nashakaga mujyana nagira ngo ubanze wongere usubiremo abaturage bo muri uyu mudugudu uburyo rwose umuntu utwite inda itateguwe
ariko jewe mwese nimunzi nako ndi umwerera
icara
none se agiye kuri n'umudiyakoni ibyo bintu murumva nabijyamo by'ibyaha
icara aha ntabwo ari mu kabari icara
ubwo rero na mwarabu nazi
mwarajya kwicara hariya cana umwanya ni uwanyu mujyana kugira ngo mutubwire nzi ko umwanya wanyu aba ari mutoya
ariko se koko tuvugishije ukuri oya icara umunyacyaha yirukanka ntawe umwirukankanyije koko ubu se
turabasaba gutuza
tuza gake tuza ngamundebere uyu mwana w'umukobwa mwagize murya ubu ntarimo aravirirana
yakomeretse se yo disi
icara dore ko amagambo yawe ari umunsi. Icara none se oya mbabarira
cyari twe mwibandaho kandi bose babizi.
Ariko rero
reka umuyobozi w'akagari agiye kugera hano buretse.
umuyobozi nawe.
Umuyobozi naza nawe ndamubwira ibi byose mukora. Niko nimumbwire. Ntago muzi ko iyo umuntu ahuye n'ikibazo yitabaza ubuyobozi. Abajyana mu buzima se tumaze iki? Koko. Ntiduturanye. Ntituba hafi aha. Ubu se ko twaje mu nama.
Inama igamije iki?
Icara.
Uzazire vuze.
Icara. Ntabwo muzi ngamundebera umwana w'umukobwa.
Ariko ikibazo umwana yanarembye nimumwamuretse nkamujyana kwa muganga ko arembye.
Wabuze kumujyana mbere umukuriramo inda. Ubu se ubuzima bwe.
Wagize ute? Ku izina ry'Imana.
Barimo kuvuga nuza ko yitabye Imana. Wabivanze. Yitabye Imana yarapfuye neza nyine.
Bari uratwite?
Oya ntago nwite papa.
Uratwite?
Ntago nwite papa. Ntago nwite papa.
Icara.
Ariko mbwira makuru y'umwana wanjye. Uyu mwana yabaye iki?
Nagira ngo wabwire uburyo yari kubigenza gute.
Muyobo ntabwo ibintu byakumvikana.
None icara bazi kuki. Icara ikibazo cyawe. Umuyobozi w'akagari agiye kugera aha. Ikibazo cyawe.
Ababyeyi be mwamufashe nabi. Yego. Mwabyaye abana bangana kuriya. Mwanze kuboneza urubyaro. Ahuye n'ikibazo. Nta nubwo mwigeze mumujyana kwa muganga. Koko.
Ntago ndwaye papa.
Umuyobozi muvugishe kuri telefone ko.
Ariko umuyobozi w'akagari
muvugishe.
None ageze aha umenyaye baho turi
muhamagare. Ariko wakicaye. Dore yahageze ya.
Umuyobozi yaje.
Nimutuze
twakira ariko kundya inzara wowe ubundi.
Nimutuze twakira umuyobozi. Muraho neza. Karibu.
Murakoze cyane.
Mwatambuka mukicara. Umuyobozi murakoze rero kuboneka muri iyi nteko y'abaturage hano mu mudugudu wa Bwiza.
Hagerera igihe rwose.
Twarimo tuganira ku tuntu n'utundi. Ariko nyine nkuko nagiye mbibabwira hano hagiye habonekamo ibibazo bitandukanye. Harimo abagabo ahangaha umwe yafashe umwana waramugurisha mu kabari. Amuhindura umukozi wo mu kabari yari atarageza imyaka aza guterwa inda. Bamwegereza nyirasenge ayikuramo nabi ngo niba yarakoresheje igiti hari simbizi. Namwe ibyo byose murabimenya. Ariko ubwo ntatinze nari nahamagaye n'umujyanama w'ubuzima ngo yongere mbese abibasubiriremo. Tugize amahirwe ko namwe muje rero umwanya no wanyu. Murakoze
cyane. Murakoze. Ndabashimiye mwese ko mwitabiriye iyi nama. Ni byiza cyane. Muri akagari kacu ka Rusogo uyu munsi aha twateraniye hari ibyo twifuza kugeraho. Aribyo nibyo twifuza kuganiraho. Ariko hari abantu nshaka kumenya ko uyu munsi bitabiriye. Twumvikane. Bazi gupyeta arahari.
Muyobo barongeye bakunteranyijeho.
Okay, urahari urakoze cyane.
Oya nagira
bawicaye gato nagira umenye ko hari. Karipo fori arahari.
Nditabira rwose bose barabizi. Nabasuje.
Ndahari rwose. Reka ndebe harundi nawe bambwiye. Wa nyira gitariro. Gitariro sinigeze kumubona.
Karame.
Ngo waraho urakoze cyane.
Ariko nari ntashye.
Mwarabu arahari. Mwarabu ni wowe? Urakoze cyane. Uyu munsi rero reka tube tuganira. Yego. Harya wowe ni Maribori?
Ningiye twa Maribori.
Yego.
Ariko ko wakomeje kurira ufite ikihe kibazo Maribo?
Mfite ikibazo kindemereye umutima ndumva ngiye gusandara. Ariko ndashima ubwo umuyobozi aje muze kumpa akanya mbabwire.
Tubwire nta kibazo. Reka tubanze twumve ibyo Maribori agiye gutubwira.
Bwana muyobozi ndabashimira ko sishanga wanditse koko. Rega ndabivuga nundi namaze gupfa. Bwana muyobozi uko ndebanga ndi umwana w'umukobwa w'imyaka 17. Papa wanjye nguyu no bitabazi gupyeta. Mama wanjye rero aherutse kwitaba Imana
mumube hafi mumwegere
azize yuko yabyaye imbyaro nyinshi, imbyaro ya nyuma niyo yamuhitanye. Muyobo uko ndeba nganda do papa yagize gutya arangurisha,
akagurirwa ikiziri kugera kuguje.
Ntago nabashije kwiga, anjyana gukora mu kabari kugira ngo bajye bamuha inzoga za buri munsi, anjyana gukora kwa Karikoforo.
Twumve neza Maribori.
Kwa Karikoforo rero mageze, uyu mugabo ni umugome mana yanjye, angurisha kwa Mwarabu nabizi, Mwarabu akajyamo ibiryo byo kujyana mu rugo, akagura umuceri, isukari, nkabitwara mu rugo. Umunsi umwe rero amamagaye ngiye kubifata, amfata ku ngufu.
Ibyo byarabaye. Mwe muretse mutuze, mwe mutuje. Mwe mutuje.
Ariko
sigaho.
abashinzwe umutekano bari hano.
Abashinzwe umutekano bari hano hafi.
Abashinzwe umutekano bari aha ngaha.
Mwe muretse.
Ntago ndarangiza. Nishake mitemfa.
Mwe hafi abagabo.
Muyabona nararangiza.
Komeza utubwire nta kibazo mama.
Agahinda mfite karakabije, nahemukiwe n'umuryango wanjye, mpemukirwa na papa wambyaye, mpemukirwa n'uyu mukecuru ngo ni shangazi. Shangazi yagize gutya ankuriramo inda akoresheje ibyatsi, none ngiye kumara ukwezi n'igice mva buri munsi nkaba nsaba ubutabera ngo ndebe uko nagera kwa muganga.
Tuza.
Muyobo ibisigaye ukora igishoboka cyose ndenganurwe, ndababaye.
Ticazwa ariko ubuse
Utuje.
n'umugore wawe ninjye wamwishe.
Ihangane. Iki kibazo rero reka bari cyo duheraho muri aka gari, murumva ko ari ikibazo gikomeye. Tubanze twihanganishe Maribori.
Nanjye munyihanganisha.
Turaje tuganire, ariko Maribori arihutirwa cyane. Batubiganireho. Umujyanama w'ubuzima waba warabaganirije ku bijyanye nuko serivisi zireba ibyinda bigenda muri iki gihugu?
Rwose narabaganirije uko nshoboye, na buriya wasanze ari byo turimo turaganira, kandi rwose nzi ko namwe mubizi kurushaho, nabo mwababwira kuko namwe mufite ijwi bakumva.
Urakoze cyane. Buretse katuganire. Umujyanama w'ubuzima rero yarabaganirije, ariko uyu munsi icyo twarimo tuganiraho, ndumva ingingo ya Maribori tugomba kuyiteza mu bibuze imbere, sibyo? Mwarabu Karikoforo bazi gubyeta mutuzi, sibyo?
Ariko ngiye nimutangirira vuba, ndi gutitira kandi nkwa imiti ya diabete.
Buretse arwara diabete, mujyanama w'ubuzima ujye ujyayo?
Shangazi arabeshya.
Noneho rero birababaje rero kuba dufite Maribori muri aka kagari kacu ka RSOG, akaba yarabaye gutya, kandi twese dufite umujyanama w'ubuzima dushobora kugana. Iyi nkuru irababaje kuba twaramuhohoteye muri aka kagari kacu, ibi byose biturutse ku baturage bagenzi bacu. Ariko rero Maribori, wenda nuko utabimenye, hari ibyo igihugu cyateganyije, icyo wemerewe. Buryo iyo umuntu yafashwe ku ngufu aba yemerewe kuba yajya kwa muganga akabagana bakamukuriramo inda aramutse abisabye. Ariko sinabo gusa, hari n'abandi bagera ku byiciro bine bemererwa n'igihugu ko ashobora kujyayo. Buretse tuganire. Abandi rero harimo nk'uwatewe inda atarageza imyaka 18. Ibyo mujyanama w'ubuzima ntiyabibabwiye koko? Karikoforo
Ntago ndayuzuza 18.
Nayo nturayuzuza. Urumva ko twamuhohoteye? Ni bande bamuhohoteye hano? Nibande? Ni iki kigabo buretse?
Ni Mwarabu.
Yego. Hanyuma rero abandi babyemerewe ni nk'ababyeyi bafite uburwayi ku buryo inda ishobora gutuma ibahitana, ubwo burwayi bubahitana baramutse batwite, cyangwa umwana akaba afite ibibazo mu nda. Tumaze kuvuga ibyiciro bingahe? 2. Ni 3. Wafashwe ku ngufu utaruza imyaka 18, umubyeyi ufite uburwayi bushobora gutuma inda yamuhitana, cyangwa umwana uri mu nda agapfiramo. Ibyo bindi byiciro 2 rero ni nk'uwasambanyijwe n'umuntu bafitanye isano.
Koko Mwarabu ni umugabo wa tanti.
Ni umugabo wa tanti. Nubwo atari kugira isanira cya kabiri, ariko n'ubundi yakoze amakosa mwarabu wasambanyije umwana
twapfana n'iyi mpyisi n'ukuntu isa
atarageza imyaka 18 ni amakosa ni satani noneho rero ikindi cyiciro ninde wagifora hano ninde wagifora niba mujyana mu buzima yarabiganirijeho koko
mutavuga si ubwo ngubwo umwe bwe mu
umuntu washyingiwe ku ngufu bakamushyingira ku ngufu uko numvise iki kibazo rero uko nabyumvise wafashwe ku ngufu se nawe baguteye inda aho icyo numvise nuko Maribori mwendaga kumushyingira ku ngufu ataruzi imyaka 18 anafatwa ku ngufu ibyo byose ni ibituma tugomba guhamagara inzego z'umutekano hano wowe bazi gubyeta mwarabu na karipofori mutubwire ibyo mwakoze musabe n'aba baturage bandi imbabazi kandi turahamagara n'inzego z'umutekano
umutekano se nanone n'umutekano se
yego
ngewe ndarwaye
murajyahe mufate abashinzwe umutekano bari warugiye he garuka uraza kunyara tugeze
kandi ngewe mumfashe nabi nkapfa mwandika
hanyuma rero kaduhere kuri mwarabu tubwire
muyobo
pfa murandika
rwose ubwo kabyarawe ikintu cya mbere nk'umuturage wenda washutswe ni mu mbabarenge nijyane kuri polisi yo kugira ngo murushye pandagare itanywa esase nyinshi baza kudutwara njye muransangayo
kandi mujyana
nayumvise no kuri kwimana
abashinzwe umutekano
kandi murakoze kumbabarira
turabajyana ku kagari ubundi dukurikize ubutabera ubundi tugiye kujyana Maribori kwa muganga nawe tumufashe nk'inzego zibisaba tumujyane ku kagari
kandi ni munwara nabi nkapfa murandika
tugende ku kagari
That was great. What did everyone think about that? Give me a wave if you enjoyed it. I hope people were translating in the room. I know there's a few people that didn't understand. Were you? I hope so. Anyways, let's move on to the next panel discussion. I shall wait a few minutes for Dr. Polyfiel, but I'll just be calling the panelists up to stage. So in line with this sketch, we're going to be having a panel discussion on SRH. It'll be adolescent sexual reproductive health, rights, and policy. The panelists are Dr. Rukundo Atanas, Dr. Melissa Tom, Ms. Evangeline, and Dr. Maganda John. Please may you welcome them to the stage. Give them a round of applause. May you grab Dr. Polyfiel, please? Thank you. Maybe we can just touch on the sketch. As we're talking about SRHR rights and policy, I think it's good for us. Oh, great, Dr. Polyfiel, police officer. Welcome. So let's welcome our moderator, Dr. Polyfiel, to the stage. Give him a round of applause, please. Okay, no problem. Yes, you can. You can take this microphone. Okay.
Thank you so much. I'm very happy to moderate this, this panel. And I'm happy also to introduce my team here. You know all of them. Each one will introduce themselves, who he was playing and who he really is in real life.
Thank you. Wakivuga mu cyongereza kugira bigaragare neza ra? Thank you so much. I'm Prevalence Wiseng. I was playing as Bazigu Pieta, the husband of Dansila, and the father to Mimi. I mean, to Maribori. Thank you so much. Nyuma busanzwe nkaba nyina filime Rukundo rw'inzitane nka Rugero ndetse ngakina n'abamenya nka manager w'Uruganda. Murakoze cyane.
Muraho. Amazina nitwa Bezere Kadi nkaba nkinye ahangaha ndi Nyiragitariro ndi umumama udashobotse nyine ukurama abana inda kandi bitemewe. Mumbabarire. Mu buzima busanzwe nkina ndi Esther muri Seburikoko nkakina ndi NG Tari muri Papa Sava. Mwibare kuza.
Muraho. Amazina y'ababyeyi nitwa Ingabire Marthe Mimi nakinnye hano nitwa Maribori umwana utujuje imyaka abagabo muduhohotera mwatubabariye. Ubusanzwe nkina nitwa Maribori muri Musekeweye. Murakoze.
Muraho. Amazina yanjye nitwa Niyo Yitaramazani nakinnye ndi Karipafori muri uyu mukino ngurisha abana ndetse bakanayanywera agashiramo. Byarangiye mutangiye 80 ariko siko bimeze bwa buryo bwo kwigisha. Sanzwe ndi umukinnyi w'amakinamico yo mu ruhame n'amafilime muri Papa Sava nkina nitwa Ramazani njyana na Ndimbati ku ishuri. Murakoze.
Muraho neza. Nitwa Emma Uwera ndi admin assistant wa RSOG. Nakinnye ndi umujyanama w'ubuzima ariko mu buzima busanzwe si ubwa mbere nkinnye. Hari filime nakinaga yacaga kuri televiziyo Rwanda nakinaga ndi Nicole 2008 ndi umunyeshuri. Murakoze.
Muraho. Mwanyikirije nk'umubyeyi. Muraho. Nitwa Tina Nyirinkindi ndi umukinnyi w'amakinamico atandukanye aca ku maradiyo n'amafilime. Hanyuma rero nkaba nkina muri Papa Sava nitwa Margarita umugore wa Ndimbati. Murakoze.
Haleluya. Haleluya. Mumere Imana icyubahiro ndafunguwe. Ariko nagororotse ntabwo nkiri mwarabu wa wundi. Murakoze cyane. Nitwa Jean Pierre Gasasira. Abakunzi ba filime nyarwanda ni Kigufuri cyangwa Rukanene. Imana ibahe umugisha.
Let's give them another round of applause, please. Thank you so much. Dr. Polyphilo, would you like to introduce yourself?
Thank you so much. I played in this scene as Rugero, the executive secretary of the cell. In real life, my name is Polyphilo Ndihenyurwa. I'm an obstetrician gynecologist, a family planning subspecialist, and I'm here as the moderator of this session as well. Thank you so much for being here with us. And what we are going to discuss in this session is about adolescence. As you saw in the scene, this was a teenage who was impregnated, and she was allowed safe and legal abortion by the national policy, but unfortunately, due to lack of information, she ended up having an unsafe one. And also, the family planning services that were not used by her mother resulted into a maternal death. Today, I would like to ask Tom Umulisa, what legal and policy gaps still exist in protecting adolescent SRH, for example, around confidentiality, consent to services, or protection from exploitation?
Thank you very much. I think I don't have much to say because you've seen through the sketch, you can see, I don't think we have much with the gaps in law. neither do we have much in the gaps in policy, because I think region-wise, in this region, I think we seem to be ahead than any other East African country in terms of law and policy on SHR. But I think what should be given emphasis is the awareness of the existing law and policy. I think through the sketch, and I think this is the practice in our, especially the rural areas, as the research has indicated, people know less about the existing legal and policy framework. They know less about the conditions that are allowed for abortion. Very few know. That is one. Another thing, I think, one of the recent research was also attitude of service providers, which should have come. If I could have met the people with a sketch, I would have told them to bring in something indicating some attitudes of service providers within either district or health centers, which is also an impediment. But also, I think they need also awareness. I think with regard to the policy and law that we have, what we need more is how do the citizens, especially in the rural areas, know about the existing legal frameworks, know where to access the services, and then also more training also and awareness to the service providers. Thank you.
Thank you so much. And I will take the next question to Evangeline Dushimeyezu. From the perspective of NGOs working on the grounds, what are the biggest barriers adolescents themselves report when trying to access SRH services, and how are you addressing them?
Thank you very much for this opportunity. I should first thank RSOG for being a long partner for our organization for many years. So adolescents face several barriers. We can classify those barriers at different levels. There is individual level partners. Adolescents have fear and they feel embarrassed to seek services. There are myths around service, contraception, STI, safe abortion. Most myths are related to the culture and the religious barriers. We have also the lack of knowledge, particularly for those adolescents from the rural areas, because they don't access the digital tool which most provide information. There are also barriers at the social and cultural level. I can talk about the stigma, because in our culture, it's very strange to have an adolescent girl seeking, doing sexuality. There is gender norms. As we know, girls are expected to be passive and not be involved in sexuality, while men, boys, face pressure for being sexuality dominant. We also have social and cultural barriers. These also impact our providers. They are not very welcoming. They have also that level of being stigmatizing those adolescents. As we know, babita ibirara, bananiranye. So while welcoming them, they are not very welcoming at the health facility. If we talk about barriers at the facility level, even if our health facility have those youth corner, but really they are not very well organized or very welcoming. So first of all, they are not youth friendly. They work on hours where adolescents are at school. They are not very attractive for youth. Some they have infrastructures, they have those decoration, but really providers are not well trained to provide the adolescent-centered services. So when we go to the community level, youth-friendly services are not very adapted or accessible at community level, particularly for those vulnerable group of in rural areas. If we talk about community health workers, they are not well trained, they are not friendly for those adolescents. So if we know every woman who is pregnant, adult woman is very comfortable to go to a community health workers, but for adolescents, they are not really comfortable. Yeah, I think.
Thank you so much. You touched the very important part of adolescents that as someone from NGO and who's working on the ground, that takes me to the clinical perspective of SRH for adolescents. Dr. John, in your clinical practice, what are the common SRHR needs you see among adolescents when we look in the lens of the clinical service delivery, and also as someone who is from the Rwanda Society of OBGYN, what do you see as the needs?
Thank you. This is a very interesting question. As a provider, really an adolescent, when he comes at our office in consultation, he needs to meet a counselor. So as a provider, we need really to be counselor. Whenever we want to talk about, whenever there is a case of unwanted pregnancy, need of family planning, how to prevent STI, really we need to be counselor and do it as a counselor. Counseling has principles. We can't just say as we are a healthcare provider, automatically we are counselors. No, there is principles. So we have really, we need to allocate enough time for counseling. Sometimes, let's take an example of an adolescent who has an unwanted pregnancy. According to the settings where you work, sometimes you are not able to provide a full package of abortion services. But if you perform counseling properly, really you give solution to the problem to the adolescent at more than 50%. Because counseling is very, very, very important. So as healthcare providers, we need to be really counselors. And I think before doing that counseling, according to abortion services, we need, there is something we call VCAT, value clarification and attitude transformation. Ourselves, the way we understand abortion, we need really to change our attitude against toward abortion before being able to do a proper counseling. So I insist very much to that aspect, and I know we have knowledge, we know what to do, but if you don't give time to counseling, sometimes it cannot work very well. Thank you.
Thank you so much. That's really inspiring. And I would like to take this to the policy level, to Dr. Atnas from the Ministry of Health. It is true that comprehensive sexuality education and mental health and prevention of gender-based violence are key pillars and the foundations in empowering adolescent SRH. From the Ministry of Health level, what is the broader vision for adolescent SRH beyond just family planning?
Yeah, thank you so much. Yeah, maybe I would be straight to the, to the answer. When you look at how the policy and legal framework has been changing over time. The goal has been to expand access to not only sexual reproductive health services, but also to expanding access to, any adolescent health related services, including these ones, prevention of GBV, or even response, expanding access to mental health services. So the broader vision we have for everyone, it's really like a country where everyone has access, especially these adolescents, have access to these essential services, and not only essential, even specialized one. Like I think the previous session was discussing about issues around fertility. So we want to make sure that everyone has access to these services. And one of the approaches we have used is one to revise the legal and policy framework, of course in partnership with different stakeholders in the loom. Currently, I would say, like Dr. Tom was saying, currently I would say there's no legal, in terms of laws, there's no legal barrier you would really present as an issue that would prevent either providers or adolescents to accessing services. So the rest is really working on the remaining aspect. Second, what we are doing as part of expanding this access to services, especially sexual reproductive health services, Evangelina was talking about youth-friendly centers that we have across the country, youth corners across all our health centers, but they are not friendly as we wish. So we are working to expand access, not only by training healthcare providers, but also giving them the right tools they need, giving the right tools to adolescents to access these services, not only in health facilities, but even outside, through different platforms. There are different digital technologies that are being developed to expand services. We are also doing a lot of engagements with different concerned partners, especially parents, religious leaders. All of those, they are very key in making sure that we expand this access, trying to address these software issues instead of maybe the hard infrastructures that you would really see. So for us, our goal is, or the vision is really to make sure that wherever everyone can go, these adolescents, wherever they can go across the country, they can access services. And in addition, I would say that whatever service you design, we have to make sure that, we are designing them with these adolescents. You can, when you see how we have expanded access to these services in terms of maybe physical infrastructure, each health center has a youth corner. Each district has a minimum of one youth center where they can, not only play, but also have services. But how many adolescents are going, in these facilities? So the issue of stigma, the cultural barriers we have been talking about, this is the work that we need to partner with everyone in the loom to see how we can address it. Yeah, maybe I can summarize.
Thank you. Thank you so much. And I think everybody in this room agrees that the Ministry of Health, when they say they keep expanding and working on a policy that enable adolescents and the Rwanda community in general, I think everybody in this room agrees that we have witnessed, significant changes in the past few years, looking at the change in the abortion policy in the end of 2014 that allows health centers to also provide safe abortion, and looking at the recent passed bill that allows family planning access without legal, without parental or guardian consent from the age of 15. That's a huge milestone. Thank you so much. And you cannot achieve any further without really surviving the adolescence period. Tom, if you were to request to the Ministry of Health one more policy to change, what would it be?
Thank you very much. I think I've been in touch with Dr. Tanaz for the last 3-4 years around this work. But I think the draft bill, the way it is right now, that has been approved by Parliament, of course, that is allowing access to, from 15-year-old to access services. I think the bill, the way it is, we don't have much to seek, but still, the bill will need some guidelines on some of the provisions. The bill that we are talking about that has been recently approved by Parliament, we need some guidelines for implementation. Yesterday, I attended a meeting with the persons with disabilities who were trying to look through the bill, the persons with disabilities, and we are looking at all disabilities, not only mental, we are talking about the deaf, the blind. They were looking at the bill and asking themselves, how will this bill respond to our needs, and how our health workers and our health centers, what facilities do they have to be able to respond to the needs of persons with disabilities. This is something that we may continue the discussion about, but with regard to the upcoming guidelines. Because while like the Ministry of Health, our Ministry of Health is very proactive. Sometimes the ministry moves ahead, even legislators, because there is when we had guidelines for abortion, even when the law was not allowing abortion, providing weeks. So the ministry is always proactive, and I think this is something that may be looked at while looking at the guidelines. Another thing was something we are engaging the institutions, but that is with regard to the law relating to data and privacy. Because if we are talking about digitalizing, if we are talking about e-health, then we are talking about confidentiality and we are talking about privacy. These are important issues because we have a concoction of laws. We have the National Cyber Strategy Policy, we have the National Cyber Security Law, we have an ICT law, and the bill that is bringing together health services provides some important provisions on digital service provision. So this is an area still that issues to do with confidentiality, issues to do with the privacy, to the service providers, and also provision of services at the health centers will be an important. But I don't want to jump the gun. I just believe that since the bill is providing for that, then I think we are going to have more time to discuss about the implementation of the bill and also the necessary guidelines that are going to help in the implementation. Thank you.
Thank you. From the clinical perspective, in one line, if you were given a chance to change, to request a policy change or a legal change in the abortion, in the adolescent SRH, in one line, what would it be?
Personally, really, I am satisfied of what we have now. But the only request I have, it is to implement already what we have. I can take an example of the last amendment we had last year in November, where we have been allowed to provide a full package of abortion services in health centers and clinics, private clinics. So perhaps Dr. Tanaz will tell us, should I write to Dr. Tanaz to have permission to start providing a full package of abortion services in my clinic? That is the question. Otherwise, I am satisfied.
Thank you so much. It's really satisfying, the policy we have and the journey, the road we are walking all together. And Evangeline, one policy or one law, if you were given a chance to change it, what would it be?
I think I should talk about at the facility level. We need to offer integrated comprehensive services at one point. So to have those youth-friendly corner operational and ensure that all services adolescents need are offered at one point, because the current situation is that even if some are welcomed at the youth corner, but they are obliged to go, like if an adolescent is pregnant, then she has to go to the antenatal care line with the mother, the aunties, and also if you look at regulation related to GBV service provision, safe abortion service provision, for example, at the health center level, we are not able to provide services to adolescents. They are obliged to go to be transferred to the hospital for GBV services, the Isango One-Stop Center, and that refer is a big barrier for adolescents who are not well supported by their parents, who have also the financial barrier, because an adolescent, if she didn't talk to her parents, then she will not get a ticket to go to the hospital. So if we are able really to decentralize services at the health center level and offer all needed services at one point.
Thank you so much. It's mostly about implementation of what you already have. That means the Ministry of Health has already done really a great job. And the last question for this panel is go to Atanas, summarizing the questions from the panelists. Where should we go? Who to call? And what's the process to have health centers implementing the new policy?
Yeah, thank you so much. I would again try to summarize, because they already gave the context. And I'm happy that we are all aligned. It used to be the time where maybe the policymaker and other key actors, clinicians, NGOs are speaking different languages. But all we did when we worked on these policies, we have been working with all concerned partners, but also the concerned individuals, general population, adolescent, and that's why the legal reforms that have been happening, they are reflecting, the views or the needs of the general public, and that's a very, it's a very big step that we are very happy for. The only highlight I wanted to make, I know sometimes in the media, people have been trying to equate the new law, the one that was passed by the parliament, with kind of an SRH bill which is trying to allow adolescents to access contraceptives. But the law is really very big. It covers everything we do in the health sector, and probably something we also do for the entire sector in general, not with the clinical service. One of the key highlights is that it has helped us to bring together all fragmented laws. We had the human reproductive health law, the medical liability insurance, the art of healing. All of these laws have been combined into one law, and we are no longer going to have them once it's promulgated, maybe in the near future. It has also brought, articles around digital health regulation. What Dr. Tom was talking about, using digital technologies, different, health applications or telemedicine, all of that were not really well regulated. But in the new law, we have provisions providing for that. The previous panel was discussing assisted reproductive technology, especially infertility, part of it. Again, in this new law, we have expanded articles. Previously, there was a gap regarding assisted reproductive technology related services, so the new law is also providing guidance on that. It has also, talked about mental health and actually catering for the needs of persons with disability that they were saying. So there's no gap really that they're going to face for persons with disability. The law caters for everyone. It's also talked about what you mentioned, privacy. It's patient's right. Whatever you do, you have to maintain the confidentiality, the privacy. Whatever you do, the patient has to consent for it. So it's also empowering or even considering the voice of the clients. Also professionalizing the profession, enforcing the standards. So I would say that there is no gap that we see currently in terms of the laws. For the guidelines, again, when we develop these guidelines, it's only waiting for the law to be, finalized, the final steps for approvals for this law. Once it's approved, so the guidelines will be guided by the legal provisions that will, happen, or that will be gazetted. Something else that you talked about, yes, once you have, like, no matter what progressive legal and policy framework you could have in place, it does not really mean that the law is being, the service is being accessed. We know some countries where the law is very progressive than any other law you would think about. But in terms of access, they rank like last. I do not want to mention countries, but we do have countries that have the best laws, but access to services, it's almost non-existent. So it's our time to now work together to see what can the society do, what can the NGOs do, what can the clinicians do, to make sure that these services are accessible to everyone. Even if you put a guideline, but the provider is not progressive to provide the service, nothing will be done. For the decentralization of services, yes, in the decentralization, there is even a law actually. It's not a request or a favor we are giving, it's an obligation we have to decentralize services. But when you decentralize, you also have to look at the capacity of, the providers, the equipment you are giving them, like the skills and competencies they have. So we decentralize again depending on what we are giving them. But most of the services around GBV, SRH, they are decentralized, including this one. For the provision of safe abortion by health centers or comprehensive abortion care, for a health center that has all the necessary tools, via telemedicine with assistance of the medical doctor at any health facility, you can always assist them. It's not a nurse decision to prescribe, so the prescription will still be done by a medical doctor, but the access can take place at the health center. For a private clinic that is allowed, again, it's the same process. It's like any other service that you request. There is a set of standards and guidelines you have to follow. There are guidelines by Rwanda Biomedical Center. So it sets the standards. When you request for the service, we just look at, the requirements. Do you have the right medical doctors? Do you have the right equipment? Do they have the right training? Do you have the right infrastructure to provide the service? Of course, you cannot allow this service in any health facility. Once you fulfill that, there's an online portal where you apply, like you apply for any other, when you apply for the license or any other service to be added to the license, it's similar. There's no standalone ways of doing it. So it's already integrated. If you want to provide it, you just go online, you apply, then you approve the service after inspecting your facility and making sure that you meet the standards. Thank you.
Thank you so much. Thank you so much for putting light on that. And I'd like to thank this panel. Please, a round of applause to our panelists. And we can join our seat again. Thank you so much.
Let's give them another round of applause, please. Great, thank you. So next we're going to have a state-of-art lecture, What's New Menopause, from Dr. Aline Mukunda. Please welcome her up to the stage. This is also another topic, another taboo topic in Rwanda, so it's great to hear from Dr. Aline.
afternoon. One second. I'm here to share with you, or actually to ignite a conversation. The title is What's New, but menopause is not new, is it? It has always existed. But maybe what's new is we are talking about it. This may be the first time, the first conference in Rwanda where we talk about it. So why is it interesting now? Why should we talk about it? So do I have, yes? Do I control the screen? Okay. 1 second, we'll get there. Thank you. So the subject is interesting now because the past few decades, the world population grows older. We all agree. And thanks to economic development, thanks to development in science, especially in health, people will live longer. And when they live longer, especially only women, they will go through it. They will go through the menopause transition. And back home, the last census told us we have over 1 million of women between the age of 40 and 64. Later on, you'll understand why I talk about that bracket. From yesterday to today, we talk about equity, right? We talk about quality of life. We talk about how could we improve women's health. It becomes a public health issue because the UN, the World Health Organizations, everyone wants to have, if we live longer, we should live healthier. It's not only about living longer, it's living with happy, and everyone gets health, no one is left behind. So if I start with just definitions, the menopause is defined as one day, a single day in life, where a woman realizes it's been 12 months since her last period. So for some in the literature, it's a single day. The menopause is a single day. Before that, it would be perimenopause. After that, it will be postmenopause. But it depends on the languages. Some will call it she's menopausal or she's postmenopausal. But before that day happens, she will go through 2 to 4 years of her life where she will experience changes, sometimes suspecting, sometimes not knowing, but this will be happening. If we talk about the natural menopause, what happens naturally because the human body, the ovaries and ovocytes will grow, we have a big bracket, 45 to 55 years, that's quite 10 years, and you clinicians will understand it's a decade to navigate when you receive the women. Some get their menopause late, as far as 55, and some early as 40 or 45. Hence the bracket I gave you earlier on the previous slide of 40 to 64. Where we count over 1 million of women, Rwandan women. The symptoms will come incrementally. They won't start all at the same time, but most of the symptoms will be seen around 50, 51 years old. And one of the signs women will complain about or they will share in their testimonies, it will mostly be what happened during perimenopause. And the most handicapping, if I can say, was heavy bleeding. And some of them said, I could no longer attend wedding. I could not go to a burial. She will not share with you. She will not tell anyone. But she bleeds so much, it's difficult for her to control. Some will go to the hospital or health center for anemia. or to try to control the bleeding. But in most of the times, she will not come. She will manage it. The heavy bleeding will be 2 to 3 days, and then she will live with it. And mind you, most of them, at least in the Rwandan community, at this stage, they are not having kids anymore. And they will say, why should I go see a man gynecologist? Why should I go get naked again when I'm not even expecting a child? Please keep this in mind. It's about herself and maybe the society we live in, diminishing her worth and her reasons to go seek care. For her, she will go see a gynecologist for the baby to come, not for herself. Now, I'm talking about the women, but who's concerned actually? Everyone in the room is concerned. Believe me, if you are under 30, and even if you are a man, maybe your mother is going through it. And you don't know, she will not tell you. But you will experience it. Because your sweet mother, the one who you used to go to for comfort, for advice, for when things are not going well in your life, there are days she's still there, she's still comforting, but there are days where she will snap at you because of the level of irritability she has that day. And you won't understand. Or the relationship will become you taking care of her more than you used to. She's lucky she has a medical doctor or son or daughter, but then she doesn't know that migraine that is constant, that fever, what she calls fever, may not be malaria. And you'll be, as a good son, as a good daughter, taking her to the hospital every now and then without really realizing what is going on. If you are over 30, 35, 45, it may not be you, but your wife. What is she going through? Why is she irritable? Why is she getting weight and she's pretending to be on diet? Is she hiding the mandazis in her bag? No. She's getting weight, she's gaining weight, and herself, she may not know why. Of course, you gynecologists in the room, you are concerned because in most cases, you will be the first person they will go to see. In most cases because of the bleeding, but also because of gynecological signs. And once again, I wanted to share with you a testimony because of the variety of symptoms that do happen. A mother said, no one is telling us what is going on. That's how lost she felt. Because she's sweating, she's getting weight, she's overbleeding, she doesn't know what's going on, she doesn't know where to go. So it will always happen, if you are a woman, it will always happen naturally. Hormone will change because your ovaries are growing, and I was going to say the problem, but the difficulty here is the time that can take that menopause transition. Imagine your mother or your wife or your sister spending 8 years with troublesome symptoms. That's not easy to handle. It won't be easy for her. It won't be easy for yourself. Do we agree? Do we agree? If we agree, the quality of life, her quality of life, your quality of life will take a toll. Her productivity, as someone who goes to the hospital every now and then, will make the productivity go down. So if she's in a private sector, she may be seen as that one woman who's never there, who doesn't deliver as she's supposed to, and the male colleagues will see her as someone who always keeps them behind, right? Or the younger ones, or those who are past that transition. but it also has the social impact. Many will share that they feel like they are losing their worth in the society. As I mentioned earlier, she doesn't feel she still has the right to go seek care, especially when it's about gynecological issues, since she's not having a baby. She's heavy bleeding, so she won't attend social events when we all know that is something everyone needs, that is very fulfilling. There can be induced menopause, especially when there is total hysterectomy. And my question here would be for the clinician, when you do a total hysterectomy for young women, do you check on the age? Do you check if she was menopausal already or not? If so, do you have treatment that will accompany the hysterectomy? When it's surgical, the symptoms will be abrupt and will be more intense. The menopause could also be induced by chemotherapy in younger women, but in this case, there are chances that when treatment stops, she gets back to herself. So symptoms. Symptoms, if you go to literature, you can get more than 30 of them. And I didn't write down the 30 symptoms. And just to bring up that it can be a lot, and it varies depending on the person. The most frequent, you will be in a room like this. The AC is on. Everyone is comfortable. Some of the men are in their suits, but there is a woman who's always, right, trying to get the heat down. And when I talk about social impact, she will feel that, okay, everyone is looking at her sideways, and she doesn't know why. I mean, she knows, but she doesn't want that eye. Another frequent symptom will be night sweats, sleep-related symptoms, when she cannot stand the cover because she's sweating, but at 30 minutes, an hour later, she's throwing away, she's shivering. So it will be shivering and sweating, shivering, sweating. The quality of sleep will go down, and the husband will be grumpy because she's disturbing him. Migraine, I mentioned it. The memory loss and foggy brain, the people who will be collateral damages will mostly be the kids or the house helper, because the mother will call the kids to please go grab this for me. By the time the kid gets to her, she doesn't know why she called him. And the kid will be upset, or the house helper will say, okay, say, my mabuja is going nuts. Weight gain. Weight gain, okay, around waist and on the shoulders. The body shape is changing. Mr. Husband is not happy with the way she looks. So I'm given 1 minute, so I will skip or go faster. Since we are in a conference of gynecologists, talk about the intimate disorder, but also mention the psychological disorder. One of our colleagues was sharing with me that he has 2 experiences of one woman who was almost suicidal because of her hormones were not balanced, and another couple who divorced due to that, but in the end got back together. So I will skip the symptoms, but there is one that is funny, the tingling and numbness. And this is another testimony where the woman said, I would feel like ants crawling under my feet or on her arms. First thinking it's malaria because she's sweating at night, sometimes she's shivering, and then she feels ant on her skin and thinks it's malaria symptoms. The differences will depend on the history. It could be genetical, but for someone who, for example, has a history of obesity, or they may experience diabetes, during this episode. Those who have already had mental problems, for example, postpartum, the blues, may experience heavier mental symptoms. A positive aspect is about lifestyle is athletes experience less and less symptoms during this phase. So mothers or women in the room, please do exercise. Now, the problem again, what they say is, whom should we see? When it's dyspareunia, when it's heavy bleeding, sometimes they will think it's the IUD they do have, and they don't know whom to see. Should they see the nutritionist because of the weight gain? Some will have a fracture due to loss of bone density, and some will go see a traditional healer for vaginal dryness because she understands what's going on, and she doesn't understand why she's having trouble with intimacy. The husband is complaining. She doesn't know this is a sign to take to the doctor. So the diagnosis will be more clinical, even if a lab can be performed, and management and treatment will be based on symptoms. There are different ways people do manage the menopause transition. Let me start with the HRT, even if it comes in the third place. There are rumors or worries, let me not say rumors, about the use of HRT. Some would say there are articles relating HRT and breast cancer, but there are studies that show you should be careful only after breast cancer that is estrogen specific. Women use natural remedies. They talk about seeds, especially nutritionists. They will advise to take seeds, pumpkin seeds, chia seeds, flax seeds, to drink a lot ichivuguto, yogurt, soya, and for others, these supplements do help. I mention them specifically because we have testimonies of women who took omega-3 or omega-3, 6, and 9, and the brain fog and the memory loss went away. Others who used magnesium and the ants under the skin disappeared. Others who used the calcium, this is not advertising or anything, I'm just reporting testimonies. The calcium for muscle and joint pain. So why this conversation? I believe it's important because we are here with the RSOG mission, we want to transform women's life. We talk about equity, and we are here to advocate for that portion of our population, that over 1 million women who are going through it, who are still young, they are 45, they are still productive, and they may still need 20, 15 years working, active members of the society, and them feeling good with a good quality of life, everyone will benefit because they will stay productive. I believe we need to raise community awareness so that even Mucharo, like far from Kigali, women know that they still have the right to positive, intimate life with their partners, and for themselves to still feel good and be productive. Under RSOG, we are trying to conduct a study, an assessment of what is happening in clinical settings. Do women come with menopausal signs? In OPD, do you see them? when you see them, what do you give them? What is the management? If someone goes in any clinic, any hospital, and asks to see the charts, is it going to be possible to identify what was presented by the patient? And are we going to see a standardized way across the country of managing menopausal transitions? I hope the Minister of Health is still here, because my last message would be for the MCCH. Don't we need to have a guide to support clinicians on how to manage our sisters, our mothers, our wives, our best friends? Thank you.
That was great. Thank you so much, Dr. Aline. We'd like to take one question. I know we're short of time, so it'd be great if someone here could ask a question, and then we can round up and go to the next. Yes?
Thank you so much. My question is, why are these ladies who are approaching menopause or who are in menopause, why do they have tendency to bleed a lot? Yes, yet the hormonal levels are like going down, especially those hormones that are responsible for prevention of menopause. My question, why are they exposed to bleeding?
Yes, thank you. What happens with menopause is when the ovaries, the lady grows old, usually every month an egg is released, right? And you know it's estrogen and progesterone balance. And after that, if she's not pregnant, she will have her period, right? And when this phase is happening, there is disturbance in production or release of the egg. There is an imbalance between the amount of estrogen that is produced, and there is thickness of there is an imbalance between the LH and the estrogen. The endometrium gets thicker than it's supposed to be, and that's where the blood comes from. You understand? And that's why it informs when they are proposing hormonal therapy. I went fast on that slide because it will depend on who the person is. If she has undergone hysterectomy, she can be given estrogen only because it tends to thicken the endometrium. If she's still younger or she still has her uterus, the proposition is to give her estrogen and progesterone together. So where the blood comes from, it comes from the endometrium.
Thank you. Thank you so much, Dr. Sorry, we can't have. Yes, thank you. Thank you, Dr. Aline. Let's give her a round of applause. So next up is our sixth oral abstract presenter, Dr. Tenjira Olive. May you please come up. He'll be speaking on exploring perceptions about enablers of women's attendance and adherence to the recommended antenatal care visits in Rwanda, a qualitative study. Please, may you come up to the stage. Let's give her a round of applause.
Good afternoon. I'm Olive Tengera. I'm a midwife. working at University of Rwanda. Don't see my presentation. The screen is not coming here. Do we help to have presentation here? Meanwhile, I present this like dissemination of published paper, and I recognize my research team members. This one? Down. But I was thinking this one will show. Yeah, meanwhile, I can recognize my research team members and supervisors. This is one of the paper published from PhD thesis, and I recognize Prof. Stephen Lisa, Letitia, Pamela, Emable, and Jocelyn. These are co-authors of our publication. As background, I can say that, let me try to see there, but it is far. Yeah, it is coming, thank you. Yeah, antenatal care helps to ensure the best health condition of the mother and fetus during pregnancy, and achieving optimal ENC attendance and adherence to the World Health Organization recommendation remains a global challenge with the significant disparities in ENC attendance. An average of 8 contacts are recommended by 2016 WHO ENC model, and however, it can be challenging to meet this recommendation as WHO doubled the number from the previous 4 visits. Lola and the colleagues conducted a study of a range of 48.1 in low-income countries and 84.8% in high-income countries. Even in sub-Saharan Africa, we have 38% of pregnant women who initiated their ENC in their first visit. In East African countries, we have the prevalence of first trimester ENC contact of 35.2%, and in Rwanda we had less than 47% of pregnant women who attended at least 4 visits according to DHS report 2020. And this study came to explore or investigate the pregnant women perspective on the context-specific enablers to their attendance and adherence to recommended visit, and it has been conducted in the eastern province of Rwanda. The study aim, as I said, it was to explore enablers influencing pregnant women attendance and adherence to ENC visit in the eastern province of Rwanda. And we used qualitative approach, and it was qualitative descriptive, where this study involved 22 pregnant women attending ENC in 4 public health centers in eastern province from 2 districts, Bugesera and Rwamagana. Those districts were selected based on the report of DHS, where we found that eastern province were less than other provinces. And the purposive sampling technique was used to recruit 22 pregnant women presenting at ENC on those facilities of semi-urban and rural health centers. And the eligible candidates were selected from facility record, and we included pregnant women aged 18 years or older attending the initial ENC appointment. And those potential participants were contacted through healthcare providers and community health workers. It goes. Okay, it is coming back. From methodology, as I was saying, we conducted individual interview, using semi-structured interview with open-ended questions. We gathered information from moderators of these ENC attendance and adherence among pregnant women, and the interviews were conducted in private places where the respondent could be comfortable and share freely their information. And findings were analyzed by thematic approaches using socio-ecological model. And thematic analysis was conducted, including the following steps. We started by familiarizing with the data. We generated initial codes. We searched for themes. We reviewed them as a team. And after we defined them and named them for the final themes after we reported. And the final list of themes were categorized through this socio-ecological model. And this socio-ecological model show how multi-levels of enablers were influencing these pregnant women to attend or adhere to ENC. We sought ethical approval from ERB, CMHS, and also ethical approval from site where we conducted this study. We also sought permission from pregnant women, oral and written informed consent, and anonymity, privacy, and confidentiality were observed through this data collection. As research findings, we found a theme categorized under socio-ecological model where we found 5 levels. We found interpersonal or individual enablers, interpersonal enablers, community enablers, institutional enablers, and policy enablers. Under intrapersonal or individual, we found there are some sub-themes. We found 2, early recognition of pregnancy, where we found some women, when they recognize they are pregnant early, they can attend to ENC at health facility. But also we found women's financial stability and involvement in decision making. We have found it even in those sketches they were praying. Some women were reporting that if they have right to the home finance or the means they have at home, they can buy what they want. Even they can help them to attend ENC. This study was conducted parallel with the barriers hinders these women to attend ENC, where some women were saying that some husbands don't give money and they prioritize beers and other things instead of giving the permission to use the money at home. And they fail to attend ENC because of that money. Another one was interpersonal enablers, where we found the sub-theme as spousal support. Women were saying when they go accompanied with their husband to the health center, they said it helped them, and sometimes they remind their wife for subsequent visit. And even the recommendation given by healthcare providers helped them to put them into action because they are supported by their husband. Another one was community health worker support under community enablers and community relationship. Some women responded that when community health workers are in their village supporting them, it helps them to go early to the health facility and even continue to go for subsequent visit or subsequent contact. And also when the neighbors support each other, they can know someone or some pregnant women in the community, and they tell to the community health worker that this woman is pregnant, can help them or her to attend the ENC. Another one was institutional enablers. They said that at health facility, they give health education. And when they receive those health education, it encourages them to go back to attend ENC for those recommended visits. And also they said when they have fixed schedule of ENC, it enables them to attend a subsequent visit or subsequent contact with those healthcare providers. And when they find available healthcare providers and competent, there are some quotes saying that sometimes they arrive at the health facility and they don't find healthcare providers, or they are busy with other work in different services, and they wait for long. But when they find these healthcare providers available for them to give services, it enables them to come back for next visit. And also we found about enablers at policy level, where women, they said, they used to attend ENC without paying much, even that ticket modulateur of mutuelle. But these days, because of those issue of money, sometimes they fail to find those 200 of buying ENC card. They, at policy level, they suggested, there are no quotes here, but they suggested if they can have advocacy from policy level to attend or to prioritize the attendance of women who are pregnant rather than the whole family, because they said if you were like 2 or 3 at home, you have to have mutual of 3, community-based insurance with the 3 people at home. They suggested also about mass media communication. As you have seen, they like to hear radio, Runana, and other mass media, and it encouraged them to attend ENC. And they suggested that community level outreach, if they can have midwives or nurses to go to community to engage not only with the community health workers. The study has strengths and limitations. The strength is what we explored. They were from women's voice, and also we explored various enablers at multiple levels, as we have seen from 5 levels of SEM. And also as limitation, it was cross-sectional study which has their limit, and also we can't say it can be representative for other population as it was in Eastern Province. What we can say as conclusion, enablers at multiple levels affect women's attendance and adherence to ENC visit, and it is essential to consider each level when implementing effective strategies. Yeah, what I can say as a further research, it is needed to explore also spouse perspective and healthcare providers on these enablers on women adherence and attendance to ENC. Thank you very much. These are references.
A bit louder, please. Let's give her another round of applause. Thank you so much. Let's have one question in the audience, please. One question. Does anyone have a question? Okay, let's move on to the next speaker. Thank you so much. Let's give her a round of applause as she sits down. So next up is our 9th oral abstract presenter, Dr. Jean-Pierre Dayisenga. Where are you? May you please come and present? Thank you. He'll be presenting on Silent Struggles, a multidimensional exploration of adolescent pregnancy in the Rwandan context. Let's give him a round of applause.
Thank you for welcoming me for this presentation. And I would like to request the technical team to start with my slide. And good afternoon for everyone. My name is Jean-Pierre. I'm from the University of Toronto in the School of Public Health. I'm going to share my research findings, which was part of my doctoral work 2 years ago, and it's all about women's health. And I'm happy that today everyone here is talking about transforming women's health in the Rwandan context and promoting equity and sustainability. And this cannot be achieved, stay on the first slide please, and this cannot be achieved without acknowledging how young women are passing through various types of struggle, including these adolescents and hey, technical team, please stay on the first slide, please. The first slide, thank you. We cannot achieve this goal without necessarily acknowledging how many young women are passing through silent struggle, especially resulting from unintended pregnancy. That's why today we're gonna discuss, those who are on technical, please, can you stay on the first slide? Yeah, I was saying we cannot achieve this goal without acknowledging how these young adolescent people are passing through struggle, and then we are going to discuss on this multidimensional aspect of adolescent pregnancy in the Rwandan context. With the background, as we all know in our community and in our village, we all know some of our neighbors who has young adolescents who become pregnant unintentionally. And also it's recognized that adolescent pregnancy in all contexts, it's a public concern, which is mainly increasing in low middle income country compared to high income country. And it's counting 11% of global birth, which is translated into 95% of birth occurring into low middle income country. And we have noted that the government of Rwanda, in collaboration with stakeholders, they are doing a great job of improving the maternal and the well-being of our generation. However, the problem is that we still have various complex barriers that are affecting the intervention. So the purpose for our research study then was to explore and to determine and understand the culture and personal meaning of unintended adolescent pregnancy in Rwandan context, and also examine the perceived consequence and the management of these unintended pregnancy in this population group. Because various interventions or research were conducted. However, some of them, few of them or none of them were able to consider culture and socio-economic context that is affected or shaping the complexity nature of adolescent pregnancy in our context. This research was guided by 4 research studies. However, today we are going to discuss only 2 research questions. And those questions are, the first one, what was the meaning and perspective and experience do Rwandan adolescents or Rwandan community bring to the issue of adolescent pregnancy? And the second one was, what were the contextual factors that are shaping the meaning of adolescent pregnancy in Rwandan context? And this was a critical ethnographic study that involved a total of 74 participants who participated in the 8 focused group discussions. 7 of them were homogeneous focused discussion, while the last one was heterogeneous that involved basic education educators, staff from any non-governmental organization, and those who are in political leader at the community level. And among our participants also, we involved adolescent mother who experienced unintended pregnancy. We involved also parent of adolescent mother, both father or mother who experienced unintended pregnancy. Also, we had a focus group of adolescent boys and adolescent girls who have not experienced, but who knows their relatives or their peer who experienced the issue. And also, we have a focused group with nurses and midwives who are providing sexual reproductive services, as well as antenatal in case those adolescent girls become pregnant and go to antenatal service. And also we have a focused group of men of varying age, starting from 25 years, because some of them have, as we have seen in the sketch they prayed today, and those who prayed the sketch with us, we have seen how some of them are impregnated by older men who are older than them. So we had the focused group with them as well. And we had a focused group discussion with Rogi as leader, because it's a social and socio-economic, but also religious implication is there as well. Moving to the data collection, this study was conducted in Eastern Province, and we used the semi-structured and deep focused group discussion, and also we had hypothetical vignette that helped to involve these participants to stimulate them sharing the experience, and we follow the thematic analysis. And we have seen that following our thematic analysis, we have seen that the culturally rooted meaning of unintended adolescent pregnancy can be captured through three main themes. The first one is shameful phenomena in our Rwandan society. And when we look at the factors that are interconnected to this issue, we realize that most of the time they say urubyiruko rw'ubu or foreigner youth as a way of blaming a young adolescent girl as deviant people who are not respecting community or family boundaries or norms, that sometimes when they become pregnant, instead of being supported, they become blamed. In other contexts, we realize that another big factor is the double vulnerability that these young girls experience. The double vulnerability in this way that being raised in an unhealthy environment sometimes where they experience the violence, and also the poverty-related stress as another ways of vulnerability, and also the vulnerability that comes after becoming pregnant, where some of these young mothers are chased out of their family, others are mistreated, others are even chased out of they drop school, others they don't access the advantage in the community, or others may even be hesitating to seek for reproductive or antenatal care service because adolescent pregnancy itself is defined as a shameful phenomena which is not welcomed. And it's a shame experienced by the adolescent mother, but also it's interpersonal shame to the family of the adolescent mother, and it's a shame also enacted to the sexual partner, and that affects how this adolescent mother is going to be treated and managed in their community. So because of the time, looking at the implication and discussion, we find that the best way to address the issue and the complex nature of adolescent pregnancy is to acknowledge how this issue is linked to the social determinant of health of these young people, which is not achieved, especially when it comes to the vulnerability to the poverty. We have seen the Maribori, how she was vulnerable because of her family, socio-economic situation, and that exposed to the unintended pregnancy that resulted to unsafe abortion. So we realized that the best way then to address this complex nature is to start with looking at the root cause, which is the poverty mainly, and this being raised in an unhealthy environment that expose them to the vulnerability. So that's where the focus should be. And we need also to see if the social determinant of health can be improved in a way that this can be achieved by, of course, engaging in multi-sectoral collaboration of those who are working in the healthcare sector, but also in the other aspect of our social determinant of health, from the community level up to the top level, but also making sure that the existing policy and the laws are also concerning the eradication of any type of violence. Though a young girl may be raised in a vulnerable family, but those who are employing them, they should also know that if we expose them to like the way Maribori was exposed, it's violating their rights. So knowing that adolescent pregnancy is a complex situation, we should also know that those who become pregnant unintentionally should be granted for all kind of support, including social, economic support, and also accompanying the family and the community member to know how they can support them. So that's the conclusion. We realize that all effort to prevent unintended adolescent pregnancy in Rwanda should consider a broad social norms and cultural values that frequently shape the perception as a phenomenon which is shameful. And also we have to stop blaming those who become pregnant unintentionally as deviant or as a foreigner youth. And we need also to address poverty and vulnerability from the family level. And we need to respond to the complex nature by incorporating the government and non-governmental collaboration. Thank you so much.
Thank you so much, Dr. Jean-Pierre. Is there any question in the audience? Let's have one. Great.
Okay, thank you very much for the insightful presentation. I do have one question and probably one comment. So, as I have seen, it's a big qualitative study. You have 74 participants, out of which you had 12 adolescent mothers. So my concern is, why did you consider only focused group discussion? Because you have the key informants, which are the victims of adolescent pregnancy, and 12 participants is a bigger one. So why didn't consider in-depth interview in addition to the focused group discussion? Because you could have captured.
Please, can you clarify for the question?
Okay, you have 74 participants, and you have around 8 focused group discussions. Yeah. So instead of doing that one, why you didn't consider key or in-depth interview? Because you have the key informants. I have seen that you have 12 mothers who are already mothers as adolescents. So why didn't you consider in-depth interview? Because you could have captured like a single statement that can reflect the impact of the socio-cultural context in having that adolescent pregnancy or how it can be managed, one. And the other one is in your focused group discussion. I think it would have been better if you could have involved some of the partners or the organizations that shape or that really understand the burden of the problem. For example, people from the Ministry of Health. I think you have involved not only NGOs, but people from RSOG itself, because these are the organizations that can, it's not just about palpating the problem, but at the end of the day, it's about how can we address this problem. So I believe you could have captured some important information if these key stakeholders from Ministry of Health and RSOG was involved, at least in the focused group discussion as one group. Thank you very much.
Yeah, thank you so much for nice questions. Starting from the first one, we decided to have this category of focused group instead of individual interview because we need to capture a multidimensional perspective around the issue that we capture, which helped us to capture culture and socio-economic situation. And we realized that having individual interview would be another aspect for consideration. And during our data collection, specifically, adolescent mother who experienced unintended pregnancy had the right to choose to participate into a focused group discussion versus an individual interview. And interestingly, they were comfortable to participate in a focused group as adolescent mother who experienced the phenomena. But also looking at the other focused group helped us to capture a multidimensional perspective. And going back also to your second question, to if we would include other key informants, of course our interest was to get a multidimensional perspective And though we cannot include everyone, but knowing that we have nurses and midwives who are working at the community level, we believe that they are the first people these adolescents go to into their service when they become pregnant unintentionally. And that also gave us the reality of what is happening at the community level or at primary healthcare settings. And of course, we know these nurses and midwives, they are the implementers of Ministry of Health policies or protocols, which also helped us to know the reality of what is happening at the community level. And our finding, of course, as some of them are published currently, they are the good reference for the Ministry of Health and other policymakers while trying to address this complex. And I think, again, to your question, it can be part of our next phase because I have the continuity of this research project as part of my postdoctoral fellowship, and we are looking at sexual health care disparity in the rural area, especially in the side country, among adolescents and young adults. Thank you so much for raising this. Will be considered as well.
Great, thank you so much. You may take a seat.
Thank you.
Thank you. So let's give him another round of applause as he takes a seat. That was great. So next, just before we have closing remarks, this is the end of the day, we would like to introduce Dennis from the Bank of Kigali. He'll be speaking on, financially being influenced in women's health, financially influencing women's health. Let's welcome him up.
Good afternoon, everyone. My name is Dennis, and I'm the branch manager at Kigali Heights in Bank of Kigali. So in the theme today, transforming women's health in Rwanda, promoting equity and sustainability. As in Bank of Kigali, we believe in transforming lives. So I want to showcase some of the products that can boost women in doing businesses and start up their own business. So I would like to skip to the, we have different types of products, accounts, cards, but I would like to go immediately to loans so that we take a few minutes. Can you skip to personal loans, please? Okay, so we have different types of loans. We have what we call BK Quick Loans. These are type of loans that you can access on your phone without doing any paperwork. And you get them just in 2 minutes. The maximum is 500,000. And as I said, just in 2 minutes with your phone, you can access the loan and it's already in your account. I'd like to skip again to the personal loan products. So we have secured and unsecured loans. I'd like to start with the unsecured loans. Or let me start with the secured loans. Okay. So with this, so can you stay to the unsecured loans, please? Unsecured. Okay. Okay, unsecured loans, these are type of loans that you request in regards to your salary, and we give a maximum up to 50 million. And the only paperwork we request is your work contract and to fill the bank forms. So this one, you can access it just within 3 days maximum. And the only thing that you give as a collateral is your salary. And the interest rates are low in regards to the market. Yeah. Skip to the next one. Secured personal loan. So we have secured personal loans, which we give up to a span of 84 months, and we give a maximum of 80 million. So you can give any collateral, which can be landed, a house, or a land, and then we give you up to 80 million, and I think this is a good amount that people can start with it in businesses. I'll share my number for whoever is interested. We can always have a call, and I can guide them on how to access this type of loans. Can you go to the next one? So I'm also coming to the mortgage loans. We have what we call mortgage loans that we give in a span of 240 months. This is 20 years maximum. It's accessible to everyone. And for the first house, we request no equity contribution, which means we can fund you up to 100%, and we don't request for the equity contribution. As you know, banks normally request for 20 to 30% contribution, but with your BOQ, we can fund you, and you can build your house without putting any money into it, and then the security becomes the same property that you're building. Can you go to the next one? So here we have an interesting product, which is called home equity. Home equity is a type of product we do give to customers. You just come to the bank, you tell them, this is my home, get it as a collateral, and give me 70% of its value. Of course, we check your repayment capacity, but we don't ask you what you're going to use with that money. So you give us the collateral, and we give 70% of the total value, and I think this is also a good amount of money that whoever wants to start business with can access. Normally, the bank could give you the loan for you to buy a property, and the property becomes the collateral. But now here you have a collateral. We are giving you the equivalent of 70% of the total valuation, and then from there you can start your business. This is another product for those who have properties that can be accessible to it, and the interest rates are very favorable. So I advise you to reach out to us on this type of product, especially if people want to open up their businesses. Yeah. So for our customers, let me just talk brief in other products we have. We have different types of accounts. Can you go back to the first slide? On accounts. So we have different types of accounts. You have current accounts. These are accounts where you bank with us and you can be accessible of each and different type of loans. We have savings accounts where you put in your money and you can get interest. So our interest varies from 5 to 8%. We also have other ones which are term deposits, which can go up to 11%, within your savings. So we also have cards which help you to transact internationally. We have credit cards, which you give 100% of your salary. We have prepaid cards, and you have debit cards. So these are other products that help frequent travelers, which I hope most of you are. So to be brief, that was my presentation. It was all about how you can make savings and how you can access this type of facilities loan with us. And I'll just leave my number behind, so whoever was interested can just give me a call or a chat after this meeting, and we can discuss more about this. Thank you. Have a lovely afternoon.
Thank you so much. If you have any more questions, you can visit Bank of Kigali exhibit right here. So next up, just as we close, I'd like to introduce the RSOG president, Dr. Victor, who will be giving us closing remarks. May you clap for him, please.
I know we had the 2 days, intensive 2 days, and it's a little bit late, but the important is what has been discussed here, because it's very important as a family for Rwanda society to come up together and then we discuss for evidence-based. First of all, I'd like to thank our members who have been able to support our society and then be where we are today. You have seen what has been done. It's really a lot. And the second, I want to also to thank our guests. You have seen we had a guest from across the world. We had Figure President. We had also Professor Hani, who came from UK to support us. We had also people from Kenya, Ethiopia, who have been here to support us. And it was also important to have a student, resident, to come up to support RSOG, to run, to exchange, but also without forgetting to thank Minister of Health, RBC, because everything we are doing here, we are under the guidance of the government of Rwanda and the Minister of Health. That's why I will not provide closing remarks while we have someone from the ministry. I would like to call upon Dr. Tanaz. Dr. Tanaz is the head of Public Health Services at the Ministry of Health, Clinical Services. Will be here to give us closing remarks. And I would like to remind our members, we have today General Assembly. After lunch, we'll be meeting here also to discuss and then to enjoy our achievement. So thank you so much. And I call everybody, next year we'll be gathering again to exchange and then learn from each other. Thank you so much.
Thank you, Dr. Victor. The RSOG President, dear partners, dear colleagues, specialists who are in the room, different people from different corners of the continent and the globe. As Minister of Health, I would, like to first appreciate and express my appreciation to Rwanda Society of Obstetrician and Gynecologists for convening us, for convening this conference for the last 2 days. It's an opportunity for not only for us, but also other colleagues on the continent to, exchange a lot of learnings we've had in different clinical practice. But this is a very good opportunity for us to, interrogate what is happening and be able to change the practice. The guidelines are not going to change without knowing what is happening in different clinics across the country. And I'm happy that you've been able to bring everyone together in the room and exchange. We've seen quite interesting topics. I was very happy to see that some of the topics would say that, I'm not going to say that they are neglected, but maybe the importance we need to give it to them has not been really highly mentioned. We are having the population aging, but what have we done as a country to make sure that these women who are, going beyond 50 or 45, what are we giving them? So I'm happy that RSOG is already working on that. We hope that probably in the next treatment guidelines, we are going to see how this is included. Every doctor was treating his own way, but I hope that in the next treatment guidelines, we will be able to integrate some of the learnings that you've been presenting. So again, this is an opportunity also for collaboration. This conference has been possible because of the collaboration with RSOG and different partners, and we are happy that there are different partnerships that have been forged out of this conference, and we encourage not only RSOG but also other societies who were represented here to take example of RSOG and be able to guide the practice. We want the practice to be guided by clinicians, and when you come together to give us all this evidence, that's what we base on to make changes that reflects patient demand. Part of the collaboration we've already forged with Rwanda Society of Obstetrician and Gynecologists, we've been able to work on the workforce development, especially expanding the number of gynecologists and obstetricians that we have. But we also went beyond to organize trainings for general practitioners to conduct ultrasounds, obstetric ultrasounds. RSOG is helping us to organize mentorships and supervision in different health facilities. Whenever we have cases of maternal mortality taking place in health facilities, RSOG has been there to give us the specialists who can go there and help us assess. And together we developed solutions that are tailored to the issues that have been identified. So I also wanted to express gratitude for what you've already done and what we've achieved together. This goes with health system strengthening interventions, whether buying medical equipment, whether organizing different capacity buildings across different healthcare providers. So it's a milestone that we need to celebrate. When you see the presentation that have been given here, yes, they are very encouraging, but we still have rooms for additional topics that are, there are a lot of opportunities that are not yet tapped into. And I would be happy to see more research taking place. And this is why I'm calling that for every gynecologist and every other provider in the room, research is not really for everyone. There's a time we felt that research is, there are some groups of people who are only allowed to do research, others are not allowed, but even one single case can be a research piece. So I'm calling everyone to really make it a priority. Most of the hospitals that you are currently working in, they have research units, but we want to be intentional and start tracking, how many publications are coming out of hospitals. It makes me very sad when I see someone coming from outside your setting. He brings an interesting topic, conduct the research, he owns everything, because when he comes, for us, we are interested in learning, but you wonder what is missing from our clinicians to be able to conduct this research and be the ones, owning these publications. So you've been, receiving patients from day one up to 5, 10 years, and nothing has come out of, all these patients you've received. Someone comes out, one day he publishes everything you've done for the last 10, 20 years. So maybe RSOG, you also have another lot to motivate them. Is it a skill gap that we have? I'm sure that one can be addressed. So it's a call to everyone, not only RSOG, but also even other colleagues. We still have a lot of opportunities to work together. We still have high maternal mortality. Yes, we are celebrating that we've achieved 105 per 100,000, but we can still go lower than 70, which is the global target. Why not 0? I think 2 days ago, when we were meeting I think the president of FIGO was telling us that they have the lowest, maternal mortality. An entire country, passes an entire year with only 1 or 2 maternal deaths. You're like, wow, what else can you do to bring these numbers down? So we have a room to improve, and I'm happy that everyone is contributing. And I would like to end up here my closing remarks, appreciating your collaboration with Ministry of Health and giving you assurance of the Ministry of Health that we are here to support you, not only RSOG, but also any other professional organization to, want you to take lead in your fields, and we just want to be there to support. So we are here to support you. Whenever you need our support, do not hesitate to come to the Ministry of Health for any assistance. So I want to wish you a fruitful General Assembly, and we hope that as you have this General Assembly, we would be happy to see, more actions coming out of that. One of the biggest tasks we have is really reducing maternal mortality, and we cannot reduce it without the role of obstetrician and gynecologist. So I hope that part of the agenda, you also have a discussion on that, what can be your role, not only at your hospital, but also how you are going to even support the lower facilities, health centers, health posts, so that we can, arrive to this level where you can record only maybe 1 or 2 women who are dying instead of having hundreds. So we are counting on your support. Thank you so much.
Okay, that's the end of the day. Let's give ourselves and everyone a round of applause. Thank you to every speaker, every participant, every guest. We thank you all for participating. I'm sure they've said everything. I don't need to speak after them. So we thank you all once again. We haven't had lunch, so there's still lunch to take. So you guys can go outside and have lunch. And remember, there's some exhibitors outside, so you may ask them questions and just visit our booth as well. Thank you. Another round of applause for yourself. Thank you.
Bank of Kigali has a promise to improve healthcare in Rwanda, not in the future, but today. We are empowering clinics, hospitals, and healthcare providers with the best medical equipment they need to offer the best care possible. Walking into a clinic and seeing the latest medical technology kind of gives you hope for feeling better soon. Our flexible financing solution is designed to help healthcare providers acquire the best equipment without the heavy financial burden. We are offering up to 80% for the equipment value with a comfortable repayment period of up to 60 months. The best part? The equipment itself secures the financing. If you're a licensed healthcare provider with a clean record and at least 3 years of working experience, you're already halfway there. And it's not just about the equipment, it's about the difference it makes. It's about every patient who gets better care, every doctor who can diagnose more accurately, and every clinic that can operate more efficiently. Bank of Kigali is here to make sure healthcare providers have what they need when they need it. We're here to make healthcare in Rwanda the best it can be. Feel good about the future, feel good about better healthcare, feel good now with Bank of Kigali. Nanje Nibeka. Bank of Kigali has a promise to improve healthcare in Rwanda, not in the future, but today. We are empowering clinics, hospitals, and healthcare providers with the best medical equipment they need to offer the best care possible. Walking into a clinic and seeing the latest medical technology kind of